is really spot on. We have hit the mark. We are at the moment that we need to be talking about the things we're going to talk about. So I want to thank very much the Centers of Excellence and the leaders of the fellowships who have put this project together, this conference together. And I'm going to turn over to Allison Swigert from Penn State to tell us a little bit more about today.
Thank you, Ken. Good morning, everyone. Welcome to those who are here in person. Really nice to see faces and meet a lot of people for the first time. And welcome also to those who are attending virtually as well. I'm just gonna give a second to get our slides up here. So when we started talking about putting this conference together, as Ken was saying, was really in the wake of a number of things happening, dealing with the COVID-19 pandemic over the last few years, as well as the related social, political, and economic forces that came out of it, which really exacerbated a mental health crisis that was already brewing. And we started putting this together shortly after President Biden gave his speech and really declared that we were in a mental health crisis. So we're here today to try to figure out how best to address that, both in the state of Pennsylvania and more widely across the region. Next slide, Deb. I want to just take a moment to thank our sponsors today. At the gold level of sponsorship, Community Care Behavioral Health Organization, and also at the gold level of sponsorship, Highmark Whole Care, who've both helped to contribute to our AV costs today. And then at the silver level of sponsorship, Recovery Insight. So we really appreciate their contributions to making this conference happen today. So our learning objectives today, I won't go through them all, but we are hoping to have you walk away with some solutions and some practical strategies to help address the challenges that we face in our mental health care delivery system. Next slide. So, oh, I think you meant, yep, there we go. Okay, so just to give you a brief outline of the day, our morning sessions, we will roll into our keynote address by Ben Miller, outlining the national mental health crisis next. And then we'll start to try to talk about different solutions. So we will have two panel discussions this morning. The first on addressing the current mental health workforce crisis, and the second on addressing access to care. We will have a break, but also kind of a working lunch today, honoring Dave Dinich, who helped found the PPLC and was sort of an administrator extraordinaire of the PPLC, who has recently retired. And also a presentation on addressing mental health challenges at the state level. And then in the afternoon, we will move on to discussing some practical tools and solutions for helping address the challenges that we face by discussing value management, how to reduce inequities or disparities, workforce development innovations, and how to help create and support healthy communities. I want to take a moment to thank and acknowledge all the people who helped make this conference possible today. So the planning committee co-chairs, Julia Macedo, Wes Sowers, myself, and numerous planning committee members who've we've all contributed quite a lot of hours, early mornings on Fridays to make this happen. So Marianne Alba, Rachel Talley, Ken Thompson, Deb Shoemaker, Lloyd Wirtz, Val Ferry, Elizabeth Kunkel, and Lauren Ross. Thank you all so much for your time, your ideas, your contributions to making this happen. And then a very special to those working behind the scenes to get everything rolling. Dave Dinich, who helped conceive of the idea and then announced his retirement, but helped shape the idea for the conference. Lucianne Green and Mary Hirsch, who are outside, who have done a lot of the legwork to get everything to happen for today. So with that, I will finish up, and I'm going to turn it back over to Ken to introduce our keynote speaker.
So we're running actually a little ahead of schedule here. So I'm going to just make one additional announcement that I forgot to mention. And that is, if you would like to Twitter this out to folks, we have a hashtag in times of time. Is it in times of crisis or in time of crisis? In times of crisis with the S in the times. Okay. So in times of crisis, those of you who are Twitter, I can see all of you reaching for your phones to do the Twitter. Come on, some of you know how to do this. And any of you who's out there in the Ethereum there, if you would like to start Twittering, we'd love to see your Twitters. I'm appreciative of Allison reminding me that we actually did start this conversation not too long after President Biden came out and proposed a series of legislative actions to address the mental health crisis in the United States. And I'm going to just say a couple words about it. The mental health crisis, I already indicated, was really going on before COVID, and COVID has just accelerated it, particularly in the area of the workforce, particularly in the area of disconnecting people, and just generally causing an extraordinary amount of additional stress. We also have obviously very serious political challenges. I didn't get through it last night before I fell asleep, but there's a 5-page piece in the New York Times about how we are in an unprecedented political crisis, and that we are all looking to what will happen in November to see how the nation's going to turn and where things are going to go. That will obviously have a huge impact on much that we can do in the public service as the nature of government goes one way or the other. And I've been recently thinking that maybe we are kind of victims of our own tendency to downplay mental health. You know, there's a real concerns about parity in mental health, and the notion that we do not put enough resources into addressing mental health because of the stigma associated with it. What started me thinking about this was about 2 weeks ago, there was an announcement that the monkeypox was a public health emergency, was constituting a public health emergency for the United States. And I thought about that in relationship to the language that we use for the mental health crisis. And I guess I began to think maybe we are downplaying what we are experiencing. We've seen in the last year a 20% rise in the number of people dying from ODs. We've seen a similar thing with number of people dying from alcohol. We know that there are large numbers of people who are reporting suicidal ideation, and we're seeing large numbers of people, much larger than before COVID, reporting that they are anxious, stressed, depressed, and that this goes on, and you can see it in the waiting list in clinics all across the country. So there's something going on in the communities that we live in, among the people who live there, in terms of the psychiatric stress and challenges that they're facing. And I think that maybe we're kind of lowballing it if we call it just call it a crisis. I actually think we're in a mental health emergency. And to talk about that, I couldn't think of a better person to recommend to the group than Ben Miller. Ben Miller is a psychologist. He is the former president of the Wellbeing Trust. He has a long history. I've known Ben for probably close to 15 years, maybe a little bit longer. He was very much an advocate for the integration of behavioral health and primary medical care. And I got to know him when I was working at SAMHSA. And since that time, he's gone on to become a national figure and an advocate for mental health. He writes I don't know if it's weekly, Ben, but it's a very frequent blog on the issue of how we think about mental health and policy. And the opportunity to have him speak to us about the crisis or the emergency that we are facing, I think is an extraordinary chance for us to hear what's going on across the nation, reflect on how it's showing up in Pennsylvania. And I'm going to turn it over to Ben because he's looming over my right shoulder and he's really big. And I would not want to confront you in any way.
I'm so sorry for the largeness of my head here. Ken, it's good to see you, and I'm sorry I can't be there in person. My deepest thanks to you and the planning committee for the chance to come on and share a bit today about our current crisis and where we need to go as a community. And just before we get started, Ken, you and I need to have a conversation about your social media vernacular because you tweet, you don't Twitter. You know, so we'll get to that later.
What did I do? Did I Twitter?
Your language is a little off. We'll get you there, my friend. We'll get you there. So
thanks for the correction, Ben.
Of course, of course. As Ken said, I come at this work honestly, and like many of you, I've spent several decades standing on stages trying to convince people that mental health was something that we should be prioritizing. I have stories and stories and stories of being told that mental health wasn't a problem. It wasn't a problem in my community because it just wasn't. I remember getting phone calls when I started in Colorado of clinicians in the community saying, you know, you guys are trying to bring mental health into my practice, but I want to go ahead and tell you, we don't need it because our people are okay. Well, my friends, like many of you, I don't think that we now were prepared back then for how bad things were getting right in front of us, but I'm getting a bit ahead of myself. I want to spend my time today on two things. One, I want to lay out the case for our crisis and for some of the fissures that it's exposed. And two, arguably more important, is what we can do about it. The massive structural changes that we need to consider. So I'm going to do this awkward thing since I am virtual of saying next slide, but I think it'll probably get used to it here in just a second. So next slide, please. I have an 8-year-old who played soccer all day yesterday, and it's part of the reason why, if you could see me in person, I have too much redness on my face because we were outside. But we've been studying a lot about history. And one of the things that she and I have been reading about was Mount Vesuvius. And so let me tell you a brief story about that. August 24th, 79 AD, Mount Vesuvius erupted in southern Italy, and it killed countless people, devastated cities like Pompeii. Pompeii was a really fertile city with extremely rich soil where vineyards thrived. And little did the people who lived there know, but Mount Vesuvius had erupted previously, likely being the reason that the soil was so rich. The eruption in 79 led to this 10-mile mushroom cloud of ash and pumice that really was in the air for almost 12 hours, and it rained down on the city. Many fled, many did not. And according to some accounts, the eruption lasted for a little over 18 hours. The city was burned, and there was 14 to 17 feet of ash and pumice. And even today, Mount Vesuvius Thank you. Sorry about that. You either didn't like the story or that was an accident, so I'll keep going. But Mount Vesuvius remains the only active volcano on the European mainland with its last eruption in 1944. Next slide, please. So why do I start here? Well, it's a little morbid for me to be telling you the story with my 8-year-old and how we got into it together. But I think that the relevance of something that happened 2,000 years ago is important. Despite the history and stories from this time, there were many warning signs that were present that signaled that an eruption was inevitable. For example, there had been other towns destroyed completely. Prior to the eruption, there were massive tremors. The people didn't know what this meant. They felt them, they heard them, they didn't know what it meant. They didn't have the knowledge. Closer to date, the mountain started making groaning noises and sounds, and even the sea started bubbling. The animals all left the town, literally, even the rats. I mean, look this up, read this. We were fascinated by this. And despite this strange sight, the people stayed. Wells and streams dried up, and they blamed other things for why this was all happening. They looked to other signs and said, well, it's because of the weather, or it's just, what's going on today, it won't be there tomorrow. The signs were on the wall and the signs were ignored. Next slide, please. Well, my friends, we have a real life Mount Vesuvius in front of us right now. Alongside partners that we worked with at Trust for America's Health, for the past 5 years, we've been looking at the mortality data from 2 decades. And it's a disturbing sight as we can see the trends over time to the place where we are now. 1 person every 3 minutes dies from drug, alcohol, and suicide in this country. The most recent report that we did analyzed data compiled from 2020, so the first year of the pandemic, and it confirmed what many of us know and witnessed firsthand. 2020 was a tough year for millions of Americans. It was the first year of COVID and the first year many of us had been asked to stay at home. Over the course of 2020, as the COVID pandemic initially tore through the world and upended virtually every aspect of daily life, the US saw the highest number of these deaths on despair on record, with nearly 180,000 men, women, and children losing their lives. There's a few really important points to make here. The death rates increased in 49 out of 50 states, with the notable exception of New Hampshire. Every state in the country, plus DC, recorded a higher number of deaths due to alcohol, drugs, and suicide in 2020 than 2019. It was also the first year that we saw that any state's mortality rate rose above 100 deaths per 100,000 residents, yet it happened in 2 states, West Virginia and New Mexico. And so in part to cope with the pandemic-fueled feelings of anxiety, isolation, and grief, and in large part due to the long-standing unaddressed mental health and addiction crisis in this nation, people turned to alcohol and drug use in record numbers. We saw alcohol-induced death rates increase by 27%, drug-induced death rates, which was driven in large part by a spike to synthetic opioids like fentanyl, jumped 30% compared to 2019. And finally, I just want to make one other point here on the slide, and I'll come back to this with solutions, but the mental health crisis among America's youth continues to be a deadly trend. I'm a parent. I've got a high schooler who had her first homecoming this past weekend. I've got an 8-year-old. And I have to tell you, the loss of sudden structure and peer support and social skill development that comes with attending school every day. Without that sufficient access to mental health support, the resources that were in the schools, our kids' emotional health went into a tailspin. Children 17 and younger saw the highest increase in drug-induced death rates of any age group at 78%. As well as the second highest increase in suicides. Next slide, please. So this is the 5th year of me being a part of this report, the 5th year of me talking to countless media and other interested parties about the data, why they matter and what we should be doing about it. And I won't lie to you all, it gets harder each year. Why? Because I think it's hard to know that every time I report out on these data, every time I say the phrase like the most ever, as you can see here on this slide, where we again cross the threshold of losing that we as a nation still aren't doing enough, threshold of losing 100,000 lives to drug overdose. We are a nation still aren't doing enough to meet this moment. I worry that because the data and trends are so hard to comprehend, so high and so consistently in the wrong direction, that people are going to become desensitized to it. Maybe I'm wrong, but on my watch, I want to do everything I can to shine a spotlight on this massive problem, even when politicians and media pundits have forgotten about the unspeakable tragedies occurring in our nation each day. Next slide, please. So studying these trends has also taught me a lot about what doesn't work. In the substance use disorder space, we've seen the trends over the past few years, especially for opioid use disorder, that the solutions work for some, but not all, especially communities of color. We've applied this one-size-fits-all mentality as if it was actually going to make a huge impact. And so we approached much deeper issues like addiction as if it were only about one specific aspect of the substance use disorders, opioids. And yet we tried to overly simplify this very complex issue. Next slide, please. So if leaders at all levels continue their reactive approach to this rising death toll, instead of getting ahead of it by implementing policies that emphasize the things that I know you all care about, community, prevention, treatment, our collective losses will continue to grow. If, and this is a big if, we can all finally acknowledge that enough is enough, we can band together to help transform America's mental health landscape and finally begin to ease the pain that our nation has been feeling. And it begins with accepting the fact that most of our systems remain fragmented, which has so many consequences for people looking for help. Next slide, please. And no one really needs to see slides like this anymore. I've been talking about this for way too long. The data have been consistent for years. And the stories from our friends and even more, supported by people that we know when they talk about access challenges, we know that fragmentation drives so much of the problems, and integration is our solution. Next slide, please. I've sat in front of this camera and watched as people have told me of their challenges of getting help. And somewhere along the way in our quest to solve this mighty problem, we thought that more money was simply the best solution. Sure, don't get me wrong. More money is useful in a lot of ways, but more money into the same structures only gets us the same outcomes we were getting before, which is, I think we can all attest, isn't ideal. We can do so much better. Next slide, please. I remain fascinated by our fixation to keep trying the same things, hoping it will get us to a different outcome. One of the most common misperceptions about healthcare is that there's a system. And while we use those words because there's not really better words to use, there was a wonderful article that came out in JAMA a few years back where the authors described how the US healthcare system, it's not a system because it's neither coordinated by a central entity nor governed by individuals and institutions that interact in predictable ways. While there are a great deal of assumptions that go into solutions for problems with mental health, central among them is a recognition that an actual system exists that's capable of morphing in response to these recommended challenges that we're going to face. Next slide, please. And COVID has really given us this unprecedented moment to reassess, to examine the cracks in the system, the massive problems we were facing before that were only made worse by a global pandemic. Ken said this well. A lot of the things that we're seeing now, we knew were a problem before. They've only been made worse. Next slide, please. And so I want to really put this into context and highlight how COVID has given us an unprecedented moment to really think through what we can do, but also more importantly, my friends, to examine what wasn't working. Next slide, please. Our friends at Kaiser Family Foundation have been doing some excellent work over the past 2 years, and we've seen how COVID has significantly impacted our mental health. And again, to highlight, it wasn't great to begin with, but it definitely got much worse. And I don't know what's going on with the slides and the missing rest of the line there, but you can see pretty much consistently, we have had negative reports of negative impact on our mental health. Next slide, please. So at the beginning of COVID, partners and I wanted to project out how many more lives might we lose to drug, alcohol, and suicide because of the virus. Because of things like lack of social connection, isolation, economic decline, unemployment, and more. We look back to 2008 and the Great Recession, and we based our projections on several different scenarios. We basically posited that there's going to be an increase of deaths of despair on top of already expected increases. Next slide, please. And I don't think I was prepared for the amount of media attention that we received for this report. I used it as a moment for every chance I could to highlight the massive problem that was here before COVID and use those platforms to call for more robust and comprehensive solutions. Just a small aside, his personal favorite story during this time. When I found out that I was going to do a live shot on CNN, I just texted my wife and I said, hey, you can turn this on and let's see if the kids can watch me. And my 6-year-old at the time, she could not get past the fact that her dad was talking to a man whose name was actually Wolf. And she still talks about that to this day. She does not understand how a mom would name somebody Wolf, but anyway, I digress. Next slide, please. So I leveraged COVID as best I could to get the attention that we needed to have our response include mental health. Before language that's emerged around syndemics and getting used to talking about the emotional toll of COVID, I simply wanted to try and paint a picture of where mental health fit into the pandemic. This article that you see here on the slide today was published in USA Today, and it hit as quickly as we could possibly get it published. I mean, look at the date. This is in April of 2020. And what's funny is I go back and read that article now, and so much of what we said early on in the pandemic remains true today, even now. Next slide, please. And when we look at our kids, we started to see how huge COVID was impacting the next generation. Children's hospitals helped lead the way here, declaring a mental health state of emergency and more. It helped shine a light and a spotlight on our kids. And I'm really glad that we did this because we all probably have stories from our own kitchen table about how hard this has been for them and still is. And I sit with that daily. I think a lot about the number of friends and families who I have encountered who have lost their children during COVID. And it's something that I take very seriously because, as I'll talk about a little bit later, this is on our watch. And what do I, as a leader, what will I do about it? Next slide, please. Oh yeah, and then there's this whole market thing and this recession, non-recession that keeps hovering over us. For an overwhelmingly majority of people, their ability to live, to provide for their families, and to receive medical care is inextricably linked to things like their employment and their finances. So imagine the stress of losing all of that in one fell swoop and suddenly having to scramble to find new work with no safety net, new retirement plans with nothing to fall back on. If left unaddressed, that stress can sometimes grow and manifest in very destructive ways. Yet many who would benefit from things like counseling or therapy will delay seeking help in an effort to keep their bills paid and their fridges stocked. These are real issues that I think you all have probably seen with the patients that have showed up in front of you. Next slide, please. So this is what I like to call a crisisopportunity. It's a crisis that opens the door for major opportunity for reform. The COVID-19 crisis has given us this unique moment to examine mental health, what works and what doesn't, as I said. And we have learned that our health is impacted in ways that are not just about becoming sick with the virus. We've learned that our nation's well-being includes factors like our mental health, our physical health, and our social and economic health, making it really clear, I think, to most that all of these should be forefront and integrated in any response and recovery plan if we hope to avoid going back to the way that we were before, which, as I've outlined, I don't think it was working for a lot of people. So I want to take the rest of my time and I want to shift from our problems and the context of these problems to our solution. And yeah, you'll hear me talk still a little bit about some of the problems as I go through the solutions, but I want to lift up 5 things that I think we can consider to truly advance mental health. I know you're only supposed to use 3, but I'm using 5. All right, here we go. Next slide. First, I think we as a field have got to take more risk. For mental health, we have inherited these imperfect systems and structures that at one time was someone's best idea. There's no finger pointing here and no names to call out or to blame. What we have in this moment is what we must work with. It does, however, force us to take a look back and understand a bit more about the historical context in which why decisions were made. When we do this, I think sometimes, and just sometimes, we get some clues that can be used to inform our thinking today. The most classic example is our community mental health centers. Started as a solution to individuals with mental illness languishing in institutions, it never really received the attention, funding, or support that it needed to be successful. And what I think we should be focusing on now is how that system and those structures are still with us today, still underfunded, still basically the same. Not much risk has been taken there. Sure, there's been a lot of subtle attempts and shifts in how these centers operate and where the funding comes from and how they receive it. But for all intents and purposes, it's the same structure. We haven't really broken ourselves from this clinic mentality yet, which means that most care is still predicated on a you come to me model. Next slide, please. So I want to take us away from healthcare for just a second, and I want you to think about risk in this context. Let's talk about Google. Google's a company that consistently reinvents itself. You thought all they did was provide a search engine for you to find obscure sports facts, but they do so much more than that. You all know that. From getting maps to cars that drive themselves to venture work, they've really tried to consistently reinvent who they are. And it's absolutely no secret that many courageous business leaders have taken calculated risks as a crucial component for their long-term success. Peter Drucker, who we've all probably read and loved over time, once said that whenever you have a successful business, someone once made a courageous decision. Why don't we make more courageous decisions for mental health? Try to undo decades of things that weren't working, to rethink our delivery of care. So Google as a company rewards risk-taking. In and of itself, that's pretty great. They want people to solve big problems and they reward their employees for thinking big, for being bold, for failing. They challenge employees across all their departments and functions to not only develop new ideas, but to also poke holes in existing systems and challenge the status quo. The goal is to optimize their own efficiency, and they love investing in efforts that end in failure because they just want to learn something along the way. The mental health field could learn a lot from Google. Next slide, please. So considering the magnitude of the issues, we should be considering ways we should embrace risk as a foundational tenet. As I said here, during the course of this presentation, how many people will die I mean, it's just to me unfathomable that we aren't doing more to be bold. Next slide, please. A good colleague and friend of mine, Maureen Viciano, has taught me this, and it's the bumper sticker that I carry around with me almost everywhere. But once we realize that something isn't working, it is unethical to proceed as if it is. There's a lot of things that aren't working for mental health and addiction. And I do believe that it is on us to figure out, well, how can we continue to proceed as if it is working? Next slide, please. My colleagues at Inseparable, which is a powerful mental health advocacy organization, pulled the 990s from various organizations to see how much they were spending on mental health. And you can see that here on the slide in front of you. We are vastly overspent or underspending on things like advocacy. We've got other insurers that are out there that are fine. I mean, they're doing their part, but the mental health field has not stepped up to really advocate and be bold and take risk with how we are investing some of our resources to impact on policy. So I think these are things for us to consider. And I start here as a foundational tenet, because I think that if you are not willing to be courageous and accept risk, then everything else I'm about to say to you doesn't make a lot of sense. Next slide, please. So solution 2 is all about how we show up and where. The mental health community often gets left out of this national dialogue, and I want to try and challenge us here on some things we can do. So next slide, please. Here's a few examples of places we can better show up. Now, Ken already mentioned that we can tweet. Absolutely. We need more experts out there on social media. There are so much misinformation and disinformation that comes out about the impact of mental health. We need to be out there showing them the latest article, telling them the truths and separating that from the falsehoods. We need to be showing up on television. I'm actually not a big fan of doing live television, but I have to say it's a wonderful platform to be able to talk more about how mental health is impacting all of us, and not just to be, the cliche, okay, here's the 2 things about mental health, but to really challenge people. Ken mentioned too, blogging. I mean, I started this Substack almost a year and a half ago, and I did it as another outlet to get more people to pay attention to mental health. Are you writing about this consistently? Are we going beyond some of our academic publications, which I still do, but translating that over to the general community? Another example was placing 1-page ads in papers. We were very successful with this the last year. We put 2 1-page ads, one in New York Times, one in Washington Post, one calling for more investment in mental health, one calling for attention to 988. We've got to be doing that because the public is looking for leadership. And if they don't see us, they're going to see someone else. And some of the people that they're seeing are not necessarily telling them what needs to be the vision for the future of mental health. We all need to be bringing more attention to this issue. Next slide, please. Leadership. I am absolutely convinced that leadership is one of the most fundamental issues that we don't talk about enough. Because sometimes, as I mentioned about taking risk, who is leading and their vision and how willing they are to support their teams in taking that risk, it matters a lot. Next slide, please. I have really been struck by social movement principles and leaders from our past that have taught us and given us almost a roadmap of how to use social movement principles to advance causes. And if you read about social movement principles enough, there's a few ingredients that stand out. The first is around vision and framing. You have to appeal to hearts and minds. And I've been taught over the years, if you look at other movements like marriage equality, it started out as several hundred policies that needed to be changed. Everybody wanted a particular policy. But what ultimately won people over was when the message was simplified to be about love. People understood love. They understood playing the importance of offense over defense on policy. You also need a constituency. You need to have people, starting with friends and family and community members. Eventually, a successful social movement means that clinicians and leaders at every level of society get on board as well. And you got to have a long-term commitment. You need to know that social movements are not episodic. They're all about long-term perspective and investing in building relationships and training those future leaders who can keep the work going. Next slide, please. I want to focus just for a minute. Oh, maybe not. Go back. I don't mean to go there yet. I want to focus just for a second on these issues around social movement. And I want to challenge us to think about a few things just out loud here. Have we as a field moved out of our comfort zone and become political enough to build real power? Have we as a field asked our philanthropic leaders to come together to fund robust, coordinated education and advocacy campaigns designed to win? Have we as a field done the right research with people outside of mental health to find out who moves people the most? Just this past week, I was in some focus groups in Atlanta, and we were asking people on all ends of the political spectrum what their thoughts were for mental health. And if you don't think that there's a difference in the language, if you don't think that there's a difference in the solutions and what people want, then you're mistaken. And being able to sit there and listen to all ends and come up with a formulated plan on what we can do matters greatly for us. Next slide, please. Can't see the slide deck. It looks like there's a comment there about the slide deck. I'm not sure how to help you all. We will make sure to share the deck afterwards though, and you can see the pretty pictures that I've got on there. Okay, let's talk about meeting people where meeting people where they are. And I want to use this very simple graphic on the next slide, because I think that so much of our leadership, next slide please, has to do with how we advocate for where mental health needs to be. Leading also means that we fight for what's best for our people and listening to what they want. If you guys can go to the next slide, I think you might be trying to, there we are. So this is a ridiculously simple graphic, but if you can't see it, I'll go ahead and spell it out for you. Basically, most people interact with the mental health system in a couple of different ways. Okay, they get referred there by primary care, they show up in the emergency department, and they say, hey, go to community mental health for follow-up. Very rarely though, are the entry points consistent across the spectrum here for how to get people easier access to care. And so some people might find that, hey, listen, I'm in a crisis, I need to get help today, and there is no place for them to go. I call this a cycle within the system, because when you can't get in to see a clinician, you are put back out, waiting. And then for some people, the languishing leads to, more crisis. For some people, the languishing leads to frustration and challenges facing them and their family. But we have to break this cycle. And so it seems like people are having a hard time seeing the slides. I can see the slides, but I don't, it's on Sierra's screen here. I'll let the tech people, there we go. I'll let you guys figure that out. Let's go to the next slide, please. And if you want to take my big head down from the screen and just have the slides so everybody can see them, I'm okay to do that too. Great. More importantly here, though, we've codified the separation of mind and body through policy, and we've got to recognize that we use policy as a lever to reinforce certain aspects of what we want. But what happens if those structures aren't working? We reinforce bad ideas and bad programs through policymaking, and there you go, that's great. I can see it now too. Make it very difficult to undo. So next slide, please. Let's use telehealth as one example. Next slide, please. It's been hugely successful during COVID. I mean, Ken joked about it at the top. That's so much better. Thank you, Sarah. Looks great. That some of us went from like 40%, no-show rates to 100% no-show rates. I mean, everybody's showing up. COVID has been really great for us to acknowledge this thing that's been around for seemingly decades. But telehealth also takes us back to a day where I think that we were siloed, and it was about me doing my thing and you doing yours. And we have to be careful with this, because if we just created a policy that said telehealth is meant to be the front door for everybody, then that reinforces a very dangerous siloed thinking. And I don't think that's what you all are saying, but I just want to make sure that we are aware of unintended consequences of policymaking on really good ideas that actually do make a difference. So let's not make the mistake of policy saying that this is the only way we should be starting or initiating our care. Next slide, please. All right, solution number 3. In an emergency situation, yeah, it looks like folks are still having a hard time with the slides. I don't know what to tell you guys. I'm so sorry. I wish you could see it. It's a beautiful picture of a hand holding a phone. Hopefully our tech people can work it out. I'll just keep saying next slide and you can follow along. But for most of you, and you know this from either personal experience or experience with your patients, just to be clear, Sierra, what I see is a slide, and that's what I see on my screen. I'm going to keep talking though. We're told to call 911, and some 240 million Americans do that every year. We as a society are slowly coming to understand that as mental health professionals, we've known for some time that not every emergency requires police, fire, or EMT to address it. Mental health emergencies require nuanced response that emphasizes understanding, compassion, and nonviolent de-escalation. Unfortunately, most of today's emergency responders and dispatchers, by their own admission, are not adequately trained to properly handle mental health crises, including substance misuse emergencies. Next slide, please. So enter 988, a new opportunity for reforming how we respond to crisis. Now, if I were in the room with you, I would ask a show of hands, how many of you are aware of this, or how many of you are tired of this, or whatever, because, you're either on one side of the coin here. Some people in some communities aren't as well-versed or prepared for where we need to be for 988, whereas others are very well prepared. No matter where you sit, we are long overdue to have a comprehensive federally supported system in place that can dispatch trained mental health professionals to properly address the type of crises when they arise. Launched just in this past July, mental health emergency calls are now routed to local call centers within the National Suicide Prevention Lifeline Network. We're still just a few weeks in, excuse me, and we still only have a handful of states that have reported taking legislative action to financially support 988, but we're learning a lot. And there's some positivity here that I think we should be paying attention to. Next slide, please. So I have talked a lot about 988 as the Trojan horse for mental health reform. And I believe that this is because we have an opportunity here to really think about the delivery of mental health. And there's a lot of opportunity for us to really reconsider, well, who shows up? And what are the solutions for mental health that we might want to be pursuing differently? I mean, 988's effectiveness is largely dependent on significant investment in things like pre-crisis care. Prevention isn't a bad word. Public education campaigns should provide information about warning signs to help identify crises in their earliest stages. Schools should implement mental health and drug use screening protocols and all the things that you all know. But the availability of warm lines should be expanded to help those who are struggling and avoid a full-blown crisis, as well as offer post-crisis counseling and care. So while the Trojan horse metaphor is a little strange, it's huge in what it could mean, because it puts the responsibility of who's responding to mental health crisis not just on the mental health system. It's an opportunity for all of us as a community to come together and really rethink, well, who is responsible for what? Next slide, please. So these are the big elements of 988. This is pushed out by our friends at SAMHSA, and it's really simple. You call 988 or you text or you go through chat, you get someone to call, someone to talk to, a place to go, or someone to respond and a place to go. And these matter. And I think we're going to see a variety of different approaches here as we continue to learn about 988. Next slide, please. And while prevention and things like pre-crisis care are key, we must simultaneously prepare our mental health care system for the influx of crisis calls that are sure to come our way with this new easy to remember number. Our current system of healthcare coverage must be re-examined and revised to meet the needs of those who are struggling with mental health, so we don't continue to build new structures on a decrepit foundation. And in addition, things like parity laws, which have been around for a while now, they've got to be applied so that all health plans can be readily enforced to ensure that individuals' care is covered when they do reach out for help through 988. Law enforcement still has its place in this new, more equitable mental health landscape, but its crisis response role should be secondary to that of certified mental health professionals of a new response. And this requires coordination, additional training, and hard conversations like how you connect 911 to 988. Next slide, please. So I want to kind of go through two more, and then I'm going to try and wrap up here in a few minutes and give us some time for Q&A. But I really just want to try and emphasize that, as you've seen here, I've given you three things, and we're heading on to the fourth. I've tried to work our way sequentially into bigger, bolder ideas. 988 is a platform for what I think of is more robust change. And I want to now talk a little bit about our workforce. And there's a lot of people out there now, and probably many of you, talking about how much our workforce has been under and how much pressure and stress and challenges that our frontline workforce has faced. I'm not going to talk about that so much today, though I do think it's critical. I want to broaden our discussion around workforce And I want to begin with this acknowledgement that there's this vast unmet need for mental health care and support in the US. And although expanding specialty services is needed, this is neither sufficient nor necessary to comprehensively address the current and future demand that our communities are going to have. Traditional models of care, which have focused on mental disorders, while useful for many, remain out of reach, unaffordable, and not timely for helping the vast majority of individuals in need of mental health support. We all know how often workforce gets used as a reason why we aren't progressing as a field. We don't have enough is always the question that gets asked. How can we have more? Well, I actually think that's the wrong question and the wrong problem we're trying to solve. Next slide, please. We have to get more creative about this. This slide was published in a beautiful paper by a colleague, Brandon Court at GW. This is one of my other bumper stickers in my car. What does care look like? Where is care being delivered? Who is providing that care, and how is care being provided? Next slide, please. Brief encounters based on kernels of psychological treatments delivered through supportive conversations by fellow members of one's own community are crucial components of the continuum of mental health care. And they promote the journey to mental health and well-being. Fostering these encounters reduces barriers that I've already described to accessing support, while it also contributes to the well-being of the community members engaged in actually helping one another. And ultimately, widespread implementation of models that we train up our communities to help each other can create more socially connected and flourishing communities. The literature for years has talked about this as task sharing or task shifting. Okay, but how do we take some of the knowledge that we've got and democratize that and put it into communities? Next slide, please. So there is a growing movement of community-based networks and organizations which aims to fill this need by harnessing existing community resources to promote mental health. And its goal is to prevent mental health and substance use disorders. I mean, we coined the phrase community-initiated care as it felt like the right thing to say because it's care in community by community for community. And it built on these real-world experiences and the growing science of lay people delivering brief psychosocial interventions in community settings. I think of CIC as a backbone of sorts for training lay people to support the mental health and well-being of others in their community. It's envisioned as an equitable, efficient, safe, and timely form of contextualized support to promote mental health and to prevent self-harm, mental health, and substance use problems. It's not intended to replace clinical interventions. Rather, it's meant to really be more about supportive encounters, to use a person-centered approach to bolster existing positive coping skills, to promote positive social engagement, and to reduce the risk of future mental health problems. And by doing this, absolutely, everybody gets a copy of the slides. Absolutely important here is that it allows for there to be an immediate response when a person is in a crisis or in need of help. And that can change someone's trajectory almost immediately. Next slide, please. You can see on this slide a bit of where we have started. First, we rebranded community-initiated care. We call it that in the literature, but we rebranded it to be called Strengthen Us, as we felt it was an easier way for communities to understand what we were trying to do. Second, we wanted this training to be free, easy to access, based on the evidence. This is a very straightforward strengths-focused model that doesn't take us down any rabbit holes of needing to differentiate diagnoses or do risk assessment. It's about being there in the moment for the person who needs you. Next slide, please. For more information, you can scan the QR code here or simply go to the website strength.us. I should mention that you can see a nice video of some preliminary work we did in Pittsburgh on the website. Next slide, please. So in closing, I want to offer one more consideration, and it's a doozy, but I really want you to kind of come with me on this journey here. It's one that I think we talk about a lot, but it's rarely acted on. It's one that I feel is crucial and critical considering the long-term trajectory of our work. Next slide, please. Our youth. So we know our nation's youth are in the midst of an unprecedented mental health crisis. Survey upon survey upon survey indicate that anywhere from 13 to 20% of adolescents in the US experience some form of mental health struggle with anxiety, depression, and other behavioral issues, ADHD, they're being most commonly reported. Pediatric emergency rooms have reported massive increases in visits by children in the throes of a mental health episode. And as I noted earlier, children under 17 saw the highest increase in deaths by suicide in 2020. Next slide, please. Our youth have brilliant ideas. They have solutions to wicked problems and are often just not invited to the table to share those solutions. We need to change this. A few years ago, in partnership with Academy Health, we put out some public policy recommendations for adolescent mental health. And the first recommendation of that entire report was inviting more youth to the table. Just recently, last year, we were able to create a policy advocacy toolkit with youth called Evocate. And it was their version of an advocacy agenda for policy. I really worry that if we don't run the risk, if we don't take risk of creating solutions that the next generation says they want, then we are creating something that won't get used or won't have the intended effect. There are practical ways to get youth involved. Invite them to the table, listen to their ideas, act on their ideas. Some of you probably have youth that you sit at the dinner table with every night. Ask them what solutions that they feel would be most beneficial for their friends, for their colleagues. I will tell you, some of the most rich conversations that I've had as a parent have to do with what other youth are struggling with and how my children show up. You know, this is not about tokenism or saying that you had youth at the table. It's truly about taking action. Action with the youth, for the youth. They need us. But more importantly, I think that we need them. And we need to catch them before they become too jaded and cynical like some of us are now. They have the big ideas, the ideas that will work. Next slide, please. So as I've outlined today, we are a nation in crisis, but there are ways forward. Ways that force us to re-examine our structures, to assess what's working, what's not, and to really push for a more radical and community-centric forward approach to mental health. You are the leaders for this moment. This is not on someone else's watch. This is happening. We can't blame the decisions of the past. This is on our watch. And I feel deeply that we have to be bold to take action in order to do meaningful work. I want to challenge you all today, not just to think about the legacies that you've inherited, someone else's programs or ideas, which are really easy to fall back into as we get into our discussions later today. It's really easy to point to the barriers, but I want you to really think about the legacy you want to leave behind. What does that look like? What do you want to tell your kids, your grandkids that you did to impact mental health in this moment? What is your vision for mental health? Whatever it is, I hope you pursue it, because all of us, all of our communities, we're looking to you for leadership and for guidance. And in turn, we ask that you look to us, the community, to partner and to forge solutions together, because together is the only way that we're going to find a way through this crisis. So I want to thank you for the opportunity to highlight some of what I think are ideas that we can pursue with you today. Ken mentioned this. I do write a weekly Substack. You do not need to subscribe, but I do put out information every week on the topics of mental health and policy. And I just really thank you all for all you've done to help advance mental health and all that you will do.
Thank you very much, Ben. That was a great tour de force tour of the challenges that we face and ideas about how we can move forward. So sorry about all the technical challenges, but this is the first time we've done this and we're all learning here. I wanted to open this up to some questions, and Deb's got a mic, and I think we have, do we have any way to monitor any questions that might be coming in?
Yes, Sarah has it.
You got it? Okay, terrific. So does anybody have a question for Ben? Any comments or questions about what you've heard so far this morning?
Do you have one, Ken?
We've got one over here. Dr. Niemark.
Thanks for that presentation. It was really thought-provoking and I'd say inspiring as well. Wanted to just ask you around the community-centered interventions that you mentioned, and I agree. I think they have a very important role. Could you speak about some of the places or programs that to date perhaps have been implemented and how they're going, recognizing I know that sort of a frame shift might be early in the process, but was just curious if you could talk to that a bit.
Yeah, there's nothing like being the big Wizard of Oz talking head that can't unmute yourself. So apologies for that. I awkwardly look at you all through the camera. Thank you for the question. And you're right. Unfortunately, here in the United States, we have not progressed as much as we should or could as other countries have. And so a lot of the examples that I can give you here in the States are in their very formative stages, their beginning stages. The literature that we drew on for this, and I'm sure you're familiar with this, does come from other countries, where you've been able to train folks like community health workers, promotors and the like to deliver very profound evidence-based interventions. The most common example that we've seen in the literature, and a wonderful RCT done around the friendship bench, teaching, training matriarchs in communities to address issues of depression in men. 2 years ago, when we started looking deeply into this, we asked the question that you asked me, well, who's doing this here in the US? And what we found was that you would see bits and pieces here, but no one had ever created an operational plan or infrastructure necessary to provide this at scale. So in partnership with our friends at Harvard Medical School, specifically Vikram Patel, and some of the colleagues that have been doing this work internationally, we wanted to create those opportunities here in the US. And specific to the where, because I do think this matters, the literature has got good examples of medical interventions being done in non-medical settings. And most of you are familiar with looking at cardiovascular disease, specifically in barbershops, and doing some testing there. We even did some work in rural Northeast Colorado around opioid use disorder and colorectal cancer screening, and found that there's really interesting ways that you can go to feed stores in places where people are buying ammunition and do more interventions in those locations. But I think that the key to this is finding out where people are. Where is those first moments of encounter that we can be reaching them that we're not? And I challenge myself on this, because I do think it at a certain level comes back to some of the data. Where do people begin their journey to find out more for help? It might be the person that is cutting your hair. And I use this one a lot because we know that when you do systematic reviews around the psychological interventions, 80% of the good stuff is about the relationships that you forge. So if you have a trusted relationship with the partner in the community, you're 80% of the way there. Having additional skills allows them to intervene. So we're looking specifically at things like barbershops, nail technicians and nail salons, places like libraries, which have become really almost de facto community health centers in many ways these days. Go to where the people are. We have one, we're trying to pilot this now. Unfortunately, because some of the changes that existed in the funding, we are not currently in the middle of rolling this out actively at this moment. We're working on the fundraising for that. But there is one example I can point to in Harris County, Texas, the largest county in Texas, where they are using this model right now. And I have not seen the data on that, but they are looking specifically at addressing this in communities of color with Black men and suicide in Harris County. So thank you for your question. Appreciate it.
I should mention, as Ben knows, I've been working on bringing a process from Brazil that does this work in integrated community therapy. And I chuckled, Ben, because I just recently went to the University of Pittsburgh Psychology Club. They have a meeting at 9 o'clock at night on a Tuesday, and there were over 150 students. It was extraordinary. And we talked about integrative community therapy and did a little mock example of it. And I have never had this experience before. Certainly, I would love it at a PPLC, but what happened at this particular meeting was people at the end of the session, at the end of the talk, came literally running up to the stage and said, we need to have ICT on every single campus in the United States right now. And I said, that's going to be a big scale thing to get to. But I think your points about going where the people are, going to an audience that I don't ordinarily talk to. I didn't even know there was a psychology club. I should have known. It's a big group of people, and talking about things that are innovative and start to appeal to the sense that they can make a contribution and be part of almost immediately was really, really quite profound. So, so I think that it's out there. There's a hunger for it. We just have to find the way to release it. If I had a method, and if you had a method that we knew a drug that could provide aid and help to 500,000 people in the United States, we would have so much money, so much capital coming our way to develop that. It's been tested in another country. We're bringing it to the United States. And yet we cannot find the resources yet. That's why the innovation piece that you're calling for and the leadership and the risk-taking, I think is so critical, not just for ICT, but for many other ways that we could sort of proceed and try different things for the future. So we have other questions.
Yes.
Crystal.
So you mentioned about looking at you to the youth. What is your feeling on looking to the families as well in your model? Since they weren't mentioned, I thought I would ask.
Oh, that is a egregious oversight on my part, because I always talk about, it's the youth or the patient in the context of family in the context of community. I do think it's an opportunity here for us to really go back and think a little bit more thoughtfully on all the things that we learned in graduate school somewhere. Socio-ecological frameworks have been around forever, and yet we forget that family component. So I agree. I think it is a huge opportunity here. One of the challenges that I think we faced in engaging families, and you all that are clinicians, you get this, but you get family dynamics that come to your board table. And sometimes that plays out in all kinds of healthy and unhealthy ways. But short of that, it's really rich to be able to have a family, especially families that have pursued strategies that they think are going to help their communities to bring that forward. So thank you. I did not mean to not say the name, because it is part of how I think about our work. Families are crucial. So thank you for flagging that.
Any other questions? I've got one while we're waiting for somebody to materialize. And I want to make sure that any questions on the, we're good. Okay. So Ben, are there any states that you're running into where there's active advocacy to really move into the lines of activity that you've been describing? Are there some places that we should be looking to maybe emulate or to partner with in terms of what's going on at the state level?
Oh, that's a whole nother talk, Ken. There's lots of states that are right now really taking advantage of this moment. So there's two things that provide a backdrop for this. And I don't think I need to say this to you all because you're probably experiencing this yourself. But there's an unprecedented amount of resources going into states right now to do something related to mental health. Unprecedented. I have never seen this much money funnel through the states, and it's huge. And so because of that, it means that there's a lot of momentum and a lot of opportunity for us to really shape where those dollars go. So that's one thing. Two is that everybody's experienced this whole COVID for the last 2 years. And so mental health is not this foreign concept. And so each state is now able to leverage that and talk to policymakers and have them come to the table and understand what the advocates are asking about, maybe for the first time for some, because they themselves have experienced it. So I think those two factors mean that every state is well positioned here. There's some innovative things happening across the country, and I can point to you all, I can point north and south and west of you. But truly, I think the biggest thing here is that if we do not rally together as a community and come up with that very comprehensive, bold agenda for advancing mental health, a lot of these dollars are going to go into programs that we know don't work. And I don't know what they are and where they are, but I'm sure you do. And it's a moment for us to reflect on that and to really challenge us to go bigger and bolder there. So Ken, I know that's a kind of a dodgy, but there's just too many states that are doing too many good things to give you that in a short answer.
It just tells us that we've got to keep doing what we're doing and find our friends out there who are doing similar things. So we will. Anna.
Thank you. So to build on Ken's question, I'm curious about who the advocacy partners are and how we build political will, especially here in Pennsylvania, for the leadership and risk taking that you're talking about, especially with funding for 988.
Yeah, so thank you. I love the question. This is where I love what I do too, because I get to say things like this. That while we need the mental health advocacy community at the table with us, this is an opportunity to go find new friends. And if you're in a meeting and you look around the room and it's the same people you've been meeting with for 5 years, you're in the wrong meeting. You got to find new folks to join your coalition. And so 988 is a good example of that, because this impacts people you probably haven't spent a lot of time talking to, not you directly, but we as a community. And from the call centers to the first responders, while we may have had a passing relationship with them because they've taken our patients or there's been some handoff along the way, let's get strategic. Let's talk about pathways. Let's talk about like what I can do for you and what you can do for me and how we can create this broader coalition. And then never mind that we rarely bring our friends in public health to the table. So like, I think this is a huge moment for us to go find new friends and take advantage of that. I was on a call yesterday, yesterday, where we were talking about who was in opposition to a particular piece of legislation. And it was an industry that I had never thought about working with. It was the meatpacking industry. And because the legislation was actually going to impact them in ways that were unattended, even though it was good for mental health. And so we have to find new partners at the table and bring them to the table and have that conversation. Just one final thing I'll say on this, the mental health field, while we've gotten better at bringing our medical colleagues and specialists to the table, we still don't do a great job bridging that adult-kid divide. And I don't mean to imply that the policies are going to be the same, but the coalitions should definitely be pointing in the same direction. And so having some of our youth friends at the table with the adult people does mitigate some of the angst that I think we feel sometimes when we get to policy making. And people are saying, well, what about the kids? It prevents some of that from happening. So beautiful question. And I hope you have some of those partners already at your table.
All right.
Good morning. Good morning. Thank you for a thought-provoking presentation. I wondered if you could speak to some of the elements of an effective prevention strategy, maybe from your study of other countries and around the United States.
Thank you. As you probably heard in my comments, I think we don't use the word prevention enough, and I don't think we plan on it enough. And all of you are familiar with primary, secondary, tertiary prevention. We don't need to get into that. But I think in our space, we almost shy away from conversations around primary prevention. And what we've done to try and have those different conversations without constantly having to say the name mental health or use phrases like mental illness is we talk about community conditions. We talk about the factors in community that give rise to flourishing and positive well-being, and how we can actually have big wins for mental health without actually ever doing work for mental health. Examples of this, housing. I mean, we could talk about housing all day too, but there are real concerns that I think each of us should have around the affordability of housing. In my community, I moved from a large city to a small town during COVID, like many people did. And in my small town, home prices have gone up 20% this year. I know for a fact that there are people in that community that cannot afford to live there anymore. And that will wreak just unbelievable havoc on our long-term mental health if we don't do something there. So I think things like housing are foundational. I also think of things that we don't often pay attention to, like transportation, giving people the ease or consistent availability to get from point A to point B for their work. There are cities in the United States that still don't have public transportation. And I don't want to go off on an infrastructure conversation, but I think that that's another moment. Where are the bus routes? Where are they taking people to? How do we ease the burden of length of time that people are spending in transportation? That also has an impact on our mental health. While it's not as on the nose as some of the other things that we could talk about, I fundamentally believe that if we as a community advocated for stronger policies in the housing, the transportation, the employment, spaces and places, we will and should claim benefit from mental health, but we don't do it. And so I think it's an opportunity for us to get very bold, very creative in looking upstream at some of those community conditions. And yes, you're right, other countries have done this. The Commonwealth Fund has put out some wonderful reports recently to look at how the US fares to other nations for mental health. And they highlight certain key variables that go into that. They don't get as much into the prevention space as I just did, but they talk about things like role of technology, ease of workforce, distribution of workforce across locations, and more. So thank you for your question. And I do think it's a challenge that we need to continue to tackle.
I think we have time for maybe one more question, and Dr. Roth.
Thank you for this great talk. Words count. And I have a feeling that instead of always talking about mental health, we should be on a program that I would call healthy living. Healthy living. Because we care about healthy living until you're about age 16 or 17. We raise children. We cover each and everything we think a child needs to be healthy. I won't elaborate. Then, after age 65 in geriatrics, you will hear the same discussion about holistic living, about 6 factors, whether it's exercise, sleep, social contact, activity. So what I'm saying is life is very stressful. And once you go to college, where we know it used to be where you go to college. Now I think it's when you're 14 years old. But that interim space until you're 65 is threatened by every aspect of what is promoted as healthy living. So that's sort of my view. And the reason I hold it is people will listen to that and think, do I live healthy? Parents think that way. Children think that way when they look at their old parents. But that middle stage where we're all under enormous work, personal, dollars, etc., stress, it isn't stressed enough. And many of your solutions revolve around that idea of healthy living for everybody. So I'm sorry I didn't ask the question, but I think that you might agree with me.
You know, if I were in the room right now, I'd come up and give you a fist bump or a hug or whatever you're comfortable with, because I 100% agree with you. A mentor of mine always taught me that health is the foundation for achievement. And we have such a hyper specialized way of thinking about health that it works against healthy living. And so I would just conclude by saying I 100% agree with you. And I will challenge each of you participating today to be cognizant of our language. Language changes our culture. And if the culture we're trying to create is one that's more holistic, more inclusive and comprehensive of essential aspects of our health, like mental health, then maybe our language is flawed. And I've said this for years. I do think it's a problem in how we describe what we do, because it always makes it separate. And healthy living and the ability to achieve our goals should be our priority. So I thank you for your comment, sir, and I applaud you for being so eloquent and being able to state that. So thank you.
In the medical field, the field is called lifestyle medicine. Lifestyle medicine. If you just put that into the net and find out what it is.
We have a question over here. I'm going to sneak one more in on you if I can, Ben. Is that all right?
One more, Ken.
If you can ask him to read Melissa's question and then answer it.
Melissa's question is I can read it to you.
Yeah.
You mentioned COVID and telehealth policies, including legislation that may restrict the milieu of care and mental health care in general. And I'm wondering if you could elaborate briefly on this.
Thank you for the briefly. I'll give it to you in 30 seconds. I am a proponent and a fan of telehealth. I think we should use our digital technologies to bring care to where people are. I think it works for some people. I don't think it works for all people. And I don't want any policies that mandate that to be the front door of entry. That's all I was getting at. I also don't want us to forget that for the last 30 years, many of us have been trying to integrate mental health with our friends in primary care and other medical specialties. And I would hate that telehealth might restrict us from being in a more team-based mindset and mentality. And that's all I was getting at. And so if you begin to see policies from anyone at any level that says this is the only way that patients can initially access care, I will have a hard time with that. But I do think it works for some, just not for all. That's all I was getting at there. So thank you for the clarifying question.
All right, I think with that, and I'm just going to make one brief comment to build on the healthy living comment, and particularly children. Congress has now reintroduced legislation to restart the child tax credit, which had eliminated 50% of child poverty, which is a huge, big issue that I want to just encourage all of us to pay a lot of attention to. It's the most significant mental health measure in line with what Ben was talking about that we could take in the United States at this time. So pass that child tax credit and say thank you to Ben Miller for his presentation. We're done.
Thank you all.
Thanks, Ben. All right, I think we have a 15-minute break, and we will see you all back here in 12 and a half minutes promptly, so you're all ready. Am I go? Okay. All right, everybody. I just want to give you an update on the latest literature. The latest literature has found that the most important part of any conference is the 15-minute breaks that people get. But the problem is that they can only be 15 minutes long. You have to limit them. If it's any longer than that, the benefit goes down dramatically. So we are at 15 minutes and we are going to start. Actually, that's not true. You could probably talk all day and we'd get a lot out of that too, but we're not going to do that because we've got other stuff that we're going to think about and talk about now. I want to make a brief announcement. If you came in today and you parked in the parking lot, there are vouchers at the desk there that will allow you to leave that parking lot without paying any money. So if you want to get a parking ticket voucher, they are on the table with Lucy and Mary. And I think I'm going to turn this over to the next panel and to Julia Macedo. This is the Addressing the Current Mental Health Workforce Crisis panel, and I'll let you guys assemble and we will get ready when you're ready to go.
Macedo. I'm a psychiatrist in Pittsburgh. I graduated from the Public Service Psychiatry Fellowship in 2018. I'm 9 years of Pennsylvania, I came out here for training and I stayed. I was actually recruited for my current job at one of these very meetings. So it's my pleasure to organize this great group of panelists today to be discussing their expertise and direction in addressing the workforce issues in the state of Pennsylvania, and in our priorities really to have a competent, diverse, and community-oriented workforce to address the growing needs of this crisis. So I'm going to go through and introduce everyone. Right here to my right is Dr. Gina Perez. She is the Associate Chief of the Behavioral Health Network and Telepsychiatry for UPMC, which is the University of Pittsburgh Medical Center. That network has over 40 network hospitals and community affiliates. And certainly since the COVID lockdown, Dr. Perez's role has expanded as the emphasis on meeting need through telepsychiatry has only grown and will continue to grow, I suspect as well. She's Senior Director for Medical Student Education and Clinical Faculty Development, and the Clinician Educator Faculty Development Program. Again, also investing in workforce development through those priorities. Dr. Jeffrey Niemark is the Chief Medical Officer at Community Care Behavioral Health, and previously was the Community Behavioral Health Director for Philadelphia as well, correct? Yes, okay. He's a graduate of Haverford College undergraduate and his medical degree at SUNY Downstate. I'm also a Downstate alum. And did his residency at Penn. So has been a Pennsylvanian for many years as well. And he'll be talking about his role through CCBH and the workforce development. Dr. Sosimolu Shoyinka is here as well, Chief Medical Officer for the City of Philadelphia's Department of Behavioral Health and Intellectual Disability Services. In this role, he addresses the needs of the 1.6 million Philadelphians. And he's been part of the redesign of Philadelphia's crisis system, particularly in preparation for the implementation of 988, as we heard Ben Miller discuss how that has been underscoring some of the workforce needs as well. He has had many, many involvements, one of which is also the development of the SMART tool, which we'll hear about a bit later as well. He's a triple board certified. He has an MBA from the Kelley School of Business and many other accomplishments. And then we have our former fellows here as well to talk about the boots on the ground, actually the implementation, our workforce members as well. We have Dr. Amy Silberschmidt, who graduated the fellowship, I think last year, but she had completed the residency in 2019 at University of Pittsburgh Medical Center, Western Psychiatric. Since graduation from 2019 to 2021, she was a staff psychiatrist at the Pennsylvania State Prison System and served as regional director of psychiatry from 2021 until recently when she, for the Pennsylvania Department of Corrections, until recently when she switched to a Pittsburgh FQHC, where I work as well, Squirrel Hill Health Center. She's a recipient of the National Health Services Corps in recognition of her community work in physician shortage areas. And last but not least, Nils Magnuson, who's both a psychiatry and mental health nurse practitioner, as well as a family nurse practitioner. He graduated the fellowship, the community psych fellowship in the same year I did in 2018. So we were co-fellows at the same time. He graduated the Rural Public Psychiatry Fellowship in Erie and has since worked in different settings, including currently as doing telepsychiatry. All right, so I think that my order on here was to start actually with Dr. Niemark. I'd like everyone to kind of give about 5 minutes of comments, and then we'll have some time for question and answer afterwards. Thank you, everyone.
Sounds good. Can everyone hear me? Is good. Well, thank you. Thank you for that introduction. And again, I'm Jeff Niemark, the Chief Medical Officer at Community Care Behavioral Health. It's really so great, as I think Ken and others have mentioned before, to see everyone in person. I too remember that last meeting. So glad we could all reconnect, and really thankful for the chance to talk today a bit on COVID-19 and the behavioral workforce challenges, and to share a bit about what community care is doing in this area. I will try to keep it brief. If you look in your packets, there is a handout. I'll loosely be following those. So if you want to sort of walk along with that, feel free to. But the sort of 30-second overview about community care, I'm sure everyone knows, but we are a nonprofit subsidiary of UPMC, headquartered out of Pittsburgh. And our mission is really to improve the health and well-being of the community through the delivery of effective, cost-efficient, and accessible health services. And to that end, we administer the Medicaid managed care health benefit to over 1.4 million at this point Pennsylvanians across 43 counties. And they're really in urban and rural settings across the state. So given our position and our role, we really have a unique perspective into some of the behavioral workforce challenges facing the Commonwealth today. I'll start with some level setting. I think Ken alluded to this in his opening, but I think it's necessary to say that in the Medicaid behavioral health area, there was a workforce area, there was a pre-existing condition. Like many other system challenges, in that way, the COVID pandemic deepened, but certainly did not create the problem. So let's talk a moment about that pre-existing challenge. Everyone here, I think, is aware of the profound need for behavioral health services and Medicaid eligible individuals. Really, the overlay of poverty and the social determinants of health really, I think, coalesce to create that higher prevalence of challenges in the public sector. So there's always been high demand. On the sort of supply side, despite that high demand, Medicaid providers have always been challenged historically due to their really being financially under-resourced and a resultant inability, I think, to recruit and to retain staff. So even though Medicaid is the single largest payer of behavioral health services in the country, those generally low rates have really come together to create and perpetuate a workforce challenge and to impact capacity in a bad way. I'll throw out that I think the behavioral health choices has been a really strong mitigating factor in that way, and has contributed to Pennsylvania really having a very strong behavioral health system, unlike many of the other states. But that this sort of pre-existing mismatch of supply and demand in the public sector and its attendant public health consequences have really been noted by so many in this organization, so long. I think about Mike Flaherty and some of the presentations he did with the Annapolis Coalition. I think about the HRSA projections and numbers. So we've been hearing about this for some time. And I think one of the things I'll point out on your handout, if you look at the slide, there's really an unfortunate and sort of self-perpetuating feedback loop that exists as a result of this low funding, where low rates result in low wages, then not enough staff, and then the resultant staff being compelled to see more and more people, resulting in staff burnout, more people leaving, and it's quite a messy cycle. Just last word I'll say about that is that sort of pre-existing challenge exacerbated by COVID, and I think felt particularly hard in rural areas. In addition to those sort of financial issues, there are other sort of social trends and dynamics at play here that are contributory. Fewer people are completing high school and college. There's less overall participation in the workforce, and population shifts in the available work pool have again occurred with some disproportionate impact on rural areas. So all that's to say, in terms of the workforce, and I'm sort of setting the stage here, there were challenges with baseline capacity. There was subsequent increased demand and strains on existing workforce supply, and really no clear replenishment options in sight. So overall, a bit concerning. So with that backdrop, wanted to say a bit about what community care has done. We started where we often start, which is in order to better understand, we listened. We surveyed our provider network. We sent out these informational gathering packets to our provider agencies in 2022, 2021 on a large number of areas. They included staff turnover, vacancies, expectations for need, recruitment strategies, really in the service of helping us better understand what they were experiencing and how we might best partner with them moving forward. I'll share quickly some of the results we found. Turnover rates were higher for most of the agencies during the pandemic than they were pre-pandemic, and they were higher in substance use disorder serving facilities. Staff vacancies were higher overall, and again, elevated more on the children than the adult side. And while all of this was occurring, there was simultaneously more demand going on. And again, if you want more details, there are some nice bar graphs in the handouts. I'm just highlighting some of the key points. Also looked at some of the reasons staff were leaving the workforce. A lot of it was due to COVID-related health concerns. A lot of it was providing care to their young children. And a lot of it was around opportunities in other industries.
Dr. Newmark, if you can kind of wrap up your comments and then we'll focus more on the question and answer.
Sure. I won't get into the all the interventions that we've implemented, but suffice to say, I think putting all this together, we came up with, I think, sort of a four-pronged approach. The first was really saying access needs to be prioritized, and I'm glad access is following this. It's really inseparable from workforce and probably needs to be thought about together. Two, we needed to support existing providers. Three, we needed to generate a pipeline. And I think four was we really need to move into non-traditional areas and expand our definition of the workforce. So happy to talk a little bit more about those in the next section. And sorry, I went a bit over.
Thank you very much. All right, so Dr. Paris.
Hi, so Gina Perez here. I'll give a little background about my role. So I'm Associate Chief for UPMC's Behavioral Health Network and for Telepsychiatry, and Senior Director for Med Student Education and Clinical Faculty Development. That is a mouthful. I wish it was an easier, just one word title, but it's not. They go hand in hand, and so it ends up working really well. So UPMC has a lot of hospitals, and we have psychiatrists or psychiatric services in about 12 out of 41 of the hospitals. We also have a lot of outpatient services that are not affiliated with a hospital, and we partner with a lot of non-UPMC entities for outpatient care. And so my job has been to figure out a way to keep people connected when they want to be, to share ideas across our network, and to really make sure that any of the providers do not feel alone. and they don't worry alone. And so that's really kind of my motto that I repeat a lot when I'm talking to new psychiatrists looking into our system. And I know as somebody who practiced in a rural area, it is one of the most challenging things when you don't feel supported and you have a really difficult patient scenario to work through. And so that's one thing I've really tried to prioritize. So I'll highlight two things. So one is that with our telehealth, of course, we used to brag about doing 900 visits a month before COVID. And then during COVID, I think on average, our outpatient alone does in-person and video and telephone to close to 35,000 visits per month. And it's a lot. So that's peers, peer supports, therapists, psychiatrists. I see you doing some mental math here. Yes.
Thousands a day.
And so about 40% currently of those monthly outpatient visits are done through video mostly, and then a handful are still done by telephone. And so one priority that we've always had is when we have our providers who are doing telepsychiatry, my feeling is that you can't really provide good care unless you know the community that you're treating. And so we did a quality improvement project and invested money in, and we still do this now, flying our docs into the site so they can meet the staff, they can meet their patients, they can just drive around and get to know the community more. And so I really felt like that's an important piece of making telehealth work. I've never wanted a job where I pop on a screen and I don't really understand where the person is or how they had to travel to get to the appointment. So that has been one successful strategy to keep people happy with the care that they're providing. An additional strategy has been, I developed a program called the Nurse Practitioner, and now it's NPA, Clinical Enhancement Series. And that was born out of working in an underserved area and appreciating how difficult it is if you're a new nurse practitioner to acclimate into more direct clinical decision-making, high pressure volumes. Sometimes people will sign up as a collaborator and then not really take the role seriously. And so I can talk about the structure of that clinical enhancement program, and I feel very proud of that. And it's been a highlight of my work. So I think I've talked enough. I'm getting the head nod. So I could go on and on, but I won't. All right, thank you.
Thank you. Dr. Shaik, please share your comments.
Good morning. It's a pleasure to be here with you all. See some old friends again in person. So I'll be speaking a little bit about structural racism and cultural humility. I think to just lead in, it's been really encouraging to witness the national dialogue over the last couple of years, and also to see the commitment of the PPLC to moving the needle on structural racism, improving equity, and so on. It's been very encouraging, and I would go as far as to say that the work of the PPLC, I think in many ways is groundbreaking. So kudos to the group on that commitment and dedication. It's a lot of work. That said, I think just looking at numbers across the country in various different arenas that concern medicine and public mental health will show just how far we still have to go. So just a few numbers here to share. When we look at the disparity in the application of coercive or restrictive care, you see Black and Brown people are far more represented in those areas than others. So for example, in Philadelphia, as part of our work on around 988, one of the things we did was to examine the use of 302s, and there's a lot of disproportionality in the use of 302s, and they are applied for threat of harm to others in contrast to other populations. And so we're keeping an eye on that. You see the same trends in the use of application of AOT, where it does exist in places like New York and so on. See the same thing all the way down in the use of chemical, physical restraints,
admissions, inpatient, even the choice of medications, tend to see that disparity. So within our own world of public mental health, there certainly is work to do around structural racism. COVID, I think, gave us a real clear picture of how those disparities exist in other aspects of medicine. So I won't go over that. Now let's talk a little bit about other areas. So provider representation. 2.6% of physicians in the United States are Black. Black males. That hasn't changed in the past 120 years. 2.8% of physicians in the United States are Black females. That has improved from the 1940s. In academia, only 4% of professors and associates are Black or brown or persons of color, compared to white tenured faculty at 87%. That is important because that is the pipeline. That representation is crucial for attracting and retaining other talent. When you look at tech, the numbers are even more concerning. And this is, when you think about the role and impact of social media on the entire population, this is important. 2.5% of tech employees are persons of color. And when you look at senior leadership, executive management across all industries, it's about 6% are persons of color. Why is that important? Well, the data is pretty clear that where there's concordance between the person delivering the care and the person receiving the care, whether that's in medicine or education or anywhere else, there tends to be greater adherence and the results tend to be better. Now, one little factor that I think is important to point out, when you look at attitudes of white medical students, it's actually really concerning. There's a persistence of the belief, for example, that Black people and brown people don't feel pain to the same extent, have thicker skin, and have other physiological differences that are just not based in research. And that plays out in how treatment is delivered. So, for example, screening rates are really low or lower for cancers and even things like treatment for heart disease and what medications are selected. So that starts to, I think, give some insights into why there's disproportionality in those outcomes. And then further, and I'll just end with this as far as the sort of data. There's much more, but there's a wage gap. So we talk about the wage gap between male and female physicians, and that needs to be addressed. But there is a consistent wage gap between minority physicians and non-minority physicians of about 68,000. When you think about the fact that many of those physicians start out with about 25% more debt, that's important. Now, this is not to leave us in a state of despair. I mean, I think there's good efforts being put in place right now. But I think it's also important to think about potential pitfalls as we do this work. So one of those potential pitfalls is this idea that, everybody else has a problem, but I'm a good person. I'm not one of those folks. Another pitfall is that it's really, really difficult to have these conversations. It's very difficult. There's a sense of threat, certainly for a lot of people that want to participate. The other pitfall that I think is this idea of a one and done, intervention. So for example, people want to train their way out of this. Oh, I've done this training, we talked about it, we fixed it, let's move on. That the evidence doesn't bear that out, that's effective. So what is needed is actually a couple of things, and I'll move a little quicker here. So we have to start. Okay, so we have to think about the fact that racism as it exists now was intentional, entirely intentional. Somebody sat down and classified human beings on the basis of an external physical characteristic, which nobody has the ability to control, and added value or designated value based on that. So through thoughts of a person and so on. That same level of, there was intentionality in, the GI Bill and excluding, persons of color from that and so on. That same level of intentionality has to be applied in redressing racism and over time. The other idea is that you cannot manage what you can't measure. And so in order to really sort of wrap our arms around this and really identify areas for improvement, we'll hear more about SMART today, but that's the basic idea is you have to have the ability to measure. Now, a couple quick words about cultural humility. There are three facets of cultural humility. The first is the ability, is lifelong learning. Second is intentionally mitigating power imbalance. And the last piece is institutional accountability. I can't get into all this because we don't have enough time, but I'll just share with you one idea of a person that has really embodied this. And it's not the example that you think of. It's Nelson Mandela. So this is a person who spends his entire life fighting up against apartheid successfully to some extent. Early on in his life, he fought it with a certain set of tools. Later on in life, he embraced the idea of cultural humility. He learned Afrikaans. He read the history of the Boers. He read their poetry and their literature, and it gave him that willingness to take a step back and reassess his own thought process and approach, allowed him to connect with his former adversaries in a way that actually led to change. And I think it's the same thing that we have to do. And I'll stop there. Thank you.
Thank you. And so now we'll turn it over to some of the graduates of our fellowship who have been recruited to do the community work here in Pennsylvania. Sounds like we've decided who's going first.
Apparently we have. I'm not really sure what to say. I did graduate from the fellowship, like you said, in, oh gosh, last December, so 2021, but I started it in 2019 as a resident because social justice is something that I'm interested in. I think I had the naivete entering medicine to sort of not realize that there was a need for a designation around the idea that we would all be interested in sort of social justice and public service within psychiatry. I thought that was the deal, but turns out that's not true. So I did the fellowship and I liked having that space. I think for me, clinical work is overwhelming and demanding, and you're sort of immersed in that as a resident. Didactics felt like they were, let me tell you everything that's ever happened in an hour about every subject that could ever possibly relate. So you didn't have a lot of space, I think, to kind of get depth. And it was nice to sit around a table with like-minded people for a couple of hours every Thursday morning and just kind of think together about those issues. I wasn't able to do the whole thing at the time because of some other clinical rotations I wanted to take, but I left residency and went to work in the state prison system, which was very challenging and very isolating. I was initially one of two psychiatrists, but the other psychiatrist there was not very supportive and frankly, not very ethical, and was asked to not be there anymore after an ethical misstep that I pointed out. So that was not a person who was going to be a good mentor for me. So it was, I started to like, okay, I'm alone out here and I'm figuring out how to practice in this setting that I really don't have much experience with. And I'm trying to be, do the stuff that all new attendings are trying to do, like figure out how to be a doctor. And I'm also kind of trying to figure it out in this space. And I'm also kind of trying to make sure that I am, practicing cultural humility, and I'm serving a largely Black population. And that was important to me. And then also there's a pandemic, and also we're having a racial reckoning. So I went back and I thought, it would be good maybe to sit around a table again and talk to other people about things, mostly not even psychiatry in the strictest sense of the word. I don't recall ever really having a conversation about, boy, would you use Latuda here? Or are you going to go with Lamictal? It was much more about kind of the social space in which we work, and how do we think about these relationships, and how do we think about our world, and with a mix of here's how sort of administrative things actually happen, which is useful to know, and I will probably forget, and then I will have someone I can ask. So I feel like that's what I can mostly sort of talk about. I was thankful to have actually two separate groups of fellows around me at two separate times. And I hope to stay involved and have these people around me in the future.
Thank you. And actually some of what you're talking about is what Dr. Perez was talking about as well, about making sure that when you're doing that community work and there's so much high need and there's so much patient volume and you're kind of alone in some of these settings, that you're working very hard to retain those people by providing community, by providing support for colleagues and career development.
Yeah, for sure. And I think in the corrections space specifically, but probably other spaces, the people around you may not be as invested in providing good care as you are. I can say that the corrections space specifically was not as invested as I was in providing good care. And so I think, you know, keeping in mind that your role is not just a doctor in the narrow sense of like, I know science and I can prescribe medicines, but it's also sort of to be that advocate and to be that voice and that representation of, we are trying to look together in what's going to let you live a good life. And that may not be, strictly speaking, only medication management.
That's right.
So that was helpful.
Thank you. All right, last but not least, Nils Magnuson for
And
your comments.
I can certainly echo that, and I'll start at the beginning briefly at some point, but having a better understanding of and having a systems approach where it's not just the clinical one-on-one therapeutic interaction and medication management, but all of the other pieces that impact access and care delivery, and then even internal audit aspects. This is how these things should be occurring. So the fellowship was really beneficial that way. So it came at the perfect time, of course. Dr. Chapman heard of my plight. The clinic that I was initially hired at, I was an FNP at the time, and you can practice psychiatry as an FNP in Pennsylvania. Other states, that's not the case. I had been planning to get a postmaster's and board certify anyway, but that was my kind of entry into practice. The sole physician at the clinic at the time abruptly retired. So I was going to be onboarded with no collaborating, I wouldn't even be able to practice, so they were going to bring up somebody back because psychiatrists aren't allowed to retire or pass away. So they pulled one from who had been there prior. He was my collaborating physician. But like Dr. Perez had echoed, he signed the collaborating physician documentation. That was the extent of it. And that's not a criticism. That was the level of involvement that he wanted to have. So Dr. Chapman kind of heard, and through Rick Seeger said, well, you should do the fellowship. And I said, what are you talking about? And that's for physicians. And she said, we can have it be for whatever I want. I'm the director. and she was right. So I got to spend 2 years, initially with Dr. Chapman, and then subsequently child and adolescent with Dr. Alba, because I was seeing all ages at the time. So I was FNP, seeing all ages in an outpatient clinic, the only full-time prescriber or provider, even though I didn't go to school for either of those. I was the only full-time individual providing care as a nurse practitioner. Psychiatrist was mostly part-time then. And then that really solidified my desire to make sure I did my postmasters and board certification. And, and then to be able to attend the meetings, and I'm really hoping that some type of integrated care model would more readily develop, or I would have access to something like that. So really maintaining both certifications was a priority to me. A lot of those family med skills can be quite perishable. So it's not like I want to roll in and just start being somebody's primary care provider, but certainly it has benefited the telepsych piece. But through those 2 years, helped implement the clinical, what is that? The shared decision making, platform came into the clinic, so I helped kind of champion that. And then the second year was, primarily focusing on child and adolescent psychiatry, because I was also helping cover an IOP in the area at the time. So, some of it was clinical decision making and talking about that. And a lot of the rest of it was the community not feeling very isolated and alone, even in an outpatient clinic, because that was it. I was just, myself and, very limited support staff. So it couldn't have come at a perfect time. And it really was a very defining period in my career. And I couldn't be more thankful for it. It was really one of the best decisions that I ever participated in or ever made. So, but the fact that it was open to nurse practitioners, and, I won't pretend that there's not some fulmination around physician assistants and NPs and their level of ability to practice either with a collaborating physician or physician, either way. That's not I never felt that somehow my care was being restricted by anything. But really to have the benefit of physician led, which means actually being a leader, which, not everyone is possessed with, and that's fine, and not a criticism in any way. And some people aren't interested in it, but having the ability to have that type of support, is fundamental and really made a huge difference in how I'm able to practice today. So very beneficial.
Thank you for those comments, everyone. We have a few written down questions, and if people in the room want to verbally ask some questions as well, we can do that too. Whoever wrote this one, I might ask for some clarifications, but I'll start with this. What efforts are being extended by CCBH, CBH, or other care organizations right now at the local or statewide level in terms of advocacy and supporting the policies of finance and expanding mental health personnel offerings, it looks like. So I guess like the.
Are there efforts, or are you allowed to make efforts in the communities in which you offer service to create, not lobbying necessarily, but advocacy? An uncomfortable public official is sometimes a better public official. And if we can make those efforts, are you able to do that?
So it's a good question. I'd say a few initial thoughts, and then I'll try to get into some of the details. There are some explicit prohibitions on lobbying that exist. But with that said, I think we try to partner with our primary contractors and often work with them around the optimal strategies to rope in key stakeholders like everything from legislators to community members to talk about kind of what's happening on the access capacity front. So I think there are regular meetings that we have with providers, with member groups, with other stakeholders, where we, I think, frankly discuss what's going on, what the state of the state is. I'm not sure that we are as directive as your question might be suggesting we might be or ought to be. But I think we are continuously advocating for there to be rate adequacy, for there to be attention to the behavioral health epidemic. And so, I think, I know OMSAS DHS folks are in the room. We certainly speak with them on a regular basis to keep them apprised of what we're hearing. We share the results of things like those provider surveys I mentioned before, and work in concert around those. So there certainly is exchange of information, stakeholder engagement, the stirring of the pot as actively as possible, something to probably talk more about, but I'd say it's more on the communication front now and trying to drive policy in the right way.
We'll put in my usual plug for the things to advocate for, but Dr. Shoyinka mentioned about the the burden of debt that clinicians take on to become doctors, and then what that then entails in terms of doing the community work thereafter. And I just want to put in the plug that, I received the state primary care loan repayment money for the work that I do at the FQHC, and Dr. Silberschmidt is a National Health Services Corps recipient. And these are the ways that you help keep people doing this work to offset the costs that it took to get here. All right, so another question again about kind of building this workforce. We hear of college and universities needing to close counseling and social work programs for lack of enrollment. Any thoughts on reversing this trend, and really how do you invest in this workforce if not training the people to get there? I don't know if anybody has any thoughts on it.
It's not a full answer, but I think our entire field has a real marketing problem. Branding problem, I should say. So whatever can be done, I think, at earlier stages to inform and really, it really boils down to marketing. It's crafting a clear picture of what a career in mental health looks like, what the benefits, the rewards are, and communicating that, modeling that. I think that's easy to say. It's obviously not easy to do, but I think that has to be part of the solution.
Part of that cycle that you were mentioning, Dr. Niemark, about lack of resources and reimbursement that then causes extra effort and burnout for the clinicians and the people that are doing the work, that then causes us to diurese clinicians from the community setting. That's not a great example to lead for when you're looking to recruit people for a master's in social work program. So
I will say that I'm aware of efforts, certainly in Philadelphia, to create pipeline programs, which Val could speak to in much more detail. She's been critical in setting that up. Those might be one solution.
Yeah, I would just layer on that. I think it's there are a number of things to consider. I mean, we certainly need to lead from the heart and inspire people to be thinking that a career in mental health is something that they want to do. I mean, we want a workforce to be driven, to be inspired, to have a mission, and to think they're going to help. I think we also need to make sure we inspire from the pocket as well. So we need to make sure that we're creating, a livable sort of existence for them. And that's not just sort of the wage, it's all these sort of in-kind loan to, incentives and loan forgiveness and all that other stuff. And then, I think we just have to think about when we're doing sort of a barrier analysis, what some of the obstacles that we could focus on to bring more training into the public health sphere. So whether that's around requirements for, documentation and supervision in those settings, what we can do to facilitate that, or other sort of administrative areas to just facilitate people's entry. So I think it's considering all those three.
In one area that we've looked at when we're trying to recruit new providers or new staff members is really appreciating the dynamics of the team on the ground and the importance of having heart and having patient care as your main focus, and for people to feel proud of where they work and proud of the clinical decisions that are made, because from past experience, those are the things that can be demoralizing and create burnout. And so while looking ahead to bring on new team members, it's critical to look at who you have now and really appreciating what they're doing and what everybody brings to the table.
Yeah, can I also just say one more thing, building on something Sosamalo said? I think the marketing we need to do earlier, and we also need to expand it, and we need to move beyond you don't have to have, this speaks to, I think, Ken and others' thoughts about expanding our workforce. The most meaningful changes that people experience are come about from the conversation with the tech on the night shift, not the doctor. So I think really the message that people, you can bring with what you are and who you are, amazing capacities to impact this is something that we need to get out there, and that there's healing in that.
And that was something that Ben Miller was talking about too, in terms of the who in workforce development. This is not just about recruiting more clinicians, but rather about expanding who we're looking at on the team to better fit the need.
I may be sort of echoing things that you've already said, excuse me, sorry. But as someone who was a single parent through most of my training, I think sometimes there's this idea of, okay, well, we got you in the door, great. But the whole training process, at least for physicians, but I think for other specialties as well, is arduous. When there's not that support all along the way, and I don't think being a single parent is dramatically different than sort of other kinds of challenges, whether it be, coming from a minority community or what have you. That support has to go all the way along. And sort of on that, and granted, I'm talking about corrections too much, but I have a lot of patients who would really like to offer their experience, and they know that because they have felonies, there's not, maybe they're not going to become physicians, but there's not any doorway for them to be saying, hey, I actually learned a lot about my mental health through this space. I learned a lot about my addiction through this space. I'd like to be helpful for others. I think helping peer support is one way that we've been doing that, but starting to think about how do we get the folks who have the experience we need in the door and keep them there in maybe a broader way than just some of the categories we've been thinking about up till this point, I think is really important.
It's like having too much lived experience as a barrier to sharing all the important aspects of your lived experience.
Exactly.
It's like, well, that was too much. It has to be less.
And if we're talking about finding a workforce that meets the needs of our communities, right? What are we putting in place to address all those other social factors that are impediments to getting there? It sounds like you have a comment, Dr. Schenk.
You just made my comment.
Well, since I already put you on the spot, I'm going to ask this next question to you. What would be one policy change to expand or enhance the entrance of brown and Black young people into STEM fields? So what are some of the, we talk about those early pipeline moves. What would be, I realize this is multi-layered, but if you could pick one, that would seem appropriate.
I think it's an excellent question. If there were one intervention, I think there's a lot to be said for exposure to role models. I think there's a lot to be said for that. And if there were, so that would be one thing. But I think the other thing would be, looking at structural barriers, and oftentimes it boils down to financial concerns. So if there were some sort of, this morning, Ken was talking about the child tax credit, as a means to, eliminate child poverty, and with all this, the sort of downstream effects of that, if there were some sort of a similar intervention targeted, the idea of microfinancing, for example, you can take that and apply to, grants, scholarships, and so on to help kids from minoritized communities to, give them access to more resources. That would be one simple idea. Not easy, but I think that would go a long way.
Let's do this next one for Dr. Niemark. How is CCBH supporting providers in the workforce? We talk about some of the kind of difficulties in the workload and the needs and being out there providing care alone. Are there any innovative models that CCBH is looking at to support retention?
Yes, share a few, and probably for ease, break them into what I'm going to call the sort of financial and non-financial buckets. I think, again, ensuring an adequate competitive wage is, it's like a floor that needs to occur. So I think we, with our county partners, have worked very hard to really make sure that we provide ample rate increases across the board. I think in addition to just those sort of baseline rate increases, we've worked on some innovative alternative payment arrangements that have allowed for providers to, I'd say, use money to provide for retention, recruitment. So beyond traditional sort of fee-for-service models, thinking about again, alternative and value-based arrangements that support the workforce. I think on the non-financial side, supporting providers, and that comes in a lot of different forms. I think, listening to them is the starting point. So making sure we're hearing what they're experiencing regularly is important. We, for instance, meet with the physicians, we meet with other groups. I'd love for there to be more sort of feedback and input in those sort of sessions to really make sure we're hearing a diverse opinion. But we are, I think, actioning that in ways. One example was we created a sort of learning seminar for our provider network that focused on key issues that providers were experiencing during the pandemic. So things like burnout, things like, remote supervision, sort of compelling issues. We partnered with the Penn State School of Business and created a 6-part learning seminar, and very well attended, very positive feedback, just to work with agencies and their leadership about how to sort of navigate this. And we actually did that last year. We're planning a part 2 that's a little more focused on supervisors and other staff. But I think it's those are just some examples of the work we're trying to do to support providers.
I think personally, events like this, right, opportunities to kind of talk about the struggles and the direction for hope are some of the things I think that personally help offset my own burnout and kind of break up some of the burden that it is to provide a lot of clinical care.
Yeah, and one of the other things I'll say, it's more in the sort of beginning stages, but thinking about vicarious burnout and creating a sort of trauma-informed provider network, and thinking about how we can partner with our provider network to help bring that about is something that we're sort of starting to look at. We've done some of that work. I know Sally's in the back with our providers in the North Central BHARP region. So they've been a leader in that way, but I think we're looking to do that more broadly because it's a big issue.
Dr. Perez, you mentioned some of the specific programs that your network has in place, and I wonder if you could kind of speak to the potential ability to apply some of that even more broadly with those lessons, and what would be the keys to getting people to the table to have those opportunities to discuss burnout, hear from these clinicians that need the support.
Sure. So one of the challenges is that across Pennsylvania and into New York and Maryland, in our network, we have 56 different psychiatrists and 39 advanced practice providers, and they're all in very unique locations. And so I think one of the first steps is just appreciating what their setting is like and what their site is like and their supports, and recognizing that a solution for one location may not make sense at all for another. And so just respecting the individuality of each of the providers. And another thing that I aim to do, and I'm not perfect at it, is just really trying to get to know people on a personal level and understand what's inspiring and what's demotivating, and making sure that we shift the balance in the right direction. And from the APP perspective as well, it brings me a ton of joy to do like our weekly case conferences. I've pulled in over the past 4 years, 18 different psychiatrists to also help me with that case conference. And it's really about sharing knowledge and about me learning as well, and not pretending like I have all the answers, and letting people connect. And so, I don't know, across our network, I consider it success when, say, if you're in our network, Julia, and you have a crisis or a difficult patient situation, you always can reach out to me. But if you then have 3 other people on your speed dial or speed text, to me, that's like success. So I think it's about creating those meaningful networks that are real. And that makes the work more fun too. I don't even know if I answered your question. I just sort of.
I actually often think that, we talk about the fellowship setting or residency setting, you have so much support and there's so much kind of hierarchy for leadership, and you sort of expect that that's going to continue. And Maybe in some settings it does, but in a lot of these community settings that we're talking about, that does not. And making sure that we're supporting people in creating their own networks for, support from peers is really important. This next question is for Dr. Shreyanka. You mentioned the importance of representation, and often one or two people of color are asked to lead DEI programming all the time, and the tax that takes. What are your suggestions to prevent re-traumatization and build resilience in those leaders?
I think the PPLC's work has been a real example on how to do that. That work has the racial justice work, that it's been a group, and many of the members are here, if not all of them. But one of the things I really liked about that was that and Ken said I remember when you made this comment, said they didn't create this problem, they should not be responsible for fixing it. Meaning referring to persons of minority backgrounds. And so I think that's a model. The work certainly has included representation. I know Rachel is here, she's been a real leader in that, but so has Marianne and Lloyd and Ken and several other people in this room. So I would think that the willingness to, and it really sort of boils down to willingness to, for want of a better term, muddle through this very uncomfortable space for non-minority people. It's just a willingness to hang in there and learn and learn and learn until, and sort of take one's part in sharing that work. I think the other piece of this is recognizing, and I've personally had to learn this myself, that what you said, that some of these conversations can be re-traumatizing. And recognizing that at a certain point, some people may have to just extricate themselves and back off of it, and then re-engage when they're ready, and being willing to allow that space. It's probably not fair to task the work of DEI to only persons of minority backgrounds. I'll say one other thing, and it may sound controversial, but it's I think the historical anecdotal evidence would actually support this. In many cases, the appointment of a Black or brown person to do DI work is an example of a one and done. That's a way for an organization to assuage its own conscience. Well, we fixed it, but then there's very little actual power or influence given to that person, or support given to them when they're dealing with the inevitable pushback that comes with trying to do that work. So that has to be part of the thinking as well.
I know you have a business background as well, and I often think there's a gap in our healthcare training in terms of that. How do you advocate for yourself as well? And if clinicians and psychiatrists are being asked this extra burden, this extra tax, then we also have to train people how to advocate for themselves, to get administrative time for this, to get a pay raise, and to get a title raise for the efforts that we're asking people to do. I mean, this can't just only be volunteer based. And I think that's one of the inspire from the pocket also as well, in terms of, making sure that we're supporting people financially for the efforts we're making them do. And along those lines, this is maybe even more of a suggestion than a question, but someone asks about the issue in funding, that social workers, to get their clinical hours for their LCSW, often need to pay out of pocket to their supervisors in order to qualify that time to become licensed, which clearly has a large implication for discrimination. Any thoughts on helping change that?
I think it's a real problem. I think it's a good suggestion, and I'm happy to look into what can be done. I think, historically we've struggled around ways to fund supervision. from a regulatory and policy perspective. But I think it's one of those things that would really attract and entice and potentially retain social workers to the public mental health space if that was a benefit. So it's a yes, and happy to look into it. Don't know all the nuances of what's possible, but I think this is an example of, as we inventory the existing barriers, like, is this a place we could push and see movement on and change the game? Because I think that's what's necessary given the state of affairs. So that's a yes. Look into it.
We have a similar issue with psych certified nurse practitioners. To be able to be board certified, you need so much time with a psych certified nurse practitioner. And that's aside from psychiatrist and master's level therapist. So, there are very few practice sites. There are not a lot of psych certified nurse practitioners to begin with. I think it was bouncing around 2 or 3% overall. And maybe, and you could argue whether this is good or bad. It has increased. Hopefully it has increased for all the right reasons, with all the right education and training that should come with board certification, though that can be up for debate at sometimes. So there are honorariums, there are whole businesses where you can be paid, for so many hours, hundreds or if not thousands of dollars. Because if you cannot complete that time, schooling is on hold. So you have to withdraw or be in a state where you're not able to complete those courses if you don't have a psych certified nurse practitioner. So it's really, I almost had to stop mine because there wasn't one, and I just so happened to be talking to an RN I was trying to hire. She declined the position, and we got to talking because that's kind of my job. And she said, "Oh, my mom's a psych certified nurse practitioner." I said, "Give me her cell phone number immediately." And she was 20 minutes down the road, and I was the person who had her prior job. So I knew her through documentation, didn't know where she was or how to find her. And just by chance, it all worked. So, it was really, and she had a spot open. So, it was really, couldn't have worked out better. I was really.
That's the social capital that you then kind of stumble on. I don't want to leave out, I guess there was one question online that we had neglected. So I think that'll be our last question. If you can unmute them from Zoom. Okay, great.
Hi, everyone. My name is Lisa Davis, and I'm the director of the Pennsylvania Office of Rural Health. And I like to categorize myself as a lifelong recovering community mental health caseworker. And one of the things that I always think about, mental health to me is such an important issue. And I think about the clients who I had served when I was working with schizophrenics in the community, thinking about two things: Maslow's hierarchy of need and also social determinants of health. As you all know, low-income persons or persons who are struggling with housing or unemployment or drug addiction and so on are facing so many needs. And I'm wondering how you see reaching out to these populations. We all recognize the importance of mental health services, but I think for many, being able to access those services, especially in rural communities, although we do appreciate the telehealth services that are provided, how do you help those who truly need these services being able to first understand the need for it, then be able to access it, and for those who will be losing their Medicaid coverage once the public health emergency ends, how will they be able to access affordable mental health services? So those are just a couple of questions, and I know you have about 30 seconds to answer them. So thank you so much.
I think there's a big question that underlines a lot of the crisis that we're talking about today.
So I think one important way for accessing is through obviously telepsychiatry. And one immediate challenge is the struggle with needing signatures for encounter verification forms at each visit. And I feel like the population that's going to be impacted the most is our patients who struggle with more serious illnesses and those in rural settings. And the options, the alternatives that are on the table now are going to be really difficult. So like digital signatures are very tough to manage within an encounter. And the concept of storing recorded verbal consent is a challenge from a system level about how to keep that secure within an EMR that's never done that. And so I think that those will be important factors in looking at how do we continue to support people in rural locations with who really need us and want treatment.
Yeah. Oh, I was just going to quickly say, I think to the point of engagement's a really critical strategy that we need to think about. And my take on that, and it probably extends to rural and non-rural, but is demedicalizing and probably privileging some of the community-based organizations, using them really as extensions of the human services system. And so people who struggle with food insecurity or housing instability, I mean, really thinking about those areas as places where we can best do that initial engagement, outreach, and connection. And very quickly to the other question, just, I mean, I think the de-enrollment is going to be a challenge. I know we are thinking and partnering with our stakeholders on how best we can communicate and outreach. I mean, this is harder for folks who are homeless or difficult to contact. So it's really going to be an all hands on deck effort around that, but unfortunately, I think some will still get sort of caught in the crack. So it's something I appreciate the flagging, and we need to be very thoughtful about that transition.
Thank you to our panelists and to everyone for joining. Thank you for all these thoughtful questions. I'm sure we could have done plenty more time on it, and I'm sorry for going over into our break. Thank you.
We will reassemble in 15 minutes.
We're going to ask people to take their seats so we can start the next panel, please.
Order.
Good. Nice to see you, like not on video. Yeah. You're very harsh, I was gonna say. Makes me feel like I'm in the Senate.
Right. So I'm just going to give really short introductions and allow you to take the time to say all the things you need to say. Okay, it looks like we're abruptly ready to get started. My name is Wes Sowers, and I'm one of the course directors. And so it's my pleasure to be able to introduce our panelists here for this, this session on access to care. And I think we had kind of a nice segue into this session at the end of our previous one. And so we can really continue that discussion. So with us today is Sally Walker, to my right. And Sally serves as a Chief Executive Officer for the Behavioral Health Alliance of Rural Pennsylvania. And thank you for being here. Next is Eleanor Anderson, who's going to be talking about whole person health. She's a consultation liaison psychiatrist and Chief of Integrated Services for the Department of Psychiatry and Medical Director of Penn Integrated Care at Penn Medicine. Next, we have Dr. Hope Selinek. And Dr. Selinek began her training in internal medicine, but gravitated towards psychiatry and addictions and completed her residency at Hahnemann and is now on the faculty at UPenn. Next is Kristen Hauser. She currently serves as the Deputy Secretary for Pennsylvania Department of Human Services in the Office of Mental Health and Substance Use Services, or OMSAS. And finally, we have Anna Brindle Kennedy. She serves as the Executive Director for the Touchstone Foundation in Lancaster, Pennsylvania. And so I think that we intended to start a little bit with the discussion of the 988 initiative. And so I'm going to just kind of turn it over to the two of you. I know you're going to do a little touch tag kind of presentation for us.
Do you want to start? Sure. Okay, sure.
So welcome, everyone, and thanks for putting this on the agenda. As Ben Miller shared this morning, I think that 988 is really a huge opportunity, not only for Pennsylvania, but everywhere in the country, as a real opportunity to change the way that we are providing access to mental health care for people who need it most. And as a philanthropic organization, I also want to share that we are taking the lead and we are taking some risks. So I think it's an opportunity really to help shift the conversation around what we can do with 988. So in your packets, I have a handout. It looks like this on one side and there's a little workflow diagram on the other. And really, at the Touchstone Foundation, our work focuses on youth mental wellness and building the talent pipeline, as we just heard about in the previous panel, simultaneously with increasing access. And so we're concerned about the suicide rates that we heard about this morning. Suicide is the second leading cause of death for youth ages 10 to 24, according to the National Institutes of Mental Health. So 988 was funded by, or was authorized by federal legislation that went live in July of 2022. So all it did really was change the number. So it changed from 800-273-TALK to 988. But what didn't happen is that there's no federal funding associated with it. Instead, it's really up to states to provide the funding. And as you can see here, it's really an opportunity to better connect the systems of care that we do have, or even, maybe we don't have a system that we need, but here's an opportunity to better build and more importantly, fund that system. So the vast majority of calls into 911, these folks are not trained to respond to suicide-related calls, mental health, substance use. So law enforcement is not necessarily always the best trained to respond. And crisis call centers don't always require an emergency response. So we need to integrate a system here. And this is an opportunity.
Could I interject there just for a moment? Just to sort of build out like where the federal government is going and some of the direction that they're giving to states. The introduction of the 3-digit phone number was sort of the first step toward trying to build out a more integrated system. And I always want to remind people that when the legislation passed in 2020, it was before any of us knew about COVID. And that 2-year implementation timeline was a bit aggressive, even in the best of times. And so COVID certainly, really tested us in terms of keeping on track with working with our call centers. Pennsylvania currently has 14 call centers that are taking the calls from the National Suicide Prevention Lifeline, or now 988. They were doing it all but one prior to this coming in. So they do have staff in place. We've been watching our answer rates. We're doing very well with it. Pennsylvania is actually answering about 86% of the calls that are originating from Pennsylvania-based telephone numbers. SAMHSA has asked states to strive for a 90% answer rate within the first year. So we are right on track for where they want us to be. And then they recognize that the rest of the crisis service continuum will take more time to build. And that is trying to ensure full access to mobile response teams, not just an individual, but a team, and having walk-in centers or walk-in stabilization centers available. So they have sort of mapped that out and said by the end of 2020, they would like to see 80% of the state with access to mobile response teams. And by the end of 2027, access to walk-in stabilization centers. So they're with us in recognizing just because the number went live in July, building a comprehensive coordinated system behind it will take a little more time.
Thanks, Kristen. So with our partners in philanthropy across Pennsylvania, we are really working to try and advocate for blended funding. So this is, I think, really an opportunity to look at, what have other states done across the whole country? And what they've done is a whole mix of things. And so I think the opportunity for Pennsylvania is to really look at many different sources of funding, including other funds that could come in from the federal government, as well as possibly passing additional fee for some additional funds. So other states have appropriated funding, not the vast majority, but some have. And what the model shows here is what is happening in Arizona, which is really, I think, an opportunity for us to look at in Pennsylvania as well. So we're really here at the table as philanthropy saying, we can be a partner in this and we can help advocate for 988. We've also drafted model legislation. So it is available and we're happy to share that with all of you. And again, what it's really looking at is, how could we increase funding to support the full vision of what 988 could be if funding is adequate to really realize and recognize that full opportunity that we have. Thank you. Yeah.
So just to lay out where the funding picture is right now, it's scattershot is I think a fair way to say it. So the call centers do receive funds through a variety of sources. Some of them are using base dollars, some of them are using block grant dollars, some of them have local foundation support, some have local support from their county or a city. The call centers get a very small stipend from the federal government. We are in the process of processing some workforce support grants that we just received from SAMHSA this year that will go toward helping to stabilize workforce in the call centers. But on the statewide level, we did write draft legislation last year. And I know it looks like Pennsylvania hasn't moved on legislation, but we've just been doing it behind closed doors. We're trying to be pretty strategic about finding the right person and the right time to move forward with trying to get more funding for the crisis system. With the budget this year and the creation of the Adult Behavioral Health Commission needing to determine how to spend $100 million, it sort of put the kibosh on our ability to ask for additional dollars before we knew how those were going to be spent. It does look like crisis services will be a spending priority. We will need to wait for the final recommendations from the Behavioral Health Commission. Dr. Adair can say more about that if we have questions. And the legislature will need to approve that appropriation, which could include a spending period of what was it, till the end of 2026? Okay, so multiple year funding. And then we know that the federal government is going to continue making grants available. They just don't give us a roadmap for it. So it's a little bit of wait and see what comes up, utilize that opportunity. And we at OMSAS will be issuing a county funding opportunity here in the very near future to provide counties with different options based on where they are in their current service delivery model and what they need to do next. And we're certainly incentivizing, particularly for rural counties, the ability to partner as a region, recognizing that standing up a 24/7 walk-in stabilization center with clinicians, with all the different folks that need to be there is really a very tall order for Pennsylvania and financially not feasible, particularly given utilization rates. But we know that other states, including Arizona, have very successfully looked at regional response models. And so we are going to be incentivizing that for counties that are interested. We've done some preparatory preview meetings so that folks can start thinking about that and be prepared when the grant announcement comes out. So we are sort of trying to lay a foundation. And what's important about that is, while we have estimates from our actuarials of what the system might cost in an ongoing way, they're just estimates. We don't have a real plan. So we're really hoping that because we are a county operated system, this grant planning process that we are about to make available, within a year or so, that we would have a much more concrete footprint of what the services might really look like. What do counties or regions want to have? How might that, the real cost look like? So it's more than just an actuarial cost. And that will give us a much more easy to sell, or hopefully easy to sell. It'll give us a real product to start talking to the legislature about, so that it's not, we're estimating such and such. Well, we know what other states have passed. They also have a very different background. They're not a county operated system in most places. They're state centralized operations. It costs less that way.
Thank you for that great overview,
okay,
but I'm going to interrupt you, and hopefully we can come back to that a little bit as we move on. But next, I want to turn things over to Dr. Anderson to talk about whole person health.
Hi, well, thanks so much for having me here. I really liked Dr. Miller's keynote address, and especially the quote where he said, "We've codified the separation of mind and body through policy." And I would also add that your eyes and your teeth also have different insurances. So here's a question for you. Can we provide whole person healthcare, including psychiatric care, in medical care as a whole, while improving access? And the answer is a resounding yes. Considering the whole person in medical care really requires substantial attention to psychiatric comorbidities, as you know. So mental and physical health are just deeply intertwined. 30% of those with physical health conditions have psychiatric comorbidities. 70% of those with mental health conditions have physical health comorbidities. And those patients have worse health outcomes. The life expectancy of patients with mental disorders is 10 years shorter compared to those without mental health disorders. They tend to have higher healthcare utilization. They sometimes increase provider and caregiver burnout. It's a very entrenched systemic issue. And the impact on society is really substantial. Depression is a leading cause of disability-adjusted life years worldwide, and it's an effect felt especially keenly among young adults who are expected to be among society's most productive members. So not only mortality, but really morbidity, quality of life is suffering. So this interplay between physical and mental health, as well as the challenges of our mental health system with our access issues, variable quality, often unmeasured quality, reimbursement is low, many areas of population stigma is still high, and these are the things that have really driven people towards integrated care. So I want to go over the core principles of integrated care for those of you for whom it may not be that familiar. So first and foremost, it's population-based. It's defined groups of patients are tracked in aggregate, and care coordination and engagement are emphasized. So for example, those with uncontrolled diabetes and depression, or those with a lot of emergency department visits and anxiety can be targeted and helped. And it's a patient-centered, second, it's a patient-centered and team care model. So providers collaborate effectively using shared care plans that incorporate patient goals. Third, it's measurement-based care. I know that's sometimes anathema to some of the old school psychiatrists in here. How can you measure the soul? But it's measurement-based care is really the future. It uses a treat to target approach. Clinical outcomes are routinely measured by symptom assessment tools like the PHQ-9 depression scale, and then treatments are adjusted on the fly. They're actively changed based on those clinical goals. Fourth, evidence-based care. And certainly for collaborative care, which I'm going to talk about in a minute, there's over 80 randomized controlled trials demonstrating effectiveness of this model. Fifth, it's cost effective, and there's reimbursement models and evidence demonstrating a lot of cost savings and a great return on investment. And finally, there's a focus on accountability and quality of care based on those measurable clinical outcomes. So there's various forms of integrated care, and the one with the most robust evidence base is collaborative care, which is a term of art, also abbreviated as COCM. That's the model we use at Penn, and our program's called Penn Integrated Care, or PIC. So in the collaborative care model, a care manager is embedded within a primary care clinic. They take care of patients with mild to moderate depression and anxiety, which is the bulk of mental health needs, lower acuity but higher volume. And the care manager administers validated scales at every session to monitor patient progress over time or lack thereof. And then they review the patients on a registry and get weekly supervision with a psychiatrist. Patients with really severe symptoms or complex clinical pictures, or even if they just plain prefer it, they get assisted with connection to specialty mental health care in the community. So we're really addressing the mild to moderate anxiety and depression. And this model improves access by allowing patients to receive this care through the use of medical billing codes. It can reduce markers of chronic disease. So in a randomized controlled trial published in JAMA in 2020, a significantly higher proportion of participants in the collaborative care model arm had a reduction in systolic blood pressure, HbA1c, or LDL cholesterol. The collaborative care model also reduces ED visits and hospitalizations and even primary care visits by almost 50%. It decreases overall healthcare spending, primarily via decreased hospitalizations. Hospitals are so expensive. Every dollar spent on a collaborative care program saves on an average of $6 of medical spending. So about PIC itself, we've received over 22,000 referrals since the program began in 2018. We started with 8 clinics where we've expanded to 18. Our goal is to go to all 90 in the Penn primary care system, 90-ish. And consistent with the literature, we've achieved on average a 47% reduction in depression and anxiety scores, usually on the order of 12 weeks or so. And 45 to 47% of patients achieve remission. Is my time up? Okay, let me real quick. And so we are addressing the access problem not only by expanding the available workforce, and as I'm saying, primary care docs are part of the mental health workforce. Just by prescriptions alone, they are a part of the mental health workforce in this country, and they might as well get the support of psychiatrists. So I'll just stop there and we'll
Thank you.
do more Q&A.
That was great. Next, Sally Walker, we'll talk about rural needs.
Yes, thanks, Wes. And good morning, everyone. I just want to talk a little bit about BHARP and where I'm from. We are the primary contractor for 24 of the rural counties in Pennsylvania for the Behavioral Health Choices programs. And the county composition is such that 21 of our counties are class 6 or higher, which means they have a population of less than 90,000 people. So while we cover a vast majority of the geography in Pennsylvania, the population density is pretty sparse in some of our counties. Traditionally and historically, members, when we do member surveys and focus groups at member and family advisory committees, transportation has been one of the top barriers to accessing care. And we have done work around telehealth. And of course, that was expedited during the public health emergency. And I have some data and statistics because I think it's surprising to folks when we talk about telehealth and access to care. Lots of people bring it to the table as the solution. And while it is a solution, it's not the solution, particularly in our rural counties. The Office of Mental Health and Substance Abuse Service conducted a telehealth survey of individuals receiving those services in spring of 2020. And 89% of all the respondents never had a telehealth service prior to COVID-19. 88% of the respondents had a telehealth service as of March 2020 or the onset of COVID. And then we can talk a little bit about their attitudes and experience. My members specifically from my 24 counties were asked after COVID-19, how would you like to receive services for yourself or a family member? 43% said they would like to receive services through a blend of in-person and telehealth. 39% said they would like to receive services only in person, and 18% said they would receive services only through telehealth. So again, while it is a solution, it's not the solution. The other barrier that we run into with telehealth is rural broadband access in many of my counties. And when the public health emergency started and there was an increase in telehealth, we set about looking at what is the broadband issue. And we did find that there is some research that was done in Pennsylvania through Penn State University, where they went out and did actual speed tests to do the experience on the ground. So they looked at what the telecommunications companies said their speeds were, and then they went and tested it. And oftentimes, unfortunately, those tests did not meet what they advertise as their speeds. The other barrier we have around the rural broadband and the use of telehealth is that in probably a decade ago, the federal government did some access and expansion of access to high-speed internet in rural areas. And when they put out a request for proposals, only the satellite telecom companies responded. So we did not get our Xfinities, we did not get any of those broadband providers that are on the ground in many of our communities willing to expand. We got satellite. And so they went with that and they did subsidies. And now some of the new funds that came out during the public health emergency were not able to be used in any area where those broadband satellite subsidies were being paid. So again, we kind of struck out there, but we'll keep pushing that. The other thing that we're seeing as the biggest challenge, the lack of or limited internet, 43% of our respondents said that, and a lack of audio video capable devices. Those are the barriers now to telehealth. They did say it alleviated some of the challenges around transportation, obviously, both access to transportation and travel time and distance. Other challenges for us now, it's been talked about, I think, all morning, is the provider workforce and staffing issues that we're all experiencing across the state. There have been multiple surveys done to try to collect data around what the provider workforce struggles are with agencies. We had providers that we were helping through the public health emergency with some alternative payment arrangements to subsidize so that we could keep them afloat and keep their doors open during the public health emergency. And when we were looking to end those alternative payment arrangements, we reached out to a group of our providers still receiving them to talk about, can we do a meaningful data collection process so we can really get to the bottom of what are the struggles with the workforce. And many of them were willing to do that. They were willing to come to the table, and they were willing to develop a measurement tool and a data collection process, and then provide us data on a quarterly basis. So the first data collection that we did a look back for the entire year of 2021. It was a heavy lift for many of our providers, but again, they were willing to do it as they had helped develop the tool and understood that these outcomes would be used for measures and to bring funding to the table to support them.
Thank you, Sally. Perfect.
You're welcome. I do have data, so if anyone wants data afterward, I can share some of the data we have on our providers and their current status.
Okay. And finally, Dr. Solomon, to talk a little bit about substance use treatment.
Yeah, pleasure to be here today. It's a very special topic. We are certainly in a crisis, and I like the word that Dr. Miller used today, crisitunity. So I'm going to play on that word because I think it's very meaningful. We know that in 2021, there were 100,000 100,000 overdose deaths, more than ever on record before. Opioid overdose deaths topped 80,000. Stimulant deaths are also on the rise. Pennsylvania alone saw 5,400 overdose deaths, and Pennsylvania, unfortunately, is third in the nation. We have the dubious distinction of being between number 3 and number 6, and in 2021, we are at number 3. Very, very frightening. The rate of overdoses is rising nationally in Blacks and Indigenous people, and Philadelphia, unfortunately, is seeing the same trend, rising rates. Tobacco remains the leading cause of preventable death. Does anyone in the audience know how many deaths come from tobacco use in this country? Correct. Isn't that startling that we do so poorly with tobacco cessation? Almost 500,000 deaths from tobacco. On average, 10% of individuals with a substance use disorder receive treatment, 10%, 1 in 10. 10% of US physicians have an X waiver. Everyone knows what the X waiver is. It allows one to prescribe buprenorphine. 11,000 APPs have an X waiver. About 50% of the X waivered physicians actually use their waiver. And that is also true in rural areas. 35% of patients live in rural areas where there is no X waivered provider, so they have no access to buprenorphine. Pennsylvania, as we know, is very rural. I drove to Gettysburg last weekend for a Psychiatric Society retreat, and wow, it's beautiful, but very, very rural. We also know that there are disparities in terms of MOUD, that's medication for opioid use disorder. There's a nice study out of the Columbia School of Public Health where they looked at the NUSDA data, that's NSDUH from 2019. They looked at patients who would benefit from receiving medication for opioid use disorder. About 28% received medication, which is the most efficacious treatment. Over counseling, over psychotherapy, medication is it. Medication is life-saving for opioid use disorder in particular, unlike other substance use disorders. 30% of whites receive medication for opioid use disorder, 20% of Blacks, and 15% Hispanic. I'm using Hispanic because that's the term from the literature. So in this crisis, how can we best address the steps to take to fix this? And we know that fixing something takes many steps and a brain trust. We know what hasn't worked. Increasing the number of X-waivered providers in this country has not worked. We're up to about 100,000 from 50,000 in 2018. It hasn't helped the opioid overdose crisis. I'm going to tell you about 2 innovative programs in Pennsylvania that have worked. And I'm curious, is anyone in the audience from DDAP? Anyone here from Bureau of Drug and Alcohol Programs? Nope, okay. They've done some great work. So I'll start with the RAMP program, Project RAMP. Anyone familiar with Project RAMP? rural access to medication-assisted treatment in Pennsylvania, funded by the Agency for Healthcare Research and Quality. And Pennsylvania, because of the high overdose rate, was one of the five states picked for this project. As I said, 35% of Americans live in rural areas with no access. So again, this project was to expand access to medication-assisted treatment, namely medication for opioid use disorder in rural Pennsylvania. A chronic care model was used. Implementation teams from both UPMC, the School of Pharmacy, the University of Utah, DDAP was involved, care managers from the Centers of Excellence in Pennsylvania, and of course, primary care practices. The goal was to get medication for opioid use disorder out to 23 rural counties. 1 minute. And guess what? It worked. The project recruited sites from 2016 to 2019. The project has been expanded. It has been taken over by SAMHSA now and the University of Pittsburgh through their School of Pharmacy. And I want to report that as of 2021, more than 35 patients have been treated. That's pretty amazing. So that is a story where an opportunity was taken, innovation was used, and patients were treated. Do I have time for one more?
I think we're over the limit, so
Got it.
it may come up that you can slip it in during our discussion.
Pennsylvania Espert, another success story. That's all I'll say.
Okay, great. You can say what Espert is in case people don't know.
Does anyone in the audience want to say what Espert is? This is supposed to be interactive.
We'll get.
Shoemaker?
I know what it is. I'm not counting. You should ask other people.
Anyone? Any brave soul? Screening, brief intervention, and referral to treatment. It gets patients at the beginning of the disease, not when they're already in the throes of a severe opioid use disorder.
Thank you so much. That was great. So we're going to open it up to questions now and get into a discussion. I'm going to attempt to decipher some of these index cards and see if I can relay this information to you. And first, for Anna and Kristen. Proposals are being made to explore new funding mechanisms for rural hospitals. Has any connection been made between this effort and the effort to fund rural crisis programs?
You have time.
No. Yeah, not in a concrete way. And the reason that I say that is these are community level services. So I don't know if some rural communities are looking at that. I know we've discussed internally areas where a rural hospital may have closed their emergency department or something else, that those might be sites that a county would explore, perhaps utilizing as a walk-in center. Some of the physical plant preferences for those walk-in centers are already in place there, but in a formal way. Dr. Dare, I don't know if you know of something I don't know of, but I figured I would at least look to you.
Maybe to bounce off that a little bit, is there a time frame for finalizing crisis regulations?
No. It is our top priority and it's a priority of the administration. But as we know, with all things regulatory, the internal review process often necessitates additional changes. We are working on it. We are working actively with our legal review around finalizing our internal review so they can go external. So it is not at all on the back burner, but I really hate to give target dates or ballpark dates just because it's a very unpredictable timeline. All I can say is it remains a top priority.
Hey, Wes, we have one for the chat. So Sierra has it.
Hi, it's Lisa Davis again from the Office of Rural Health. In 30 seconds or less, I can answer the first question that was asked about the new models for rural hospitals. There are two models that are out now. One is the outpatient emergency department that has been administered now by the Pennsylvania Department of Health, which looks at establishing a sort of a freestanding emergency department in areas that are rural that fall into a number of under a number of categories and guidelines. There's also a new model of care that's going to go into place on January 1st called the Rural Emergency Hospital, which is exactly what it sounds like. It is a hospital that meets a number of guidelines, that has an emergency department, no inpatient beds, some ancillary services, and is required to be connected up to other systems of care. So these, we really don't have a sense yet of how many of either one of those options we will have here in Pennsylvania. These do offer opportunities for at least triage and transfer of individuals who might be having some mental health issues or be feeling suicidal or anything along those lines. So thank you so much for letting me answer that question. And Kristen, sorry to have sort of interceded there. I think it was directed toward you.
You know what, I'm going to invite people who are writing on these index cards to actually ask the question, because it's a little bit difficult to figure out what they are. But, you know, while we're waiting for folks to volunteer to do that, just a general question for everybody. And I think, you know, we're really experiencing all kinds of issues with access. And what are the most significant barriers to expansion of access and population health in your minds? And, you know, what kinds of things can we do to address those?
Yeah, I'll take that first. I think that to implement any change, there has to be a system transformation model put in, meaning that if you want to expand medication for opioid use disorder in rural areas, you're not going to just take 10 primary care providers or 10 NPs and train them in the use of buprenorphine or naltrexone. There has to be an actual implementation model. There has to be help on the ground. There has to be an implementation team. There has to be ongoing coaching and mentorship, because people are very uncomfortable with change, especially when they're using a medication that they're not familiar with. Then there has to be data collection and a study done to see, was this an effective intervention?
What do you think's been in the way of that?
I think what was in the way that was thinking that we could solve things simply. There's an opioid epidemic, just train more prescribers. It's not going to happen. You have to train the whole office staff. Everyone has to be on board with the model. Everyone has to be treated with respect. They're part of the team.
So one response to that is adequate training and planning. Anything else that you guys, that comes to mind in terms of major obstacles to access?
I would say for behavioral health, it's not going to be shocking to anybody. It's access to adequate, sustainable funding. You know, we all know the story behind the base dollars. So there's hesitancy around, like, when you get federal dollars, it's wonderful, but we are sort of asking for a commitment on faith. You know, the federal government has committed to building out the crisis system of care. It is a federal priority, and they are being really clear that they are expecting states to mirror that priority. We are trying to do what we can to buy some time and use those resources to put in place a good plan to use to sell the concept of getting a sustained, specific funding stream. If we're able to do that and fund a crisis system, and by that I'm very specific because it was defined federally, our call centers, mobile response teams, and walk-in respite, then the dollars that are currently being used, at least in the public system side, the base dollars, we're using a large portion of those right now to support crisis services. If we're able to fund those with a dedicated funding stream, it frees up the base dollars for all of the other services that we need in place to, number one, help keep people stabilized and not come into crisis, but also to support them after they've been stabilized during a crisis. So it's really important that we find a way to advocate that this is an emergency response system that we lack and that we need, and that frankly, emergency rooms are not the right place for it without, they don't need to be, people don't need to be going to emergency departments for mental health care. We can provide that in another setting that's more cost efficient with the right professionals. And same thing for law enforcement. We know that law enforcement does not need to be involved in terms of a safety or community protection need in the vast majority of cases. So we've been using the wrong tools to try to fix the problem, and we have an opportunity now to do it right. But we need that sustained dedicated funding.
So training and funding and planning. And, you know, I think just to kind of make a link back to our previous session, how significant is workforce? And, you know, I think that one of the things that, you know, we have really experienced is difficulty in psychiatric services and psychiatric care. And, you know, are we able to meet the needs with our present workforce and the burnout and retirement of a lot of our practitioners? And how do we need to think about changing the constellation of providers that we have?
Tack onto that, to go back to Dr. Miller's presentation again, meet the people where they are. You know, those entry points into the system, primary care, emergency rooms, as you said, you know, we need to have people of all different training levels able to receive someone with a mental health crisis or just a need, and have everybody work at the top of their licensure to really maximize efficiency of resources. As far as integrated care, one barrier is about the financing, but it's about the billing codes, and use of medical insurance is amazing. It's really been a game changer to make this at all sustainable to do a collaborative care model, but it's somewhat cumbersome in its requirements that we have to prove in order to drop a bill. And so that's been one of our barriers to expansion. It's just the sheer infrastructure and overhead needed to like process that.
That's a great point, because I think administrative burden is what really kills a lot of our resources, our human resources.
I just want to add on that and say, you know, I think really coordination of care, integrated care, the whole person primary care is really the answer. And at the same time, we need to support the pipeline of students coming into the field, especially in social work. So, you know, there is no equivalent. I mean, as someone asked in the previous session, there is no equivalent of a residency in mental health care. And so what we've been doing at the Touchstone Foundation is you're really looking at other states and other models to replicate that and to establish what is in essence a residency. So we're funding a care coordination, this clinical supervision collaborative in Lancaster County, where we're actually funding 10 agencies and practices to provide clinical supervision, because it takes 3,000 to 4,000 hours of clinical supervision before an MSW graduate can sit for their licensing board exams. That's a huge barrier, especially when they're paying out of pocket for those clinical supervision hours. So, you know, I think there's a number of different opportunities that we could be looking at, but that workforce is the majority of the folks who are trying to enter the field, so that we can create this better coordination of care, this better integrated system. If we don't pay attention to who's entering, you know, the social work field, then, you know, then we're just kind of continually spinning our wheels in this medical model that we have. It really needs to be a more community-oriented approach.
And can I just respond? I would also identify regulatory barriers, and that we should not be pushing people out of the field.
Right.
And we did see this happen in some of our rural counties around the move from BHRS to IBHS, where there was no grandfathering. So we had individuals that worked 20 years in the field, had all that clinical experience, and because they didn't have a practicum, they no longer could provide that service. So I get a little apprehensive about when I look at the SAMHSA toolkit around the requirements for staffing for crisis and think, before this happens, we have a staffing crisis going on, right? A shortage of people entering the field, shortage of people staying in the field. I have providers that went from having 87% of their positions staffed to now in a year having 77% of their positions staffed, right? 10% drop. So I really think it behooves us to think about regulations and to think about what it means to have a skilled and credentialed workforce. And it isn't always about where you came from out of college or what you did there. It's also about years experience, grandfathering people in, providing avenues for people to advance in their careers. We long advocated for career ladder for peers through train the trainer programs for the initial peer training. I mean, there are a lot of opportunities, I think, for us to utilize the staff resource we have now in a different way and in a better way. And we do have a PR problem. It was said this morning, there's definitely a PR problem. I think the young kids coming out of college now are some of the most altruistic as a group that we've ever seen, as a generation. And we have a field where you can spend your life and have the reward of helping others, and we don't marry with them. So there is definitely a PR problem in the behavioral health field. There's definitely a lack of us being able to communicate the rewards and the benefits of serving individuals with behavioral health disorders and seeing those people reach their full potential in their recovery.
So I want to kick it back to our audience. I think we have some people waiting to make some comments.
Hi, everyone. I'm Marcia, and being a resident physician in psychiatry, though I'm growing and I'm new, I was able to appreciate a few things I was observing, and my question was actually kind of just answered a while ago pertaining to emergency medical services and being able to expand on that. So what I want to ask is, how do we address acute inpatient rehabilitation of our psychiatric patient population, and probably future crisis centers having used that as a form of regular mental health care versus, at an acute stage, versus being able to support them before that and during that. And I guess that also goes back to the preventative care. But in vulnerable communities, we do notice that by the time they reach to us, it's either going to be in our future crisis centers, which is going to take the burden off of emergency rooms. And after we rehabilitate them, they go back into the same stressors, outpatient, which are numerous, whether it's homelessness or a financial housing. And I know this is a deeper discussion, but it's just something that I'm very passionate about, and having to reach a point of emergency mental health care and how we can really help patients, especially in the vulnerable at-risk communities. So that was very important.
Do you feel like you had enough information that question has been answered? Okay.
Yeah, other people have put, I thought you had questions. Sorry, I'm getting there. I thought Ken had a comment.
Okay, going to the funding of crisis. Kristen, I know you touched on some of it. We know in Montgomery County, we see a pretty high number of individuals accessing our crisis services that have commercial insurance coverage that is not being funded by commercial insurance. That's one piece of a funding that is untapped. The second, the funding that you have talked about, I think the furthest out it can go is what Dr. Adair referred to with 100 million as being 2026. I'm concerned from a county perspective, convincing our commissioners and the powers that we need to invest and build a crisis response center, for one. That's a big endeavor when I have no guarantee of funding beyond 2020?
So a couple thoughts. You're correct about the commercial insurance, and I think that's something we've been talking to the federal government about. I know even when we've had meetings with the Secretary of HHS and the head of SAMHSA, we bring this up, that we really need some federal guidance and pressure around the commercial insurance industry to do their part. Even with the work that we've done at the state level with the Pennsylvania Insurance Department to try to share those billing codes, that only touches on a very, very small number of insurers. So the commercial piece is a much larger conundrum, and one that I think we need some federal advocacy around changing the tide there. I don't want to leave out of the funding picture the Medicaid rates, which will be significantly increased to support the funding of services. So it's not all grants and public dollars and what have you. We've been working on those rates, and similar to what had to happen with the implementation of the ASAM standards, recognizing that some of the higher credential requirements and those things will require a different pay scale. And so we're doing a lot of work around that. And also considering how to ensure that the payments get to the providers, in that emergent situation. So that is part of the picture. In terms of how do we talk to our county commissioners about it? I mean, the reality is we're paying for it in one place or another. We're paying for it in our jails. We're paying for it in repeat people coming through emergency departments, through our jails, through our homeless shelters, through all the other publicly funded programs. So I don't mean to sound trite, because I know that's not an argument that elected officials always want to hear and buy into, but it is the reality. And we are, talking with PCCD and working with the Mental Health and Justice Advisory Committee in Pennsylvania about how all these things intersect, and that the ideal situation is that we're not jailing people, because we know what's happening now. People are going to emergency departments where they've closed their psychiatric care services because they haven't been lucrative. We don't have good care on site, and people are sitting for several days waiting for something in a workforce crisis, et cetera. And then they act out, and then they end up being arrested, and now they're in the forensic side of things. That's just a perfect storm. So I think we need to really talk about investing into the service line, because it's an investment into the community.
And during this period of time, I think it's also wise to invest in the staffing crisis.
Absolutely.
It's the nursing alone. We can't compete with the hospital systems that are now offering $30,000 for a sign-on bonus in the Southeast. We just can't compete with that. And the newest release in talking about crisis, but the state has indicated the need for the licensed bachelor social work level to approve the release of a mobile team. That credentialed staff does not exist.
It doesn't, which is why we're talking about it now. Because
Not
it's-
licensed, right.
Yeah, and I want to be clear that it's not a state requirement, it's a CMS requirement. And so we are trying to give as much forewarning as possible, because with some of the workforce support payments that are becoming available, if employers see the opportunity to pay for one of their bachelor level social workers to sit for the exam, it's not very expensive, nor is it terribly cumbersome from what we've been told, in return for, an agreement to stay on board for X number of months or years. That won't be in our regulations. It's already a CMS requirement, but it's not in our regulations until they're finalized. So we're trying to give people the opportunity to plant those seeds, utilize some of the workforce support funding opportunities that are out there, and see, can we help people achieve that licensure, so that we're in a better place
Right.
when the regs are
And
in
I'm
place.
just suggesting that maybe there's a way you can help support it at the state level. And that's a perfect example of also requiring the supervision and affording that ability to put out to providers to pay for.
Thank you for the excellent presentation. A couple more questions around the crisis services, one thought and around funding. Arizona uses a braided funding mechanism, which no doubt you're aware of, and somehow I believe has been successful in convincing their commercial insurers to participate in that. That might be a model to look at. That's just a comment. Question. One of my concerns, so in my role within the city of Philadelphia, my team is tasked with implementing 988. I mean, obviously with involvement of many other teams and programs and stakeholders across the city. One of my concerns is we've already seen about a 20% jump in our call volume, and this is over the last about 18 months. Some of those individuals, and that's not including the increase in mobile team deployments that we've seen, which is about somewhere between 12 and 18%, depending on the month. Ultimately, this will result in more inflow into our mental health system, which I presume many of those individuals will then be served or need to be served at some level of care, preferably the mental health outpatient system or network. My concern is that I don't believe that network is strong enough right now to absorb that extra flow. So just implementing 988 is a huge task, no taking away from that. But I just want to put it on the table for discussion, or at least for consideration, that we will need to think about that sooner than later. My personal projections are that we have maybe a 1.5 to 2 years before we start seeing that impact. That's not based on data, that's just my sense of it. One idea, and it's just an idea, Dr. Adair has heard this ad nauseum from me by now, but one idea is to consider the revamping the CCBH model in Philadelphia, in Pennsylvania. I know we were a demonstration state and did it successfully. I wonder whether it's a model that can help with some of this added flow. So that's one question and thought. The other relates to the comment about substance abuse. And again, in this arena, we're certainly seeing a spike across the city of Philadelphia, and I think it's consistent with trends across the country. Stimulant abuse has really seen a resurgence. Question, there have been conversations with CMS, I know, and with DDAP about contingency management. Has there been any progress along those lines, actually funding it under Medicaid or in some other mechanism?
May I say one thing? It's an evidence-based treatment for stimulant use disorder. Do folks know what that is? Contingency management? It's a psychosocial treatment. It does not use medication. Patients will come in to see the provider, generally a social worker, psychologist, anyone else on the substance use team. They will submit a urine. There'll be point of care testing at the time of the visit. If the urine is negative, the patient gets to draw from a fishbowl or something like that, gets a coupon worth money to be used generally in the hospital or the setting in which they are. It's evidence-based. It's one of the best treatments around. There is no medication FDA approved for stimulant use disorder, just so people know that. I think that is a fabulous question. I wonder why it's not being funded. Thank you.
I don't have a good answer for that. I know we've had at least one meeting about the treatment, but in terms of CMS and where they are and covering it in our state plan, I would really have to go back and talk to the Office of Medical Assistance Programs and others to see if we need to do more coordination on that.
One suggested, Dr. DeFilippis, who's at the VA, but also consults at other facilities, is a fabulous resource. He is the absolute guru in contingency management and recently presented at the American Psychiatric Association conference.
And I will let you have the last word. I know you.
I absolutely agree. I would love to see the CCBHC model revamped. But on a county level, in Lancaster County, we for years have been running a mental health copay assistance program. And what we see in that population, it's really supporting families who have commercial insurance but can't afford their copays. So if we look at the upstream prevention, it's really the access to care is the cost of the copays for these families who are making 250% of federal poverty, 65,000 for a year for a family of four. They don't qualify for Medicaid. If they did qualify for Medicaid, maybe that's an answer, but our agencies who accept Medicaid can't take them because we have workforce shortages. And meanwhile, the commercial payers, families are really struggling to pay these copays. So we try to subsidize that in our office. Last year, we saw a 75% increase in demands for copay assistance. Connell O'Brien's on our board chair, and he could attest to the challenge that posed for us as an organization to fund. But that's really, I think, at the crux of the issue is families can't afford the copay to be able to see a provider.
So we have identified some great challenges to access, and thank you all for your input and comments. And I think we are ready to break for lunch. Yeah. Thank you so much.
We are not slowing down here, although I think lunch is outside. I'm going to encourage people to stay here for a few minutes. We have something we need to take care of before people leave, and then we're going to have Representative Schlossberg is going to speak with us. So somehow in between that, we're going to have to figure out how to get people out of here to go get lunch, and we will do that in a second. First, I want to say. The last comments were really struck home to me. I have a patient right now who's desperately in need of therapy, and the copay is $40 a show, and he just cannot afford it. He's got private insurance, and there's no way that he can afford it. And the Medicaid, the community mental health center that I have has no way to sponsor him. So we're sitting here trying to take care of him, and we can't. We actually can't do it. So it's going to be a bad outcome. I'm really worried. So. Thank you for raising that and keeping the fight going there. You've heard this morning a lot of the challenges that we face, and I want to just point out that it really maps along with the Biden mental health crisis, which, as you've heard me say, I think this is not a crisis. I think we're underselling it. We have an emergency, and we need to talk about it that way. But we are talking about the things that the Biden mental health plan sort of that outlines. We followed that outline fairly closely, and that means that the things that you've been hearing about are the topics that are coming up across the nation, and they are the things that we see this state really taking on in the next bit of time. We're doing that, however, in the absence of David Dinich. And I want to take a moment to just say a few things about David. Now, I recognize that many of you have questions about David and want to know answers from David about all kinds of stuff. We have index cards. Any question you want to ask David, please, especially about all the terrible things he did as a child. Those are the things that we're most interested in discovering. So please, if you've got questions, fill out the index card. And we are here to honor David because David is really the father of the PPLC and of initiatives around the state to really do to bring Pennsylvania into the modern era and maybe the future around mental health services and how we provide for the people of Pennsylvania. He's the man who taught me to be a Pennsylvanian. That's actually the truth. I've always been a Pittsburgher, but now I'm a Pennsylvanian. And but in honoring David, it would be really wrong not to make a couple comments about people who are not here or are here and will no longer be coming to PPLCs unless they feel like it. And that is just to note, in the last 2.5 years, we've lost some really meaningful people in the PPLC, particularly some people I'm sure here will remember Larry Reel and also Trevor Hadley, very important folks. So we're going through a process of change. We've been on a process of change. It's been particularly significant in the last 2.5 years. Now we have a lot of folks who've also stepped away, including Estelle Richmond, who's the mother of the PPLC, I guess we can say, and also Jim Feltz, Bob Marin, Rick Seeger, who's joined us here. Where's Rick? He's here, isn't he? Did he step out? Well, you can tell him I said his name. He might have left already. Connell O'Brien is here, and Peggy Chapman. Somebody who's not able to be here, but we're thinking about is Rick Silber. It's those folks and the rest of us in this room who really have made the PPLC, and it's David who has made us. And if you look around this room, what you see is the product of just some small part of his effort. One of the things that's especially encouraging is that we're seeing an increased amount of diversity of all kinds of people in this room, and we're going to continue that. That is not going to stop. We are going to bring every kind of face of Pennsylvania into this room, into this process. That's what the PPLC is about, because that's what David told us we're about. So we are the people here, and I think there's really no greater honor for David than to note who he has brought together and to recognize that, because I know that's what really matters to David. Now, I want to say a word about David in particular. He started in a small town called Jonesville. And then he went over the mountain and ended up in Pottsville. In the process, he married Carol, who was right there in front of him. And they had a daughter. And David has committed, with their help, and I'm told firm correction, he has committed his career to advancing the cause of mental health and mental health services, mental health care in the state of Pennsylvania for many years. And when he charged us with doing this conference and then said, oh, by the way, I'm retiring in a month, we all said, oh, of course, we'll do that. I don't know, David, you don't remember this. I remember meeting you. The first time I met you was when you were coming through Pittsburgh as a head of NAMI, which would have been sometime in the middle 90s, maybe early 90s. And we met at WQED in Pittsburgh. And Lauren, you were there. I know you were there. And I eventually ended up in David's circle more profoundly when the PPLC came into existence. And that was partly a little bit of prompting by me to Estelle Richmond that we were in desperate trouble in terms of making sure that there were going to be good, committed public service psychiatrists in the state of Pennsylvania, unless we figured out how to fund them in the academic health centers and medical centers that were training psychiatrists at that time. And we were wildly successful. Estelle got David involved, and the rest of it, I don't really know how the hell they did it, but they made it happen. David is much loved. He's the head of all kinds of, he was the head of all kinds of acronyms like FTAC and PPMH. Can remember. And he is notorious for being an incredibly good boss and an extraordinary human being. And I have to say, I think of David as the most, there's a word I learned to talk about David, the most avuncular man that I know. You are an uncle to everybody, and a good uncle, and a man who has put his heart and soul into the work. And I think, and just inspired all of us, every person I've talked to about this, even the ones who know very deep secrets about you, including your wife. Everybody, by the way, has been totally willing to reveal all the terrible secrets, but I'm not going to say a word about anything. Lloyd, who spent hours and hours with you in a car, I don't know how the hell. I don't know how the hell you survived, David, but that's a whole other story. It is just a treat to recognize you and your efforts to make us be who we are. And I'm just thrilled to have had the opportunity personally to have gotten to work with you. And I hope somehow or other we can keep you giving us good advice and pointing us in the right direction when we need it. And we have some awards of sorts to give to you. And the first one will go, I think probably the first one ought to be from Val. Val, do you want to present this to David? David, why don't you come on up? Carol, he may need some help carrying some stuff if you're willing to come up as well. Do you want to say a word to him?
Sure. So when we were discussing what we should get for you, Ken wanted to make sure we got you something Pennsylvania related. And because you love breakfast so much, this is a breakfast sampler from across the state of Pennsylvania for you. So you can get a little bit of Philadelphia and a little bit of Allegheny County and a little bit of York County and all kinds of.
Scrapple in there?
Yes, of course.
Yes,
there's Scrapple.
great. Can't you smell it?
So that'll be for you. I'll hold that for now. But we also wanted to make sure that you had a keepsake. And the inscription says, a genuine leader is not a searcher for consensus, but a molder of consensus. That was said by Dr. Martin Luther King Jr. And thank you for your years of your decades of vision and genuine leadership. All the best to you in your retirement. With gratitude, the PPLC.
Thank you.
But there's more. Wait.
There's more.
Wait, there's more.
I heard that before. Okay.
Go ahead, Mary.
Okay, so I had the wonderful opportunity this summer to travel to Scotland with a stopover in London, but Scotland was amazing. And with the announcement of David's retirement, I had someone named Ken whispering in my ear, I must get something special from Scotland for David. And so we've got a bottle of, you can only get it in Scotland, brought across the pond for him. And it's a Dalwhinnie Estate bottle of Scotch whiskey.
Oh, great.
It's all wrapped up. So
Oh,
I
it's all
did it,
wrapped
it's
up,
all
okay.
wrapped up for transport.
Yes. Thank you.
So.
Oh, that is going to be so good.
Yes.
Oh, my goodness. I love it. I love it. Thank you. Thank you.
So I'm going to ask, I'm going to say if people would like to go to get something to eat, please say, we're going to have David get in a reception line right here, and you can say hello to him. But I would like just one photograph of somebody for my scrapbook. Would somebody please take a photograph of me and David? Has anybody got a camera there? Thank you guys so much. All right, David, you're going to go stand over here. People
All right.
can say something to you.
Okay, you put this, thank you. Those words are coming. Thank you.
It's good to see you.
It's great. Oh, okay.
All right.
You want me to go? You want me to just start or do you? All right. Sarah, are the Zoom people back? Okay. I think most people are seated, so I know we're a little behind schedule, and I don't want to mess up the opportunity that we have with Mike Schlossberg, and I think I have to pull that back down. That's the rest of the schedule when I get back to my seat. But we have the pleasure of having, I have to watch, I have to be respectable because I know him as a friend, so I don't always call him his, all that he's, the Honorable Mike Schlossberg. He is, oh, there I am. He is a member of the state legislature house. He was elected for his 5th term just this past November, 2020, and he's continuing his commitment to community leadership. I'll read off this even though I know what I want to say. For the last session, he was elected Democratic Caucus Administrator. To address Pennsylvania's mental health crisis, he created an agenda called Hope for PA this year, and it would invest $100 million, yes, $100 million, which we want to spend all of it if we can, in public safety, safe and healthy communities, and improving areas by addressing provider and capacity and helping more people through training, education, and outreach. Shortly after he received the money, or I shouldn't say received the money, he asked for the money. The governor's budget was passed and also approved additional $100 million for care in Pennsylvania, especially mental health care. So Representative Schlossberg was then appointed to, people call it the commission. There's a little question about what's the real name of it. It's the Behavioral Health Commission for Adult mental health. And he is also the co-chair and founder of the Mental Health Caucus in Pennsylvania. And he has been working to focus other members of the state legislature in issues related to mental health and substance use. He also is a member of what Deputy Secretary Hauser talked about, the PCCD, or Pennsylvania Commission on Crime and Delinquencies Mental Health Justice Advisory Committee. And also he has received a whole lot of awards, but the most important one that some people may know is that he won a couple years ago the Philadelphia Psychiatric Society Benjamin Rush Award, of which our Dave Dinich did as well. So, and I was fortunate then to introduce him as well. So it's hard for me to just talk for a little bit of time about Mike. He puts his money where his mouth is, and Mike is, well, he's just wonderful. So he does represent the Allentown area, but he does really represent all of us. So he has a lot to say, and he walks the walk and talks the talk. So it's my pleasure to introduce my friend Mike Schlossberg.
Thank you, Deb, for that lovely introduction, and good afternoon, everyone. Well, what I've always found when I give speeches like this is they always work better if I talk for a few minutes and then more than anything else, turn it over to all of you for questions. As a member of the legislature, that often makes me very popular or very unpopular, depending on the audience. So I'm happy to engage in a dialogue. I think that would be more beneficial. And let me add, I actually hate when my bio is read at events, but there's one thing that I need to add because I hope it'll give a little bit of perspective and context about why I talk so often about mental health. Usually when I speak about it, I begin my speeches with my own experience because like so many of you in this room, I do have lived experience, having suffered from depression, anxiety, and suicidal ideation at various points of my life. It's an issue that's deeply important to me. It's one I never really hit it per se, but I only started talking about it in the aftermath of the suicide of Robin Williams when I found that there was a real need to try to destigmatize and personalize the conversation. And being an elected official who has spoken about their own experiences with mental illness has been, I hope it's helped to push the conversation forward. And I will certainly add that in the time that I've been doing it, forget the me part of it, but there's really a noticeable change in how people talk about mental health and mental illness. And while it's not gone, it's been kind of nice to see stigma fall by the wayside, especially among younger generations. And listening to them talk about mental health and listening to the way that they very casually mention therapy appointments or anti-anxiety pills or something like that gives me hope for the future that by the time this generation becomes adults, we will talk about mental illness and stigma in a very different way. From a public policy perspective, I see stigma all the time, and not in the like, oh, you're crazy, wow, but more in the sense that mental illness is not given the same emphasis as physical illness and as physical health. And you see that in things like conversations around parity or a lack of comparable reimbursement rates for psychologists or psychiatrists or social workers that deal directly in mental health. That's where you do see the stigma. And I hope that the work that I've been doing with all of you and with many others can help to change that conversation so that we adequately fund mental health, especially as we have conversations about workforce. So let me talk about a little bit about some of the things that we're working on. As Deb was kind enough to say, the most important thing from a behavioral health perspective that we've got going in the state right now is the Behavioral Health Commission on Adult Mental Health, or the Adult Mental Health Commission on Behavioral Health. It's one of the two, I don't remember. We did some good work. So we had a very good, typically, as you all know, behavioral health and mental health is like the first thing to meet the chopping block, right? And in fact, in the 2012-2013 budget, we lost $81 million to county behavioral health, money that has still not been replaced. We actually thought we were going to get 30% of it back this budget, and it fell away at the last second, and I couldn't even begin to tell you why. It's very disappointing. So this budget, unlike every other budget that I've been dealing with, actually had a surplus, and not just a small surplus, but a very significant one. In my capacity as chair of the Mental Health Caucus in the House, I've definitely seen an increasing bipartisan conversation around mental health and around behavioral health, and that's been great. Previously, I think too often it had fallen along partisan lines with maybe Democrats paying more attention to it than Republicans, but that's definitely changed. And I think a big part of the driver for that has not only been just reality, but it's also been COVID. A lot of my Republican colleagues have been seeing the exact same strains that we've been complaining about for a long time. And in fact, in rural areas, Republicans and their members have it much worse because the rural health crisis, the rural mental health crisis is much worse than an urban or a suburban one. Not that any of us who have urban or suburban areas are, swimming in practitioners and have appointments to spare, but in rural Pennsylvania, they have higher rates of addiction, mental illness, and suicide. And that's driven by a lot of factors, including, I would argue, largely social determinants of health. They have worse performing economies. They have less access to behavioral health care. They have less telemedicine options because they don't have rural broadband. And my rural colleagues have really seen this. So with that in mind and with the surplus in mind, I propose what we call the Hope for PA plan, which was $100 million in recurring revenue. And that's the magic number, $100 million in recurring revenue so that we could repeatedly fund mental health year after year. The plan got some traction. I put it forward as part of the budget, gave it to all the folks who were involved in the conversation, and we didn't quite get that. So I had $100 million in behavioral health that would be spent in a certain prescribed amount of ways. What we got was $100 million in one-time funding. Big difference. Because in one-time funding, you could use that money once for startup costs or for grants or something like that, and then the next year it's gone. Recurring revenue would have been nicer. That would have meant it would have been in the budget for good. But one-time money and $100 million is better than nothing. And in fact, it can actually be pretty substantial if we use it right. It wasn't spent how I wanted either, and I would definitely argue that that's been a good thing. Instead, we put together the Behavioral Health Commission, which is 24 members, including 4 members, where with 4 legislative appointments, I'm the House Democratic appointment. House Republicans appointed Representative Wendy Thomas. Senate Democrats appointed Senator Marie Collette, and the Senate Republicans appointed a doctor, actually, whose name escapes me at the moment. That commission, is, you've probably heard, has been meeting. We've had 4 meetings. A report should be out shortly, and you'll get the opportunity to see that. That report then has to be folded in as a piece of legislation. We have enough time to get it done by November 30th. It is admittedly going to be very, very close, and I'm hoping that we can finish that. We can do it. It's just tight. The good news is that wasn't the only money in the budget for behavioral health. We also put $100 million in the budget for school-aged mental health needs that will go through school districts. It also comes with a lot of flexibility, so the school districts can do quite a bit with it. They can use it to hire psychologists, to make appointments with outpatient facilities off of their campuses. And again, I'd really argue that's a good thing, because we've seen obviously rates of mental illness are rising across the board, but their increases have been sharpest among young adults. So I'm grateful we were able to do that. Is it enough? No. Only in public policy can you say $200 million isn't nearly enough, but the truth is it's a drop in the bucket, comparatively speaking, compared to what we really need. The other big mental health thing that we have going on is 988, which I'm sure has been the topic of conversations throughout the day. As all of you know, I'm sure we switched to the 988 crisis hotline as opposed to dialing the number. The federal legislation allows us to levy a fee in order to better fund crisis operations and mobile crisis care. We haven't done that yet. This is just me talking here. I think we need to tamper our expectations for what we're actually going to be able to do. Pennsylvania is a notoriously tax and fee adverse state. About 6 or 7 years ago, we did increase the 911 fee on cell phones and on landlines. I am not optimistic that we're going to be able to get any sort of real tax, especially the way other states like Colorado or Washington have done. I know the Wolf administration asked for, I think they asked for $1.25 per month per line, per month per phone tax. And I can almost definitively say that won't happen in this legislature. I'd like to get something, and we need to get something. And frankly, I wish we were a little further down that path, but hopefully in the next legislation, we can get somewhere. So like I said, I can keep talking, but usually people don't like that. So at this point, I am happy to shut up and answer questions. I think that's usually useful as we go here. So if anyone has any questions for me about the legislative process, anything going on in Harrisburg, a couple of feet away, I'm more than happy to answer. And you folks out microphone, there we are.
Does this work? Yeah. Hi. I was wondering if there's been any talk about increasing funding for structured housing, particularly for people with severe mental illness. From the inpatient unit, that's one of the biggest blocks we have. And so it just becomes a repeating cycle of wherever they go, they come back to inpatient.
Would that flow through the counties?
I don't know.
I think it will. So if I'm not mistaken, funding for programs like that usually goes through counties, and then the counties will contract with outside vendors to make that happen. There was a conversation about that, and it fell away at the last second for reasons I'm still not entirely sure of. The biggest thing that we have consistently screwed up over the past decade in the legislature is not restoring county funding. So again, we cut $81 million, and I shouldn't say we, because first of all, I wasn't here, and second of all, I had nothing to do with it. But the legislature and the former governor, Governor Corbett, cut $81 million from county assistance for homelessness, drug and alcohol, substance abuse, and mental health. And that money hasn't been restored yet, with the exception of certain limited line items. I think there was some money that went back into mental health, but there hasn't been a specific conversation around that item. No, it's one of many, many areas where we desperately need to restore funding. Thank you.
Shocking, Lloyd has a question, Mike. Actually, 2 questions. How much does the $100 million in the funding of the commission's recommendations, is that likely to cause less attention on the part of your across the aisle representatives and senators toward mental health going into the near future?
That's a great question. What I will say, is it possible? Yes. What I will say is the entire conversation around people who are on the commission, as well as especially myself and Representative Thomas, has been the number one goal of the commission needs to be to help people, right? But the number two goal needs to be to structure the funding in such a way that it builds political pressure to increase recurring funding. Because if we don't do that, then we can do some good, but not nearly enough. So that's the best thing that I can tell you is that's in the report. That will be in the report. I know the report's also going to have a recommendations component, and that's hopefully going to be at the top of the report. Obviously, as you can imagine from 24 advocates, the commission is unified on the need to increase mental health funding year over year.
The other question is under the governor that I'll refer to as one-term Tom, we had a reduction in state taxes that was pretty significant, 4 billion if I'm not mistaken. This year, we had a reduction of the corporate income tax by what they like to call 1%, but in reality, it was 9.9 to start with. It's 8.9 now. Last time I checked, that's a 10% reduction in state tax. Is that recognized? And the plan is to continue that until it's a 50% reduction in about 8 years, when there would be a new governor elected. Just saying. Is that part of the discussion and recognition upon your colleagues within the House, which I think is going to retake the majority this year? Is that correct? Right.
I think the conversation around the corporate net income tax was actually and about the reduction specifically was by and large a unified one. And it was done. There's two things about the corporate net income tax. First, Pennsylvania's really was one of the either the highest or the second highest in the nation, depending on which specific tax you're looking at. But more importantly is that nobody was actually paying it by and large, because we have loopholes within our corporate tax system that a truck from Delaware can drive through. Emphasis on Delaware, because what would happen is people would register their corporations in Delaware and then do business in Pennsylvania. It's called the Delaware loophole. Portions of it were closed, not nearly enough, some would argue, myself included. It will result in the long term in a reduction in revenue. The theory, of course, being that by lowering our corporate net income tax, which, and I say this as a flamingly liberal Democrat, really was too high. You don't want to be the highest tax of anything in the nation. The hope is that we can do a better job of bringing new businesses in. And then that will, generate new revenue and jobs that can offset any of the revenue losses. Will it happen that way? No, but our tax revenues are in a relatively strong position right now. Income and sales taxes, which are the two biggest drivers of tax revenue in the state, have both been increasing pretty significantly year over year. And right now we are still running a surplus even compared to last year's numbers. Will that continue into the future? I don't know. Does the legislature have the ability to freeze the corporate net income tax phase out? Yes. And in fact, that's actually been done before. I don't remember the specific tax, but my first few years in the legislature, there was a tax, it was duplicative. And in years where we were really having a revenue problem, the phase out was freezed. Eventually it did go away completely, but that is something that can be part of the conversation. And in fact, that's usually why taxes have that year over year phase out, because it gives the legislature the ability to potentially freeze the phase out if needed, which we've done in the past. Who are you, sir? Ken and I have seen each other too much.
Hi, Representative Schlossberg. It's really just wonderful to have you here with us, and
It's good to see you in person as opposed to a Zoom.
Yeah,
this is different. Where's your dogs?
Just one.
Just
but
one.
he's very noisy.
Sounds like 6.
I wanted to ask your thoughts on, the role of an entity like the PPLC. So we're an organization of providers, of consumers, families, we're administrators, we're purchasers. We've tried to get everybody, all the stakeholders in the room, to pursue excellence in, community psychiatry and primary and whole person primary health services. What is the role that you would imagine? How can we work better to support the efforts that you're describing, that you're making, to help some of the colleagues that you've got in the legislature come around to understand the critical nature of the things that you're proposing? Are there specific messages or things that we could carry? Should we be going and talking to? I know you're going to say yes. talk to our reps and to our state senators, and, do you have any strategies for us to pursue to help support you in the work that you're doing?
I mean, the more advocacy, the better. And you should always talk to your reps and your senators. As a large group, and as frankly, a relatively prestigious group, your voice carries a little bit more weight than others. I'm going to say something that's a little bit counterintuitive. I think there is, whenever you meet with any organization, and I do this, I'm sure every member of the legislature does, you think, okay, well, how does this serve their own interests? Which is, and there's nothing wrong with that necessarily, but that's kind of always a thought. This is going to sound strange, but to an extent that you can advocate for things other than your own profession, but that still fall within the mental health field, I think that's impactful. For example, in this year's budget, the hospital associations, HAP, their biggest budget request was the increase of the county line item, because they recognize the downhill impact that had on their system. And to hear them say, we need you to fund something that won't directly wind up in our pockets, you go, oh, that's got some meaning. That's one tactic that I can think of. Beyond that, I would say not only should you advocate as a group, but all of you individually should advocate with your own individual representative and senator. Depending on the member, certainly it can be hard to get meetings, but at the representative level, we have the second biggest state legislature in the country for a reason. We should have time to meet with our constituents. So I would absolutely encourage you to meet with your representative and your senator if it's at all possible, to do so in a group, and to explain how the issues that you represent directly impact their constituents. I will say, and I always say this to groups, it depends on the member, certainly, but by and large, with a few exceptions, we don't care about things that are happening statewide. I don't care about the state. I care about the 132nd legislative district. I care about the 65,000 people that live in Allentown, South Whitehall, and Upper Macungie. So the more focused the information you can give is, the better. The more that you can show how if you increase funding by X, you will help Y amount of people in your district. I think there's a power to that. And there are some groups that do it so well, and that can be really difficult, I understand. And sometimes you have to talk statewide, but the more focused you can make it on somebody's district, the better, because we don't care about the state, we care about our districts. I just said something that's going to definitely be in the mailer soon. We don't care about the state. Brilliant.
And I had a question. My name is Nils Magnuson. Thank you for taking my question. Often the largest expense for rural outpatient clinics are healthcare costs. So on the revenue end, we're constantly being told there's no increases, reimbursement is low. Those often, I don't want to say the same insurers, but that same group, the outpatient clinics are being charged more and more for their own employees' healthcare costs. So it's like, well, which one is it? And how, if it's possible at all, how could the state, kind of help reduce those healthcare costs for the organization itself, for their employees? And like, if you're going to insure Pennsylvanians, you should have, some kind of balance to that versus one going up and the other one either going lower or never changing.
That's a great question. And I have to be honest, I don't have an answer. I know that there are some advocates that argue for a more robust government role in things like health insurance and price regulations. That's not going to happen in Pennsylvania anytime soon. Beyond that, the answer is probably to listen to you folks and try to find some efficiencies and cost reductions where we can. But I'll be honest, I've not been brought that specific question before, and I don't have an answer, but I'd be curious to have a longer conversation and try to find out more. Yeah, tax credits. Yeah, and that tax credits are typically an answer. And it's one of the few, it's one of the direct financial levers that we have. I have definitely found, and this commission has really helped to increase my perspective on this, that having conversations, having rural focused conversations is obviously important, but when you look at things statewide, the conversation shifts to underrepresented communities. That covers both Republicans and Democrats, because you say rural and then you also say communities of color, which typically more Republicans, and rural more Democrats and communities of color. That's something, and there's a tactical tip right there that I have really found, and this commission has really helped to further this idea, that rural Pennsylvania and communities of color in Pennsylvania have much more in common than I think any of them really would realize. Going once.
We have a couple more minutes if anybody has a question. If you want. Okay. I have a left field question. We have time.
We're going to be playing in the softball game tomorrow, so I love left field. And that reminds me, if you all want to laugh tomorrow, watch PCN at 5:30 because there's a legislative softball game. And we all look like jackasses. It's an amazing, more than usual. It's a really amazing experience. So it's for charity. Who knows? I don't, they're in my prayers. Usually it's Lisa Pascola, actually, now that I think about it.
You were talking earlier about sort of all this one-time money that's hanging around, and what are we going to do with it? No, I'm interested in health curriculum in schools, and I'm wondering if you guys are connecting with that at all, thinking about teaching basic mental health skills to students as a matter of routine.
It has come up repeatedly, and there's been legislation to try to, I believe there have been efforts to, on one hand, mandate it, and on the other hand, have the Department of Education create model curriculum. I might be mistaken, and if anybody in here knows better, please correct me, but I think model curriculum legislation actually did pass the House. I don't know if it's in the Senate. It has come up, though. It's definitely, there is an awareness of the need to do that. And I know a lot of school districts have started that conversation explicitly as well, but it'd be nice to see us do it at the state level, definitely.
It's true. I'm also going to make a plug just because I have you here that sex education is mental health education.
I'm with you. We do have a, yes. It's not a unified belief across the street.
Hi, I just wanted to know if you could comment on the collaborative care legislation that was introduced by Representative Thomas, and how that has gone, what the process was like, any objections, or how people responded.
I don't want to speak for Wendy here, but I did pay attention to that one. It did make it through committee unanimously. I thought it was still in the amendment process in the House, which probably means it's going to run out of time this session. I might be mistaken about that, but I think that's likely. The good news is that there's broad agreement about the concept and about the need to fund the concept. The bad news is, as always with legislation, the devil's in the details and the specific impact it would have. It was amended? All right, well, it was amended. No, I don't think so either. So I don't think it's going to pass this time. Ken, did I? Yeah.
I think you're right. At least as I understand, but we do have some money in the commission report going to this. So hopefully, if that doesn't get it started, this will be a seed money to make it start.
A good alternative. So I think we made a run at crisis care as well in lieu of a lack of dedicated funding stream for 988 right now as well. If there is nothing else, I'm always more than happy to talk. You can Google me and find me very easily. I also use Twitter way too much. So if any of you are on Twitter, please, I'm trying to be amusing. But other than that, and more than anything, thank you for what you do. My job in the legislature at a minimum is to not screw things up. And the better way to do this is to actually make your lives easier. So the more we can do that, the better. I will genuinely say, Republican or Democrat, the vast majority of us really do want to do good. And if you have ideas on how we can do better, please let us know. And thank you for what you all do. So have a wonderful day.
Yes, and I was going to say thanks for those of you who do not know, he really does. As chair of the caucus, he listens and he is very, very much in our corner. So I don't have my watch in front of me. Is it 1:30? Okay, 1:28 with 2 minutes to spare, Marianne. I'll put the slide up if you guys are about ready.
Okay, so everybody needs to stretch, stand up, wiggle around for the next line of work, which we have some wonderful speakers that will be presenting this afternoon. Okay. It is 1:30, and since we want to be really respectful of everybody's time, we're going to stay on track here. And I'd like to introduce our next speaker. As I said, we're going to have a series of presentations this afternoon and hopefully some opportunities for communication, discussion, conversation, good questions. We are going to be covering the LOCUS family of tools using the SMART assessment, thinking about innovation with workforce development, and then innovation, creating a healthy community with ICT. My first presenter is one of my mentors and colleagues, Dr. Sowers. He is clinical professor of psychiatry at University of Pittsburgh Medical Center, and he is the director of the Center for Public Service Psychiatry. And I've had the opportunity over many years to be able to see his work and to listen to the webinars and now be a part of the webinar series. So I very much appreciated that. And last year he presented LOCUS, and I thought, oh my goodness, this is an area that we need to get out to our residents across all 13 of our training programs, because it really helps us understand how we might utilize levels of care. I could present more about what he does. He's been very active in the American Association of Community Psychiatrists, as well as active involvement in leadership in the GAP programs. I'm not going to take any more time. I'm going to let him have his full time. And so Dr. Sowers, please help us understand more about LOCUS.
All right, so I'm going to see if we can kind of coordinate our slides. And so we have the first one up here. I'm going to try to read this from the computer. So anyway, I'm glad to be here to talk a little bit about some of the solutions, some of the more concrete solutions to many of the issues that we identified this morning. Right, and one of the factors that we didn't get into as much as we might have is just the difficulties presented by our systems of care. And, you know, a lot of the crisis that we face in terms of mental health is related to some of the chaos and discontinuity in our systems of care. And so part of what I would like to do is talk about movement towards a national standard for service intensity assessment and planning for mental health care and more judicious resource management. And a tool that's particularly well suited to help us in that endeavor is the level of care utilization system, or LOCUS, and the LOCUS family of tools. So why do we need, you know, a standardized process for service intensity assessment? We need a common language to enhance communication and collaboration among stakeholders, and that includes persons served, providers, payers, and population managers. We need to enhance our capacity to improve quality and to reduce the dysfunction and fragmentation that are part of our systems. We need to be better able to identify service gaps and improve our resource management. We have a ton of administrative waste, which, you know, kind of drains what we're able to apply towards treatment. And we identified in many cases this morning how funding is a major obstacle to many of the services that we need. And, you know, we really need to be able to emphasize quality rather than cost. So just to clarify a little bit about what we're talking about, service intensity assessment and management is the process of determining the correct amount and types of services and supports that best address an individual's needs at any given point in time. And that would consist of a structured method to assess an individual's current needs, a standard continuum of service intensity that consists of proper settings, clinical services, support services, intensity of program, and the expense of those services. And a standard method to match an individual's assessed need to a level of service intensity. So, if we look at the history of how decisions were made, we go back to the 1980s, and before that, it was essentially clinician-driven, primarily by MDs, and somewhat idiosyncratic. Everybody didn't necessarily consider the same factors. But this led in part, or at least part of what led to rising costs and questionable quality of care. Sometimes too much care, wasting resources, and sometimes too restrictive. So there was a great deal of inconsistency in service need determinations. There was a lack of integration between mental health, physical health, and addictions. And as we talked about, much fragmentation and discontinuity. And so part of the answer to at least the cost end of those difficulties was the emergence of managed care organizations to help manage resources more wisely. And they accomplished that in part through the development of medical necessity criteria. And the idea being to limit unnecessary services to control cost. So, that came about and progressed. And I think we may all have some frustrating stories about medical necessity criteria. And some of the problems that we encountered in trying to deal with medical necessity criteria was the fact that they were often very complex, cumbersome, and there were multiple versions. Every payer had a different set of criteria that they were using. And so it was really hard to be familiar with any one of them very easily. They weren't very flexible. They were focused on specific programming, often proprietary and difficult to access. They generally focused on acuity rather than long-term needs and recovery. They had a limited relationship to treatment planning. It was kind of a cookie cutter approach. Everybody got the same set of services if they were eligible. They lacked transparency. And so it was really difficult for people to understand why they were not getting or getting the specific services that they were offered. And, all of this led, I think, to an adversarial relationship between payers, providers, and persons being served. So, how do we get this back on the right track? How do we maximize the value of services? And by that, we mean the quality cost ratio. So we want to have the highest quality for the lowest cost possible. We want to be able to facilitate recovery and recovery-oriented care and develop integrated clinical processes. And so in response to this, the American Association for Community Psychiatry began to think about how to develop a process to improve some of these issues. And I was fortunate to be able to lead that effort. And we identified a set of principles that we would like to see incorporated into a resource management tool. And we did that by looking at a number of different criterion and trying to determine which qualities were most effective and efficient. And so we came up with these principles that there should be quantifiable dynamic dimensional ratings, integrated transdiagnostic criteria, that is the criteria that were independent of diagnosis. A tool should be easy to use and understand. It should be flexible and adaptable to a variety of situations. It should give reliable results. It should be reliably applied, I should say, and give valid results. And we wanted something that would be collaborative and empowering. So that would allow people being served to be involved in developing their assessment and their plan. And so that's how the LOCUS family of tools came into existence. They're instruments to assess intensity of service needs. They use 6 dimensions to characterize those needs and define 6 levels of service intensity. They use the ratings in the 6 dimensions to derive recommendations for service provision. And it's a method to create uniformity in decision-making, in the decision-making process. And a system that's clinically efficient assessment and placement into services. So I'm going to tell you a little bit more about these instruments. LOCUS, the adult version, was first released in 1996. And one of the qualities of this instrument is it has a unique set of service intensities or level of care definitions. It uses simple criteria sets that are reliably applied and that are easily understood so that consumers can participate in their own assessment. It's easily accessible and it's an intuitive process about our decision-making process and what we go through when we think about these decisions. It uses a decision tree to translate ratings into treatment recommendations that's computer friendly. And so this is often compatible with electronic medical records. Dimensional guidance for treatment planning. And so with those 6 dimensions, areas of greatest need can be identified. Aids recovery-oriented care by including and creating collaborative relationships between clinicians and persons being served. And it also has various value management functions that we'll talk about a little bit more. So to round out the LOCUS family of tools, the child and adolescent version was released in 2001. It was developed in partnership with the American Academy for Child and Adolescent Psychiatry. And for those between 6 and 18 years old, it uses the same structure and placement algorithm as the LOCUS, the adult LOCUS, and incorporates a systems of care perspective. The Early Childhood Service Intensity Instrument, or EXI, was also developed by ACAP for infants and children under 6. It follows the same principles as the parent tool, but a slightly different structure and placement process. So going into a little bit more detail, there are 6 dimensions for both LOCUS and CA LOCUS that are quantifiable and interactive. There's 6 levels of a resource continuum, and each level is characterized by 4 variables, which we'll be talking about a little bit more. There are specific but flexible definitions that are adaptable to a number of different situations. They integrate emotional health variables and are independent of diagnosis. And they have an efficient scoring system and level of care determination process. So the dimensions that are used are risk of harm, functional status, medical, psychiatric, and addiction comorbidity. The recovery environment has 2 scales, one to measure stress and the other support, treatment and recovery history, and engagement and recovery status. So the rating system consists of a 5-point rating in each scale, in each dimension. There's a criteria set for each point on the scale. We select the highest rating in each dimension in which at least 1 criteria is met. And if no criterion is met, we select the closest fit. When there's uncertainty between one rating level and another, we choose the higher rating to err on the side of caution. And dimensional scores are summed to obtain a composite score. There's also independent criteria In some dimensions, higher scores indicate the need for intensive treatment and a safe and secure environment and close monitoring of health status. And these conditions override the composite score. So placement at more intensive levels of care, regardless of what the composite score might be. So we talked about the dimensions of assessment. These are the levels of care. Level 1 is a recovery, maintenance, and health management. So it's a kind of a graduate level of service. So people that have completed care at higher levels graduate to a maintenance level of treatment. Level 2, low intensity community-based, is more or less analogous to clinical services like outpatient care. High intensity community-based services is more or less analogous to what we often consider intensive outpatient care for clinical services. Level 4 is medically monitored non-residential services. So these are very intensive community-based services, things like partial hospital and ACT teams, for example. Level 5 is medically monitored residential services. And so these are facilities where clients live and have their basic needs met and receive treatment in the same area, but they're not locked facilities. And finally, level 6 medically managed residential services are more or less analogous to what we think about as inpatient services in our secure settings. So these are a bit unique relative to other medical necessity criteria. They're resource intensities versus the traditional paradigm that really kind of define a service, a set program of services, and then design eligibility criteria to fit. In the LOCUS levels of care, each is defined by the care environment, clinical services, support services, and crisis and prevention services. The clinician and client can select from a menu of service elements at each level of care. There's often overlap or maybe overlap between some of the elements in various levels of care. And that is especially true in terms of support services and prevention services. Cost and resource intensity are roughly proportional. So the higher levels of care are on the average more costly than those of the lower levels. And so this provides sort of an ideal and seamless continuum of service elements. So in each level of care, we would describe the facilities, the level of security, support, where they would be located, the degree of medical involvement, the frequency, intensity, and availability, other staffing requirements in terms of nursing, therapists, peer professionals, service coordinators, and primary care access, a broad array of services that might be chosen, including clinical treatment, care coordination, housing, mutual supports, rehabilitation, and including education and employment activities, and in crisis and prevention. So we would, in some cases at the higher level of care, talk about the level of security, but also throughout, we want to talk about health and wellness, coaching, screening, nutrition, exercise, spirituality, art. So a whole gamut of services and service elements that might be required to meet somebody's needs. So I talked a little bit about the placement methodology and the ease of moving from the rating to a recommendation about services. The dimensional rating scores range from 7 to 35. There's 7 ratings of 5 points each. There's a placement grid that kind of lays out the numeric composite score and independent criteria that can be used fairly accurately, but the definitive placement is done through a decision tree, which is converted to an algorithm for computer-assisted recommendations. So what are the advantages of the LOCUS family of tools over other medical necessity criteria? Their simplicity, they're intuitable, accessible, and just a single set of criteria. So many medical necessity criteria make you learn an admission criteria, a continuing stay criteria, and a discharge criteria. That's not necessary with the LOCUS families of tools. There's just one set of ratings, and because of the numeric and quantifiable rating system, those transitions are dictated by the scoring. It's an efficient clinical system platform, so all the way from evaluation through treatment planning, progress documentation, and transition planning. It considers acute and long-term needs for services. And so the support of recovery and helping people maintain their recovery are included in its as part of the considerations. It's participatory and person-centered, recovery-oriented, and empowering. So we can do collaborative assessments and service planning with it. It offers this unique service continuum that's flexible and adaptable to a variety of situations. It's not constricted to a certain provider or a certain payer system. The translation, as I said, of assessment to the level of care recommendation is rather simple, and it reduces bias and structural discrimination. It takes out some of the idiosyncrasies and implicit bias that is often present in our assessment processes, because it creates a whole system of things that we need to look at in a standard way. So what LOCUS won't do is it doesn't prescribe program design. It doesn't specify treatment interventions. It doesn't replace clinical judgment or limit creativity. Those are really all functions of treatment planning. And LOCUS doesn't interfere with that and really allows clinicians to think creatively about what kinds of interventions and what pieces they want to choose from the menu of available services. So I talked a little bit before, I mentioned the extended uses of LOCUS. It really helps us in terms of rational resource management and value maximization. So, you know, we don't need a Cadillac to drive to the grocery store. Volkswagen will work just as well. It integrates service documentation from evaluation through treatment planning and transition. Monitors the course of illness and resource use so that we can really look at the fluctuation of scores over time, and we can see what utilization is for any particular client, but we can also look at that together and see what utilization in the system is like. And that helps us identify service deficits. It also facilitates the managed care reviews as long as they're in place, but it kind of eliminates the need for those micromanagement kinds of functions that often are put in place because it provides a very common language and clear rationale for the decisions that are being made. It's a way to monitor outcomes, although it hasn't been validated for that. We can just kind of intuitively see how we can, follow scores over time to think about how our interventions are working. And it also, we talked about the fact that the cost of care varies with the level of service intensity. And we can use that for bundled rates, right? And so we can eliminate the fee for service arrangements that we have that are so annoying and often don't allow us to be as creative as we would like to be. So all those things are advantages of the system. There's some other ancillary products that go along with that. There are multiple training options, a semi-structured interview, a certification process. There's some sub-levels that are defined for the residential levels of care. And there's even an automated service planner. So, you know, despite making this great case, and I see Dr. Niemark over there smiling, we haven't made as much progress as we would have liked. There's about 20 years that we've been trying to get people to see the advantages of LOCUS. But it's been in about 25 states and 3 Canadian provinces and some international uptake. They've been mostly provider adoptions up until recently. Some progressive MCOs have used the criteria, but there, I think, have been a little bit of a limited vision about many of the advantage of these systems. But in 2018, there was sort of a turning point, and that resulted from a lawsuit challenging proprietary medical necessity criteria used by United Behavioral Health and the way that it applied its medical necessity criteria. And it was seen to be self-serving rather than in the interests of their clients. And so the Ninth Circuit Court in California really named LOCUS and ASAM criteria as the generally accepted standards of care for service intensity assessment. That ruling was subsequently overturned on the argument that insurance coverage is not required to be consistent with generally accepted standards of care, which seems a little bizarre, but and that's now under appeal. But that kind of set in motion a lot of different gears. And in the case overview, the court found that the court identified 8 principles of generally accepted standards of care, which were basically derived from LOCUS. We'll take a little bit of a look at that, but the aftermath of which was that there was national attention on the LOCUS family of tools. Optum, a branch of UBH, adopted LOCUS as its medical necessity criteria. They cover about 40 million lives. California passed legislation mandating professionally derived criteria, such as LOCUS. Oregon and Illinois also passed such legislation, and there's about 6 other states that are considering it right now. The New York State Office of Mental Health also designated LOCUS as a standard for all behavioral health plans. In Pennsylvania, where this system was developed, we have had starts and stops and really haven't been able to get traction in terms of implementing these tools. Whoop, don't do that. There we go. So when we look at the mental health crisis and the LOCUS family of tools, how are these tools going to alleviate the impact of the crisis that we face? So we can look at this from a number of perspectives. From the clinician's perspective, there's efficiency in streamlined documentation and planning. A more collaborative approach and aid to recovery-oriented care and developing therapeutic relationships and investment in the plan. It provides structure with consistent consideration of relevant issues and communication advantages as it transcends some of the fragmentation and provides a common language. From the payer perspective, it will provide improved outcomes with the right amount of services. collaboration and improved member and provider relationships, systems planning in identification of the program deficits and what needs to be available. It could provide an advantage in terms of simplified payments and reduced administration, and cost reduction in terms of expanded margins and redirected resources towards treatment as opposed to paperwork. From service user perspectives, there's participation in assessment and planning, greater investment and ownership and direction of their care, and really an ownership of their treatment plan. Greater equity, reduced impact of personal bias and implicit bias and institutional discrimination, and continuity and consistency in progress monitoring. And even the public would benefit. So there's enhanced value from better outcomes and lower costs. We would get more bang for our buck. Emphasis on prevention and health promotion would keep population healthier. Greater transparency and understanding of why decisions are being made, and reduced discrimination and perceived division. So those are all pieces of the puzzle. And so I'm going to stop there. For folks who would like to actually see the tool, I forgot to put on my slide how to do that, but it's pretty simple, actually. You can go to www.communitypsychiatry, all one word, .org. And you can take a look at the tool and see what it looks like. But what we would really like to do is, as I said, see this move forward as a national standard. One thing that we have seen happen in many parts of the country is the establishment of the ASAM criteria in this way. And that has actually happened in Pennsylvania. What we would like to do is see the same thing happen with LOCUS and the LOCUS family of tools. And I think to do that, we have to do a good job of education, of making people aware of the benefits of having a standard way of approaching these processes. We need to be able to advocate on the administrative level, both state and local. And, in some cases, we may need to think about whether legislation would be needed to move the pendulum in this direction. And, there are obviously other states who have passed legislation, and that may be a possibility here in Pennsylvania. Training in the comprehensive use and the various advantages of these instruments, and perception, because I think, we have traditionally seen medical necessity criteria as tools of oppression. And really, when the idea and behind creating these instruments was really to create tools of liberation for everybody and to create greater collaboration and interaction between payers, providers, and people using services. So I will stop there, and I'm not sure how much time we have for questions. Perfect.
You want me to get it? Someone had their hand raised. We'll start with Elizabeth, I saw her over here, and then go to Jim, and then there's somebody here too. Let me get Elizabeth. And then I'll come back over. Her hand shot up.
Hi, I'm Elizabeth Kunkel. I'm the Chief Medical Officer at Pennsylvania Psychiatric Institute in Harrisburg, for those of you who don't know me. I guess the elephant in the room is really, how can we use this if we don't have buy-in from the other side, the insurance company? So that's sort of one aspect which you alluded to, how you're going to move that needle. And then the other sort of fundamental question I would see in this is, have you looked at how provider decision-making compares to decision-making as driven by this tool. So is this tool better than what I, as a clinician, think about whether somebody belongs in the hospital or not?
So those are two questions. And you know, one of the things that you were referring to is, you know, whether this is a valid tool, you know, whether it gives us valid results. And I think, you know, what it does do is compare with what experienced clinicians would generally choose for levels of service intensity. But it helps us do that a little bit more consistently. And it helps us be on the same page in terms of the factors that we consider in making those decisions. So sometimes, as I said, you know, the decisions can be a little bit idiosyncratic. And I might emphasize, you know, risks of harm over functional status, and you might do the opposite. And so, you know, this makes sure that we consider all the factors that are relevant. So I think it compares well with what clinicians would intuitively kind of choose. The first part of your question again was, you know, that's changing a lot. And in fact, right now, the greatest movement is among payers. And our fear is that it's tilted too much in that direction. And, you know, as I said, I think there has been traditionally, of course, not here in Pennsylvania, because we have some very progressive managed care organizations, but, you know, particularly on the private side and elsewhere, there's been a great deal of suspicion about the motives of payers, and sometimes with very good reason. And so in many cases, it's probably going to be a matter of mandates. And that's what's happening in other states.
Jim, go ahead.
Yeah. You've answered 2/3 of the question I have, building on Elizabeth's first question. But let me just try to get a little bit more. When you mentioned, you know, a tool of oppression, I do remember when it really was sort of a cutting the fat tool, and there wasn't collaboration, and we've really come a long way. I'm in Philadelphia, and certainly as a case with CBH. And I'm glad we're making progress. I guess I'm curious if there's any components of this that in fact are sort of a weakness, or there's a reason that the insurance companies are opting not to really embrace this. And I'm trying to understand that a little bit more than just the stereotypes.
Change. You know, change is hard. And, you know, it was like I was saying, our progress has been slow because we've been kind of swimming against the current, you know, that people hang on to what they perceive to be control, what they are comfortable with, what they have been using. And it's really hard to change that. And I think, you know, we're all kind of suspicious about change and, you know, uncertain that it's really going to benefit us, right? That we're always worried that it's going to make life worse. Yeah. And so, I mean, I think there's a number of ways that LOCUS and the LOCUS family of tools actually make clinicians' life easier. And they, I believe, would reduce burnout, you know, if we really implemented them in the way that they're intended.
And the other thing I wonder is if yeah, change is hard, absolutely, and there's always resistance. I'm also thinking if there was a sort of an accepted, transparent, sort of progressive standard, would that, you know, sort of handcuff funders as well as clinicians to sort of have to make a decision that doesn't feel right in that specific situation?
No, you know, the LOCUS doesn't mandate that you have to take its recommendation. And so, you know, if you have a rationale for a different decision, or if the client does not agree or want to engage in the level of care that's recommended, you know, there's nothing that stops or forces them into that situation. You know, my sense is it would be pretty hard to find a rationale for not taking the LOCUS recommendation. You know, it kind of covers the bases. But there may be some circumstances in which that's the case. And, you know, then the clinician really makes the decision.
And
along with the client.
So I'm going to include my question now and then give this to Jeff and then I think to Ken next. Along the lines of this conversation, thinking about this tool brings some increased, I think, benefit between the clinician and the patient, that there is this collaborative work around how we get to what I need as a person in my care, and having the clinician be able to be an active listener and participant in that. So I think, to me, that's a value added, which right now in our structure and system doesn't really allow that much time when we all are in that 15-minute widget universe.
Yeah.
Yeah, so appreciated the presentation, and had the opportunity to hear certainly parts of it before, and took those conversations real seriously. I think on the heels of the WIT decision, and in particular the fact, if you think about it, that we have a medical necessity criteria set in this state that really I would submit hasn't been looked at critically or comprehensively in some time. There's a real opportunity to sort of evaluate and to think about best practice in that area. And to that end, I'd also say, as part of those conversations, talk to some folks where this has been implemented, states like, I think, like Flown in Iowa, and some folks in Florida. And I'd share that one of the things that they put forward was that it really is much more successful when there's a standardized, uniform, often state-supported / mandated approach. And so, I will say that I've been impressed by the criteria, their dimensions and domains. I think there are nice ways around it, but been mindful of thinking about if we don't do, if some people do it and some don't, this can create a real headache for providers when you have conflicting criteria sets. And so I think there's some compelling reasons to do it in that organized way. Two other, so a push for standardization. The other things just to put out there I'd ask is, one, questions that I think will come up is how this compares to other nationalized standard sets, how to think about sort of the comparisons, the pros and cons. The third is some of the Pennsylvania specific nuances where there's often rub, things like IBHS, where we probably see the most denials. How well is this going to sort of speak to those issues? So I know that was a lot of questions for probably 30 seconds left, but.
Well, I talked about the menu of services at each level of care. And so every locality creates their own menu. We don't do that for them, or LOCUS doesn't do that for them. And so, if Pennsylvania has some unique services, they just have to figure out where it fits in the level of care system. I'm losing track of your other questions. Yeah, so I don't think there's any other criteria set that does what LOCUS does. ANSA and CANSA are very popular, but they're not standardized, actually. They're customized locally. And they also don't have a system of translation of ratings into service recommendations. They are useful for service planning in the same way that LOCUS is, but they don't have that other aspect in the sort of continuum of service and levels of intensity, and that making that translation.
Okay, I'll be very quick. So, Wes, this is just a really good example of how intransigent our system is, and how, unless there's a lot of money to be made in it in some way or other, or maybe some other quality, just a clear innovation. I mean, all this requires is a clinician and patient to sit and have a conversation that they then rate. I mean, they have those conversations already at some level. They put it down on a piece of paper and then it goes to where they go next. What's so hard? I mean, really, what's so hard? And yet here we are 20 years on, and we're still struggling to have any kind of a standardized approach to how we do this. What's the problem?
What's the problem? It's a good question. You know, I mean, I think it's, you know, it's really true that we have so much fragmentation. We do a different assessment every time somebody goes to a different provider or a different level of care. There's a different service plan there. The agency owns the record more than the client owns the record. And so we have all these problems, and there's very simple solutions, as is often the case. And we've heard about this all day today, right? We know what to do. It's how we get people to do it and how we get people to reallocate resources in a way that makes sense and in the long run would actually save money. And it's very difficult for people to absorb that idea. You know, we're always penny wise and pound foolish. So it looks like the cane is coming out, and I'm going to give you the order. Thank you so much.
So we do have an continued exciting afternoon. I am privileged to introduce Rachel Talley and Sosomulu Shrienka to present Reducing Inequity Using the SMART tool, which is Self-Assessment for Modification of Anti-Racism tool. Let me just tell you a little bit about Dr. Shrienka. I think we introduced him this morning, but there's so much there. And I guess I just feel compelled to say that I'm so appreciative of both Dr. Talley and Dr. Shrienka for how they've been able to help me and others really learn and grow in this work. I'll just say he's the chief medical officer right now in the city of Philadelphia, which is a wonderful city, along with Pittsburgh. But Philly is great, where I trained, in the Department of Behavioral Health and Intellectual Disability Services. And he really looks at systems of care and at disparities in care. And Rachel, my colleague, and the other Center for Community Psychiatry Fellowship Training. She is the Assistant Professor of Clinical Psychiatry in the Department of Psychiatry at the University of Pennsylvania. As I said, she's the Director of the Community Psychiatry Fellowship Program, and now the Associate Program Director at their Adult Residency Training Program. I could go on. She's a wonderful mentor for many young people involved in this work, and so I will turn it over so you have full time to talk.
Good afternoon, everybody. Thank you so much. I'm Rachel Talley. Thank you for that introduction, Marianne. And so I'm going to dive right into things since I know we're short on time, and I want to be sure there's a lot of time for questions and comments. Basically, what Dr. Shrienka and I will be presenting today is the Self-Assessment for Modification of Anti-Racism tool, which is a quality improvement tool that we developed in our capacity as board members with the American Association for Community Psychiatry to address structural racism in the community mental health setting. You can go ahead to the next slide. That's just a little bit more about us. Yep, go ahead. Just a couple of disclosures. I'm a medical advisor for an early stage startup. We have a disclosure here for Dr. Shrienka, who's the owner of Cynthia Health. We also want to acknowledge our colleague, Dr. Ken Minkoff, who is a co-creator of this tool, also a longstanding board member of the American Association for Community Psychiatry. So these are some learning objectives for today, as far as what we're hoping to take you through in presenting an overview of this tool. Go ahead to the next slide. All right, so just to dive in, I guess what I'm going to start with is sort of some of the framing of how we came to the experience of creating this tool, as well as our process for creating it. And then Dr. Shoyinka will be sharing a little bit more about how the tool actually works and how to apply it in a community mental health setting. And so what I have posted up here, as we all know, in 2020, while structural and systemic racism, of course, have been longstanding issues plaguing this nation, plaguing the world internationally for centuries, there really was this revitalized dialogue around these issues 2 years ago, triggered in part by the high-profile, sort of highly publicized killings of unarmed African-American individuals by the police. And so the American Association for Community Psychiatry was one of many healthcare organizations, just the AACP, I think many are familiar, but basically represents community mental health providers across the country. Basically, at this time, our board gave some thought to how exactly to respond to this, knowing that structural racism impacts community mental health just as it impacts really every facet of our lives and every structure in our societies. And so this is a statement that the AACP put out in the spring, summer of 2020, around the time that this revitalized national dialogue was going on, basically articulating a commitment to not just talk, but take action was our goal with the statement, to not simply decry police brutality, structural racism, but to go a bit beyond in terms of articulating a commitment to actively think about ways in which we could address structural racism in our professional roles. And so after the release of this statement with these 4 commitments, I think, of course, the natural question was, what next? How do we actually walk the walk rather than simply talking the talk? And so our board, and particularly Dr. Shoyinka, Dr. Minkoff, and I came together and started to brainstorm as far as how can we think about the ways in which structural racism uniquely impacts specifically the community mental health setting, and what can we do to support busy, overwhelmed community mental health providers who certainly have plenty of tasks on their plate as far as providing care to patients, keeping their operations running. How can we support these providers in addressing issues of structural and systemic racism as they impact the community mental health setting? And so here I have what I would sort of boil down as our goal in creating what became the SMART, which was that we ideally wanted to create something that would provide some specific metrics or areas of focus that community mental health providers could hone in on that would be really specific to the issues that impact our patients as well as our providers. So say thinking about clinical issues that one might disproportionately see in community mental health settings where there may be issues around inequity or disparity. We also wanted to extend beyond what I would say are the very important realms of cultural competency and linguistic appropriateness to think about structural inequity broadly in this tool. And so as I'm going to allude to a little bit in a couple of minutes, there are already some excellent standards out there for healthcare organizations to utilize in terms of addressing inequity that really robustly address cultural competency and linguistic appropriateness. And so our goal was to draw inspiration from those past frameworks, but really extend beyond to think about all of the policies, the structures, and the systems that might be part of a community mental health organization and where inequity might surface beyond those 2 particular arenas. And then lastly, what I would sort of boil down as this is what SMART is. This is what we ideally hope that it does for a community mental health organization, is we ideally wanted to create something that would promote a stepwise concrete quality improvement process that could be adapted for self-directed use in community mental health settings. And I want to emphasize self-directed use because something that I'd say we as the co-creators, part of what we were drawing on in creating this tool was our own experience of how providers on the ground were reacting to this revitalized dialogue around structural racism. And I think a common reaction we often heard was, this issue, structural racism, so nebulous, so overwhelming, so hard to grasp, very difficult to address. Maybe we should get a consultant was a common thing that we heard. Maybe we should bring somebody in from the outside to fix us basically and address the structural racism issues in our organization. Our hope in creating SMART was ideally to have something that would sort of facilitate the people within a community mental health organization, the people who know that organization best in terms of its processes and its ways of operating, and basically help them to draw on their own knowledge of their organization to at least make a start in terms of addressing issues of systemic racism before bringing in somebody from the outside, somebody expensive from the outside, which we all know in community mental health can be extremely challenging as far as bringing in extra help to address these issues. So here I want to highlight, this is basically just a snapshot of a little bit of the process in creating SMART. And so to describe sort of in brief what our process was, we started out first, this wasn't a formal research process, but our goal was very much to draw on the evidence, draw on prior published work in terms of creating something robust and informed by the evidence, but then something that was also informed by the lived experience of our members and our leadership in the American Association for Community Psychiatry, who again represent community psychiatrists across the country in a variety of settings with a large range of experience in terms of where structural inequity might be most relevant in community mental health work. And so our starting point was actually a town hall that the NAACP held in the summer of 2020, which was it was a town hall not really intended specifically for SMART, but we really drew a lot in terms of the content that was elicited in that town hall in creating the SMART. And it's basically a gathering point for members of the NAACP to share their reactions to recent events at that time, share their ideas as far as what community mental health providers should be doing to address structural inequity. And so that was very much our starting point, just in terms of drawing on that experience of our members and what they saw as most relevant or most important in terms of these issues. We then sort of got together as a board and started to boil down some of those ideas in terms of what could be big buckets or what could be sort of key target areas that we could look at in terms of thinking about where community mental health providers should be starting and thinking about this is a big arena of focus in terms of the things we do, where there could be a variety of issues within that bucket in which inequity and structural racism is relevant. We then did a literature search both to look to identify key target issues for which there was an evidence base suggesting that inequity would be likely. And this is where we sort of drew on the evidence in order to make sure we were picking the best targets to include in SMART where it would be likely that a community mental health provider might find disparity. So just to kind of concretize that with an example from something in SMART, one of the items in SMART deals with access to clozapine and basically specifically ask community mental health providers to look at whether there are disparities or inequities in terms of access to clozapine for the patients that they serve. How we came to that particular item in terms of clinical provision of care amongst all the many possible things and interventions or possibilities is that one, we knew this is an issue that's particularly relevant in community mental health, that clozapine is a medication for people with severe mental illness. And so disproportionately, we would expect those receiving its medicine to be in the community mental health setting. And also there's a vast body of literature evidence that has repeatedly shown that there are racial and ethnic disparities in terms of access to clozapine. So that's sort of an example of how amongst the many possible things we could consider in terms of how to direct a community mental health organization as far as what to look at in trying to track for disparities and try to address them, how we went about selecting items, both based on input from our board as well as review of the literature. And then lastly, what I have highlighted here on the slide is that we were not the first to think of the idea of, goodness, shouldn't there be some set of framework or guiding principles to address inequity in the healthcare setting? There's an array of robust work in this area, both in healthcare in general, some specific to mental health. And so we reviewed prior inequity frameworks, both to ensure we weren't reinventing the wheel, that if there was something out there specific to community mental health that could provide sort of a stepwise process to address inequity, we certainly didn't want to repeat that work and potentially would have considered disseminating it instead, but also to draw on prior frameworks and see where we could pull certain ideas or certain concepts that seem to be most successful or relevant in terms of creating a quality improvement tool of this nature. And so honestly, for the sake of time, I won't go, this is just a couple of examples from our review of the literature for this form of framework. I'm going to put up at the end, we're going to have at the end a publication that we have out there that gives sort of a deeper dive into the different frameworks that we reviewed. But what I'll say in brief is that these are examples of a couple sort of sets of key frameworks, sets of principles, schools of thought in terms of thinking about inequity in the healthcare setting, all of which we reviewed in creating the SMART, certainly pulled ideas from, but ultimately found that what we created with SMART did seem to be something that was a little bit different and fill the gap as far as addressing the needs of the community mental health provider. So with that, I think I'm going to turn it over to Dr. Shoyinka to tell us a little bit more about the thinking in terms of applying this form of tool and its different components.
Thank you, Rachel. Again, very much appreciate your time and attention to this important idea of tackling structural racism. So in the morning when we talked, when I made my remarks, I mentioned there are a couple of pitfalls to attempt to avoid or potential pitfalls in getting to grips with tackling structural racism. One of those is the idea that, okay, we're fine, everybody else, it's everybody else that has a problem. Another pitfall is the obvious difficulty in actually starting the conversation in the first place for all the reasons that have been talked about already. And then I think there's also potentially the danger that, and I think this is really what drives the anxiety a lot of the time, is this fear of mudslinging, you did this, you did that. Now, SMART attempts to remedy each of those concerns. So it's probably best to, conceptually, SMART is all about quality improvement. And for those that understand or have a background in quality improvement, I think that there's a basic understanding that it's never done. The work is never done. The Japanese, for example, have the term Kaizen, which really refers to continuous quality improvements, never really ends. And so I think adopting that basic framework is the mindset to begin SMART with. Now, Dr. Ken Minkoff, who's was a third collaborator in developing this tool, has decades of experience in doing quality improvement work. And so this mantra really comes from him. And it's really the acceptance that I can't change anybody else. We might be able to change something about our system. May not be able to do much about the rest of the world, but we can do something about ourselves. And then the FOCUS PDCA acronym, which stands for finding a process to change, again, focusing on processes rather than personality, which can be difficult to pin down anyway. Organizing a team, because any kind of quality improvement, it really is a team sport. The need to clarify the baseline, understand where you're starting from, understanding why things are the way they are, and that's where some of the richest conversations happen, is trying to really get to the roots of why are we here, and then oftentimes starting with the lowest hanging fruit, and those will vary from organization to organization, and then engaging in the PDCA cycle, which is the plan, do, check, and adjust. Next slide, please. So the SMART domains touch on several different areas that are obviously can be pertinent to many types of organizations, but are particularly so to community psychiatry. Hiring, recruitment, retention is the foundation piece, because we talked about that this morning. Not having representation, participation is key to outcomes, whether that is from the perspective of leadership or service delivery. And we also know that the literature is very, very clear on each of these areas that disparities exist. So clinical care, Rachel talked about clozapine, that's just one example. There are many others. Workplace culture is this nebulous thing that is nevertheless really powerful. It's sort of the software of the organization. It's the operating system. It's how we do things. And it's often transmitted really in very subtle ways, but influences behavior really powerfully. And because of the unique interface of community mental health with things like criminal justice and child welfare and so on, other social services, there's very definitely a role for community mental health in advocacy in these areas. And then population health, I think the point was made earlier that our population, participants in the public mental health sector tend to die a lot earlier than their non-ill counterparts. And so understanding the role of delivering mental health and being able to impact those outcomes is crucial. Next slide. So the recommended SMART process is to basically begin with a group conversation, is to convene a group, ideally comprising individuals from all different levels of the organization. And that would ideally include not just a diversity of ethnicity, but also of professional discipline, professional training, so psychiatry, psychology, peers and so on should all be represented ideally. And also different career stages, so gender and so on. So diversity in every sense of the word. And then treat this initial dive as a catalyst for broader conversation. Now, the need to arrive at a consensus for scoring is one of the, we think, most powerful aspects of the SMART tool, because organizations that have actually engaged in doing this exercise have found it, even organizations like DBHIDS, which is my organization that is fiercely committed to diversity and equity, have found opportunities. When you have that diversity of perspective, you tend to have very robust conversations. And then this scoring is then ideally followed by an action plan, and then systematic rescoring over time, reassessment over time. Next slide. So shared some data about the disparities in this arena, so I won't go on about that. But essentially, the different the different areas covered under the hiring, recruitment, retention, and promotion domain include promotion and so on, and disciplinary action. There is evidence in the literature that minorities get, for example, called to peer review much more frequently than non-minorities do. Next slide. So I'll just walk through what actually applying this tool looks like in real time. Now, let's say, just imagine that we've convened that group, and that group then has decided to tackle this particular area. Item H1, to what extent does your organization track racial disparities in promotion practices, including time to promotion, percentage of employees receiving promotion in a given time period, and to what extent do we ensure that those disparities are addressed? So this is really asking a lot of an organization. Well, a score of 1, which is the lowest, would be that the organization, according to that self-assessment, according to that consensus, has not actually begun to do anything about it. A score of 3 would be we've begun to do this fairly well and are beginning to do some work on it. And a score of 5 is we've completely eliminated all disparity in promotion, which would be cause for celebration. And then moving on to the next thing. Next slide. And under clinical care, again, Rachel talked about clozapine access, but there's so many other areas in voluntary treatment. We know, for example, from the literature that diagnostic disparities are highly prevalent. Schizophrenia, for example, and other psychotic illnesses are diagnosed at a much higher rate among minorities than non-minorities. And we've already talked about the disparities in treatment and access. So moving on, next slide. Sample item would be access to clozapine. So again, this hypothetical group would select this item and then perhaps look through records, perhaps just have a conversation about, well, to what extent have we, or has the organization in question tracked racial disparities in access to clozapine, and to what extent are disparities addressed? Score of 1 would be we've never thought about it. And this would apply to any of the other clinical items. We've not even thought about it. Score of 3 would be we've actually begun to track this fairly well, made some progress, and a score of 5 would be we've, again, eliminated all disparities, which would be, again, a cause for celebration. Next slide. So I mentioned workplace culture. These are some of the elements that were identified as being important to being intentionally anti-racist. So staff-to-staff conversations, which are difficult to have and frequently don't happen, staff-to-client conversations, There are numerous reports of microaggressions, staff to staff, patients to staff, and so on, or staff to patients for that matter. Implicit bias training, which we know there are existing tools for that. Formal reporting and structural training. Next slide. So under this, a sample item would be, to what extent has your organization identified the goal of creating a safe space in the workplace for staff to identify and discuss racism and its effects, establishing informal processes, including accountable individual structures, processes, and so on. And you see the same overall pattern to the scoring. At the score of 1 is we haven't thought about this, or we've just begun to think about this. Score of 2 would be we've acknowledged that this is a goal, but have not formalized that goal. Score of 4 would be we have a formal goal, have identified an individual or structure to address it. Next slide. Community advocacy, and this is something that I think we as a field, community mental health, do particularly well. And I think have a real opportunity to develop a voice in this arena, including here in Pennsylvania. Different aspects of advocacy, and obviously there are many more than this. We had to be selective in choosing what items to focus on, but law enforcement, school to prison pipeline, child protective services, housing and security, which we talked about this morning, and elder care. Next slide. Sample item, you can see the same basic structure, involvement with law enforcement and the criminal justice system. To what extent does this organization partner with law enforcement and the local justice system to eliminate potential disparities in arrest, incarceration, and diversion of people of color who have mental health and substance use conditions? Score of 1, we don't collaborate. We have not addressed it. Score of 3, we do have a collaboration. We have some data that we've begun to make some progress. And the score of 5 is we work as a community to track this consistently. Next slide. And under program evaluation and outcomes, health outcomes, functional outcomes. Next slide. To what extent does your organization track disparities in functional outcomes, employment, homelessness, graduation, recidivism, and so on? Score of 1, we begun to think about this. Score of 3, we formalized the goal, but have not yet begun identified any accountable entities. And a score of 5 is we have a formal goal, well-established structure and processes. Next slide. All right, hand it back to you, Rachel. Thank you.
All right, so to wrap up before we move on to the question and answer portion. So as I mentioned earlier, I did the briefest of overviews as far as some of how our development process for the tool. For anyone interested in sort of the deeper dive in terms of the literature we reviewed in our process, we do have a publication, the Community Mental Health Journal from 2021, describing it in more detail. Next slide. And then lastly, in terms of future directions, and I found myself listening to Wes Sowers earlier about sort of that slow process of uptake. And so we are very early compared to the LOCUS, that 2 years in, we're very much in what I would call sort of the informal or early adopter phase of basically encouraging organizations to test out the tool, collecting feedback on their experience to think about how we might revise the tool and move towards a more formal pilot. And so one thing I'll share as far, sorry, could you, oh, thanks. Oh, no, back, please go back. So I would say one thing we would certainly hope that you take from this, as far as if you are part of a mental health care organization, is please consider taking a look at the tool and trying the SMART process in your organization. We'd be very eager both for this tool to be helpful for you, but I'd say just as important to hear about your experience with the tool and have your feedback on it. And so the tool is freely available at the AACP's website, With the tool, we also have a structured feedback survey where you can actually sort of formally share your feedback on the process of using the tool. And we also welcome informal feedback, emails, phone calls, whatever it might be, as far as your experience using it. I do have office hours as well listed to the AACP's website. And so if you're in the process of implementing SMART and in need of some additional support or assistance as far as troubleshooting the process, we have that available as well. And I will say our sort of looking ahead, our goal as far as moving from this early adopter phase to something more formal is that as we've collected feedback, gotten a sense of the experience of some organizations out there in using the tool, and just to say we've had, I'd say, an array of a couple dozen organizations use it, ranging from individual provider organizations to managed care entities to larger city behavioral health authorities. And so our goal is to move towards a more formal pilot as well as a more formal training series. And so in the months ahead, our hope is to develop a deeper dive training series that basically goes domain by domain, giving sort of a little bit more content on how to implement each aspect of SMART, and also to hopefully, pending funding, create a learning collaborative so that we can have a process of organizations working together to implement SMART, supporting each other and sort of troubleshooting the process to, again, help us get a real sense of what more formal implementation can look like and what the outcomes are for implementing the tool. So with that, we, transition to question and answer.
This would be considered really under, quality improvement as well, and seeing how just overall quality in the organization, but also any tie to, I imagine it would be directly tied to outcomes as well. And how, it's not like how long does it take to implement it? Because I would be, it's really, quite a powerful approach and system, and would love to kind of bring it to the organization that I'm with, or at least the idea of it, or getting started to all of those aspects of it. But it's really compelling and how it's all set up. So I appreciate you sharing that, and really looks like it could be very straightforward in a way, at least initially rating the organization that you're with. It's like, what are we doing? Well, maybe something, maybe nothing, but there needs to be more either way. So thank you.
Thank you for the comment. And I'll just commenting on your comment, that's exactly our hope is that this is something that is easy to use, sort of boils down this very difficult issue into sort of some easy stepwise questions to help the organization think them through. And I guess just to highlight something that you said, we were very intentional in having level one and each item be, we have not thought about this and we have done nothing with it. And our hope was to kind of give that validation that it's okay to be at a level one, to, as you start the SMART assessment, that if you're at a level one, great, a new opportunity, a new thing for you to look at. And then just to comment a little bit about your point about the time needed for the process. I will say that is, I think, a little bit of I'd say a limitation as far as we've gotten experience from on the ground organizations, that this does take time. Our experience has been that it tends to need, say, a series of concentrated meetings amongst that stakeholder group. But that, again, to your point, I think this can add tremendous value as far as getting a starting point in tackling some of these issues. Absolutely. Yeah, absolutely.
Yolanda, go for it.
Okay, thank you. First of all, I think you've done a lot of work in 2 years. So I think you have to give yourself credit, not for where you want to be, but for where you are now. This is really impressive work. And I have a couple of comments. First of all, I think it's really important that we do this work, and especially as we're setting strategic goals for our companies, that they are informed by feedback from within the organization. And so one of my questions is, are you considering getting feedback from outside of the organization as well? I know this is a self-assessment, and I'm speaking to, I'll just give a little background on implementing the Building Bridges Initiative, which is a self-assessment for residential centers. And we did it initially doing the combined kind of team assessment approach. And then after 2 years, switched it to anonymously, allowing different people in the organization to answer, and got very different feedback. And what we found is that in a team approach, those people with strong voices or higher level positions, their vote counted more than other people within the organization. And so that took, away some of that by allowing it to be anonymous and then seeking feedback from people who might not have been in that group discussion from a leadership perspective. And this previous year, we then extended it to external stakeholders, which was one of the original components of it. And that feedback also was very valuable because it's important how we measure ourselves. It's also important whether the people on the ground see it, whether our families, funders, other people really experience it. So just thoughts for future pilots, maybe.
Well, thank you so much for those thoughts. And maybe just to highlight particularly your first point in terms of what we've experienced and ways in which some folks that we've worked with sort of altered our suggested process for using SMART, I think in really great ways to try to address some of the issues that you're getting at. That our ideal in a way was, well, you bring together the stakeholder group and they represent all sides of the organization. And so have equal seat at the table. But I think just, of course, just as you point out that in a situation like that, it could be a mix as far as whether folks who maybe are in more of that, say, on the ground frontline position feel comfortable with somebody from upper leadership sort of expressing directly their view on these questions. And so two modifications that come to mind are one organization that we worked with basically started out with an anonymous survey to their entire organization, basically to really get the input of everyone in terms of how they saw these items, basically got that data in terms of how the full set of employees would rank the organization. And then a smaller focus group that was more modeled off of what we described in SMART basically had that as a starting point to then sort of digest the rankings that employees from the larger organization had given to make sure that those voices were heard. Other modifications we've heard are sort of having basically first starting with two separate SMART processes, one with upper management and one with folks who are maybe more in a frontline position, so that each group of people, particularly those in the front line, can be in a group where they may be more comfortable directly expressing their view, coming up with their consensus, and then the groups coming together basically to share their findings and see what their difference is. So giving a little bit of cover and anonymity to who individually within that group of the frontline providers may have shared certain views, but then also allowing a place for there to be equal footing with both perspectives. But I think it's really great points that you raise. Is there anything you want to add?
No, very well said, Rachel. I think the other just very interesting report was that it's not only the frontline staff that sometimes are uncomfortable. Sometimes senior leadership are also in a position where they very well can see what's being pointed out, but feel a sense of duty to, not air the organization's dirty laundry, that sort of thing. So it cuts both ways, and these two modifications seem to have worked.
Hi, everyone. This is Eileen Diaz. I have a question for both of you. I know that the AACP hotline and helpline is on board with the SMART tool, which is fantastic. And I applaud you for making the SMART tool itself. But my question comes into the barriers and the benefits and challenges so far of the SMART tool. What feedback have you had on this helpline so far from the AACP? In other words, those organizations calling in your helpline.
Yeah, I think in terms of main feedback, and I'll add a little clarification that we don't have a full helpline. We have office hours, and I'll say only for the sake of bandwidth. I would love to helpline and offer that. But in terms of main feedback and barriers, one just general piece of feedback. I think one of the most common we've gotten is areas that we did not include in the tool, which is one of the biggest sort of push and pulls that we had. Where I'd say particularly in the arena of clinical care. Unfortunately, there's a fairly endless list of clinical issues where you can find evidence of disparity. And it was incredibly challenging to try to narrow down a starting set. And so I can say there were many occasions when I've gotten that feedback and specific things have been pointed out, such as the fact that we do not have substance abuse in that clinical care setting, where feelings like, oh my goodness, how did we not include that? But it was tough as far as making sure this was a tool that didn't feel overwhelming and gave people a starting point. And so I will often respond to that feedback is that even if an issue is not included, if an organization thinks of an issue for which they have a concern that there is disparity, or they're aware that there is literature evidence supporting the existence of disparity, that our hope is that the sort of the SMART template can be taken and applied to different items. And that is certainly an item that's not in SMART, an issue that's not in SMART can absolutely use the SMART process.
I'd say another key feedback has been, and this is where I think we're hoping to work within the ideas like the training series, the learning collaborative, essentially facilitate a process where different organizations can pull on the expertise of each other to help in terms of the next steps in SMART is we've done the assessment, sort of what do we do next and how do we motivate our organization to take next steps. And I'd say that is a challenging one as far as for each of these issues, how do you concretely create processes to improve on these different items? And so my honest approach so far has been that as different organizations that have implemented SMART have come up with interesting, innovative ideas to address a particular issue, I've been sort of collating those and then disseminating them to, say when another organization comes and says, hey, we're working on hiring and recruitment and we're not sure exactly how to approach this. And say, well, this organization that we work with came up with this really interesting way of doing this and kind of sharing information in that way. So those are the main feedback that come to mind.
Yeah, I'll just add a couple of things to that. One of the item that's come up a few times is just the amount of time that it takes to get through it. Organizations, you mentioned this, I think actually, organizations will say they need several sessions. But one organization took about 3 months of several sessions to get through it. So that's and the last thing is the structure of the questions or the items themselves. There's some of those items have double barrel, triple barrel type questions in them. So certainly opportunities to refine the tool.
I just think about, and there's probably somebody behind me and Ken here. Just a quick comment. I wrote a note to myself that come this Wednesday at the Learning Collaborative, I'm feeling like there's application for what we're going to be talking about and this process for the program directors and in particular thinking about faculty and that whole process. I'm going to give it to Ken and then back to Elizabeth.
Well, you're channeling my sort of question, Marian. So I'll just say, we just had Representative Schlossberg here, and there's money coming around workforce issues. Do you guys have any thoughts about what you'd like to see happen in Pennsylvania, and what you could do in the next year and a half, 2 years to build this out? What would you ask for, and what could you imagine?
Say, what are our limitations? Well, I think as a starting point, I would love to have, say, a more robust, even sort of technical assistance apparatus for us to support organizations in implementing SMART. That right now, I'm always eager to provide the office hours. I'm just one person offering a certain amount of slots. And I think that for an issue as complicated as this is, as much as the goal with SMART is to really boil this down, that I think implementing SMART is a somewhat involved, complicated process, that having more of a structure to offer support to organizations who are implementing it. And then I think as far as, we've had this idea of this relatively small, limited learning collaborative as a starting point. I would love first to create that, and then ideally to continue to replicate that process, to have a system where organizations that are interested in implementing this can kind of have a collective that they can join on a continuous basis, to have partners as far as troubleshooting what they encounter as they implement this. I'll have to continue to think of other ideas as far as if the sky's the limit. I'm sure there are many more possibilities.
I could think of a few hundred. But this has not been the focus of the tool, but there have been discussions about validating the tool. It would be interesting to take a look at that. Obviously, that requires bandwidth, expertise, and so on. So that would be helpful to do. And then Rachel talked about she's basically carrying this on her back right now, engaging various stakeholders. But we know that there are many more people out there who are interested in using SMART, and with a bit more of a robust team to, I loosely call it marketing, that would be helpful.
If I just add one more quick thought, I guess when I think about the process of applying and going back to that issue of bandwidth, that I think there can be organizations that are very eager to both apply SMART and then think about implementing the solutions to SMART, as far as whether there's really time within the
the work roles and the operations of a community mental health organization to tackle each of these issues. I think that could get very challenging. And so thinking about ways that there could be, say, additional support for community mental health organizations to have the carved out time and support to sort of do quality improvement activities specifically in this realm is something I'd be really interested in.
Thank you. So this is a wonderful tool to have a very difficult discussion in a non-threatening, non-judgmental way. The thought, though, occurs to me, it's a little bit like preaching to the converted. And I'm wondering what you know about your users and whether you're collecting user data that would then later give you a way to more objectively measure if you look at, willingness to change, the willingness to change of the organizations. So are you only tapping into organizations that are willing to change and therefore not attracting the other organizations that want no part of the diversity, equity conversation?
And I'll just add a tail end. So how do we get those pre-contemplative groups into the mix?
That's a great point. And I will say that we don't have a formal way of collecting it. However, I'd say informally, my suspicion is right in line with what you're thinking, Dr. Klein, that particularly at this early phase, I think that the people who have taken this up are really people who are far past pre-contemplative, who are organizations that are really passionate about this issue, really have an independent desire without specific, say, financial support behind it, without there being a specific incentive to work through this process because they feel it's the right thing to do. I think as far as changing those pre-contemplative minds, I don't know that I have the best solution. I would say, I suppose the cynic in me thinks that for those organizations unwilling to address equity related issues, I sort of think ahead to things like how can you create concrete financial incentives to do so? Say things like working on, ideally, I might say on the payer side, as far as where we could find ways to incentivize less willing organizations to take an interest in this sort of issue, because I do think it's one where if you are not interested, it's very hard to move, I think, hearts and minds on these sort of issues if people do not have that true interest. I guess our hope has been that kind of the data-driven approach was smart. Again, sort of, exactly you're saying, Dr. Klein sort of sanitizes it a little bit, makes it very neutral, makes it very objective. But I think for these issues, there's a degree to which it's impossible to completely do that, right? I think that people bring into a process like this their preconceived ideas and notions about the value of equity-related work, whether these issues are important to prioritize. And so it is challenging, I think.
Yeah, we'll take your question in a minute, but one of the, and that brings up in my mind something we've talked about, and this would be another ask. The idea of actually doing an actual assessment as to whether the SMART process delivers any value over and above, comparing with bringing in a consultant, for example. So that would be something to explore further. Question.
I know it's early, but I would be really curious to see, when the time comes for like a case study or where you organization identified something, done the planning process, and here's the result. I also think that would be really useful to get down the road into considering and see the usefulness.
It's a great suggestion. I will say, in since thinking about where we might even start with that we've done a few presentations on SMART where we've actually brought in 2 or 3 early adopters to describe their experience implementing it. And certainly an idea I've had in my mind is we really should try to find a way to write this up and disseminate it, that beyond simply having those presentations, starting to sort of package and disseminate the experience of early adopters, like just as you're saying. So
Podcast, YouTube. I know it's 3:02. We were going to have a 15-minute break, but this has been a robust conversation, so I don't want to shut it down if there's a few more questions. We good? Thank you so much.
Of course.
Okay, we start again at 3:15. It is 3:03. So enjoy the networking and the potty break.
I suspect, it's just so written into everything that we've got.
Never see your own blind spots.
Well.
I hear you. I hear you.
Yes, no, I mean, we just have the most.
What were we
diverse
thinking?
Staff in any place in the county.
Certainly,
Oh my
certainly, it's true.
gosh.
And I think it
So
would be
it is-
interesting to look at it, sort of, minorities that have their history in the US and in this space versus sort of minorities that are coming from other spaces, refugees, immigrants, et cetera. I was gonna kind of ask her to talk about thoughts on that, but I
Well,
didn't.
it becomes it's an interesting topic because then then it turns out that everybody is in fact in a minority.
Sure.
In this, not in the classic constitutional sense, but in the sense of who's being served.
No,
So it's an interesting.
as a woman who has gone through medical training as a single parent and not fallen into like many traditional minority like
Right, you see-
categories, I understand that sometimes my challenges are not on the demographics checkoff sheet. You know what I mean? Everybody can be a minority in their own way. That's all I'm saying.
Well, yeah, well, or everybody can have needs. Minoritization
barriers.
Minoritization is the only way that people have needs.
Yeah, yeah.
So it's,
This is just
but
a
I
thought.
think it's certainly something to think about. We're just so diverse.
No, I get it. When I was in medical school,
But maybe that's a blind spot. Maybe we're so diverse we don't even think about it. What is that?
I spent 8 years on the board of an organization that was very small. So being a board member was a, maybe not daily job, but weekly job. That was a child care center with an explicitly anti-bias, anti-violence, pro-environmental, whatever. And we served probably 80 to 90% international families. And I still think sometimes it's for all the, hope in your heart, there are structural things like cause pain. It may be harder for our Nepali folks to figure out how to get to, a blood draw space. And maybe not because we have that addressed. All I'm trying to say is that I think sometimes you don't see what you don't see, and it may not be because somebody somewhere is deliberately being obtuse or unkind.
Right.
Anyway, what do you think about it? Hi.
No, I just thought I'd introduce myself
Yeah,
here.
hi. I'm Amy. Nice to meet you.
Kelly, I'm PGY2.
Oh, welcome. Good for you.
It's been awesome so far.
Oh,
I
good.
like really utilize this time where, there's like this bit of integration happening.
Yeah,
And
yeah,
I do have to hop on a 4:30 train.
Yeah.
Unfortunately, work still happens tomorrow.
Yeah, how can I help
How did
you?
you
How
get
can
that
you
from
network with
Einstein
me in a
to
way that I
here?
can be
I took
helpful?
the train.
No, but I mean, what got Einstein, PGY2 from Einstein to this meeting? How did you do that?
So it was through the PPLC branch is trying to I guess introduce more minoritized residents.
Okay, so it was, so that you came for the dinner last night?
Yes, I
Okay,
did.
great.
I know, and you popped in to
Yeah,
say hey, and how can we help? Or I'm here to support.
Terrific.
So
All right, I didn't mean
here
to.
I
You
am.
were
No, no,
one
no,
of
how I
the,
got
you
here.
were one of the
Girlfriend wants to
residents?
network.
Yes.
Like, let's
Oh,
network.
okay. I
What do
was
you want to do?
wondering.
How can I help you?
So I am 1,000% interested in doing public psychiatry.
Okay.
I'm looking into going into that for my fellowship. Honestly, originally when I started residency, that was my full intent. And then, first year got to me and I was like, oh my goodness, can I really go for further training after all of this is done?
You don't have to do a fellowship to do this work. I'm not to say I had a great experience doing a fellowship. The fellowship that I did, I was working full time and I did Thursday mornings. You know what I mean? That's a possibility. I know some places it's like a full time, clinical fellowship. UCSF has an interesting program that I'm aware of. There's probably lots of other places, Columbia. But you can do public service psychiatry and not do a fellowship.
So I think that now, once now that first year is
First year,
behind me,
yeah.
I've been having that that inkling okay, no, this is right, and that I will have to go that route in the end.
All right.
So just being able to meet other individuals that are in these spaces, hear response. I met Dr. Talley actually initially at the conference. It was the last one that happened in 2019.
I was supposed to be at that one, but I.
All right.
Yeah, it was in
Had an
New York, and
emergency.
that is where I met her.
You must have been
Yeah, it was. Yeah. Mental health services. Yes. So like, yeah.
Now it is, it was IPS.
Yeah, that's what I was like. It was in my head. I was like, there's something, yes, IPS. But it's happening again. I'm in October. Yes, here in DC. I think I'm gonna make my way down there. I know. Will you? Okay, I will certainly have to. Okay. The impact. Families and children.
There also will be a meeting of the American Association of Music Artists. Reception. There's also going to be a meeting of all of the fellowships in public service.
I saw, I was just looking at it. At first I thought that I might be on like a 24 or 12, one of the other shifts, but it's a Thursday and Friday. So I actually am available. I'm very excited about this.
When?
I
heard when,
I am
but when?
October 13th.
I will. I should look at the paper and like just write.
Yeah, I gotta go. Yes, Squirrel Hill.
Yeah, you gotta work.
I gotta work.
But next time.
Yeah.
Next time.
Yeah.
Huge blessing to come and attend today, and she's always trying to help us as much as she can as far as putting in some mistakes or at least
A wonderful honor for me because she preceded me at the state psychiatric society's presidency. So she was president. And so we worked together for
Dr. Best.
Kim Best.
Oh, yeah.
I wouldn't mind joining your John.
Yes.
I'll make sure to reach out to you as your conference gets closer. Even though it's in like 3 weeks, I guess, technically.
It's in October,
Yeah. Time is fast.
So you guys got your
Which,
We did. We have an NRMP number.
So all of
you
the
know.
Pennsylvania state prisons, and I think if I
like a
correct, there are
typical way to go.
24 of them.
Okay.
I was the Southwest Regional Director
So what
when I
happens if
left,
somebody,
so I had 5
comes into
under
the
my
program and later
domain.
decides they want to-
Looking
Yep.
at, I'm sorry.
Right now.
It's in your hair.
That's where I've
It's so
encountered
much
a
on
ton
my
of
Pennsylvania
prisons. Tried to
Okay.
advocate for something.
Got
It was simple to start with.
I have 5 prisons
Like,
under my domain.
You know,
I've
third and fourth
been
year.
to 6 of them in person.
I'm sort of
I've
hoping
done-
this
I've
is
done
like
telehealth
in,
facility and
and then maybe we
but my main one is
towards that. 'Cause I think
don't know how long.
our residency program director, and I've explained it to him, I've explained your model to him. Has a sense that it requires a lot more change to the basic structure of residency to incorporate it and make it happen. But actually, in reality, how we're constructing the track is like 4 years is not actually all that different. Essentially, we're just designating their elective time.
It's super challenging. I also hate it.
And he said something quite,
some other things.
I loved the population. I just left, basically, I walked off in a huff because they had one of the prisons they couldn't hire for. I got one of my
So
friends.
we're gonna,
They can't recruit. I recruited.
We're hoping to
Underneath
do,
me. And they
like, I'm
paid
hoping to
him
do kind of
$20
like
more an hour than me.
a
and I was like,
seminar with
like,
the residents.
it doesn't make
track.
sense. They promised me a
The
raise
only
they never
one to
gave
start
me
with.
previously, and I'm already mad about that. I'm like, you can't
Medicine for 6
go hiring
months
out
of
my
first
friend
year,
to work
so
under me.
we don't have them for
You know what I
that. And then
mean?
we were
For
hoping
that.
to
And
kind
I
of
don't
do
know
some
if it's a
kind of
gender
almost
thing or
like
if
field
it's
trip
just like-
experiences, or maybe meeting with, community organizations, like kind of getting a better understanding of some of the community resources, and supports
I
early
understand.
on, which they hear a lot about on the innovation artists, but they don't understand.
I find that they are.
It's not like-
Especially given the first.
I was there and
Rooted.
right, and they're like,
Right.
and
it's
know
like,
the organization,
I
first
don't
of
think
all,
we could have created, it's
don't hurt
bizarre
any
with
men
our
at all.
GME office, I
So,
don't
like,
think we could have created another slot
regardless.
unless
like,
it was
they-
specially designated for this track.
I did
Sort
not
of how we
know
did it.
the way it worked actually,
Because
Ken's
slide was not
was that the Department of
He
Corrections
has it in
itself
some
does not
weird
hire
keynote or
physicians.
something,
And
and
they
they
hire a
maybe
firm,
it's a
for-profit
thing,
firm.
but no, just
can
was,
open
I
that
think there was
for
just a sense
my
that our
direct
residency
employer
program
is
is
for-profit.
so
And they just
there's a some rigidity in the thinking about this. And like I said, I think just sense that it requires a lot more change to standard fourth year.
I will say that occasionally it worked in my favor in terms of, I was definitely there and really trying to motivate people that I did not my boss.
So I don't know.
Like,
Let's see how we
I'm
go.
calling my
We also, I mean,
actual boss,
we
we're
applied
having
for this
stuff. But
ARPA
at the
grant
same
through
time,
Cumberland
it
County. People find out what
our
about
organization
2 weeks. Because without that, we
It
can't.
was very reactive and very desperate. Oh, we can't fill this thing. We'll throw money at this guy to come in, but we don't actually have money to pay everybody like that. So we're now paying, so it just.
So hoping this is sort of an aid.
I'm in Pittsburgh. I'm at Louisville Health Center, which is.
It was refreshing. We had a residency retreat last week, and on both, they sort of divided up topics: clinical, scholarly, and education. And those clinical and education components would give specific questions about how can we
Noble
incorporate
human
psychiatry
beings to work, but I
stuff
haven't
in.
been there.
So
So I'm still kind of getting
thinking about it a little bit.
Out, but my population, I really like working with that population.
No, I just this year I got a few lectures in, and
One of the
Katie
things
Dahl,
I liked about corrections,
the transgender
they
and
hired
did with the CPS.
that's what
She got
but the way that it worked,
invited to
I was
revamp some of
every
the
day,
DEI curriculum, and so we've incorporated some things there. So that we're making
time, unless we were extreme circumstances around for various reasons. Most of the time, I did not find my list like overly burdensome. Nobody was asking me to do it 5 patients a day. I mean, it was usually somewhere around 10 to 12 plus in the morning. I would round up. It wasn't we had like an observation.
Okay.
Center. So I do that in writing and various meetings. I would say one of the things I think I liked about it, although it breaks it apart, is that they, in theory,
that's the other thing we run into. So we've been given slots in the 3rd and 4th year track curriculum, and Katie and I are just thinking it's too late for some of this stuff.
Those people are overburdened.
So there's that as well. There's rigidity among the person who kind of administers the didactic curriculum about, well, we need to get these specific, DSM topics in because they need to know how to make diagnoses.
Maybe, at best sort of indifferent, and maybe at worst, the judge or sort of violate privacy. I didn't intend to do a lot of therapy. I didn't necessarily in my training think I'm going to go out there and do a lot of therapy. I was really somebody who thought
Dr. Kumpel is a strong advocate for it.
consults and crisis services and inpatients, that's who I was as a doctor, and maybe I'm still. But when you have a person in front of you who needs therapy, that's what you do. And it was actually, I think, incredibly rewarding. My favorite part of my job.
You've had a pretty robust stream of interest, so.
Yeah, no, that's required.
Yeah.
Yeah, we've pretty much come to the conclusion that the PTY5 model is not going to be for us. Oh, you know what I wanted to ask you about is the residency program director was asking me. Doing it the residency track way doesn't really change like the board, the eligibility to take the community psychiatry courses, right? It's very sort of label it as this additional training.
I didn't think it would be me.
Yeah, that's true. Most of it is.
So I think you just have to call it.
I guess we could call it.
I feel like it's true.
I think it's probably what's better. I can't remember what the line is.
Yeah, it says, I think it says, I have to go back and look at the A's.
That's what I almost
website, but it says, I think it does say designated fellowship. Do you think most of your graduates actually take the board?
Did not need it, and I won't do it. I just won't. I'm like, they threaten to fire me. They threaten to, go ahead and fire me. It's just like, where are you gonna get done with psychiatrist?
Okay. It's been been on my agenda to do as well.
Yeah.
Yeah, because it's not a requirement.
Yeah,
But
and that's
really,
the thing, it
So you are deciding CD that this person's medical needs were there was a there's a donor versus Hale's community psychiatry endowment fund that Dr. Hale's who endowed it at some point last year was really interested in getting a whole bunch of faculty to be board certified. And I don't really think it's the best use of our.
Okay, everybody, we need to rally the troops. We've got a couple more dynamic speakers here and we need to stay focused. So it is my great pleasure to introduce Stan Morosky. What I will say about Stan is that he was a wonderful partner with Erie County for systems of care work. And he has a wonderful background in design and leadership management, continuous improvement. He has held lots of positions in state government and in consultation. And he is going to talk to us today about workforce development and the Coalition for the Common Health. But he could talk a lot more about all kinds of things, and maybe he will.
So here's what I heard today. We have a mental health crisis. Well, it's really an emergency. You're like, I'm not so good, really bad public health emergency. People are dying from drug overdose, from alcoholism, suicide. In Pennsylvania and across the country, we've heard today, and we've known this, there's a dramatic increase in the number of people that are in need of behavioral health services and a very troubling lack of staff. So we have a really bad, not so good workforce crisis, probably a workforce emergency. What we haven't heard from are those people who are trying to get care. But I think all of us know that many times, unfortunately, it can be a real nightmare. We also haven't heard specifically from provider agencies, but my colleague Val heard from a provider recently who said, we used to get lots of bad applications. Now we don't even get those. We've together collectively come to the realization that we can't just talk about this, or what was it last night? We heard we can't just do white papers. We must do something. At PPLC, we're trying. I'm going to share with you a couple of things that we're doing to address various parts of the workforce need that we have. But I really also want to spend a lot of time discussing and having you tell us how we can fix, how we can address at least this workforce crisis. That's not what we want up. We want the outline. So you've heard Ken talk this morning about the centers of excellence. We have these 4 centers that since 2005, which is what I believe was when this started. During the period of time, there have been 70 psychiatrists who have gone, 70 folks who have gone through the fellowship program, most of them psychiatrists, but as Niels pointed out, not all, in a good way. 75% of those people that have gone through the fellowship have remained in Pennsylvania. So although the leadership from OMSAS is not here, we have told them that, and hopefully they'll continue to hear that. We have the video conference education series. Wes, maybe 1,000 people a year take part in that, do you think? About that? Yeah. Large numbers of people get educated about contemporary issues in behavioral health. And it's growing. And it's not just a state audience that we're getting, some people from outside the state as well. In regard to racial justice, you've heard a little bit about this learning collaborative. All 13 psychiatric residency programs in Pennsylvania have membership on this learning collaborative that meets once a month to talk about two things primarily: how to increase the number of Black residents in the residency program, psychiatric residents. And two, how to improve the education and training for all of the residents so that all of them, white as well as other ethnic and racial groups, can serve people of color more effectively. We also have a Black resident group that actually helped get this learning collaborative started. There was a roundtable of about 13 or 14 Black residents that we helped pull together, that provided input, and that led to some of the work that the learning collaborative has undertaken. And we've tried to encourage the Black residents to continue to meet, and they did. Some of them did last night, for example. PPLC has had a spirituality religion committee for about 5 years, I think now. Dr. Kathleen Klein and I lead that. And there are two areas that we're focused on there. One is education and training for behavioral health staff on how to feel comfortable and utilize the concepts of spirituality and religion for those people who want to have that part of their treatment. Spirituality and religion can be a very powerful resource for people. Ben Miller this morning talked about community interventions and about meeting people where they are. This helps do that, where people have religion and or spirituality as an essential part of their lives, and it can be a very important part of their behavioral health treatment. And then we've been working with folks from Wheaton College outside of Chicago that have developed something that's called spiritual first aid. It's a well-designed, based on evidence-based principles to train individuals from faith communities, and they're branching out into other communities as well, on how to help address emotional challenges of daily living. So again, as Ben Miller said, meeting people where they are. There are lots of people, not as many as there used to be, but lots of people that are still part of faith communities who are motivated to help others. There are people in faith communities that are struggling with daily ideas around daily life, meaning of life, how to deal with challenges. This is a way of helping develop a well-trained cadre of peers and tapping into the power of the spirituality and religion field. Let me stop there. Questions about any of that? Okay, we have given you updates. The PPLC has been receiving updates about some of these things, so you're pretty well familiar with that. So now we can go to the blue page. PPLC has been part of, actually, Dave Dinich was one of the founding members of the Coalition for the Common Health. It's a loose affiliation of about 20 statewide organizations that voluntarily come together to address healthcare issues. And what this coalition, which has people from family medicine, the State Nurses Association, oral healthcare, the Association of Community Health Centers, the FQHCs, are members of this coalition. The coalition has identified whole person primary care as the focus of its work and what it wants to advance. Whole person primary care basically is a person-centered, understandable, coordinated system. It's the collaborative care approach that we learned about a little bit this morning. That's from the University of Pennsylvania, but it's well known. But whole person primary care is the focus of what the coalition is trying to do. We have this opportunity in Pennsylvania. So while I talked about what I've heard today about the challenges, the negatives, there are some really positive things. This Behavioral Health Commission and $100 million is an opportunity. We have an opportunity with a new governor. There will be some legislative changes. We know that some of the legislative leaders didn't win their primary, so there'll be changes in the legislature. So there will be opportunities, pretty big opportunity to influence decisions at the state. So what the coalition has done is develop this one pager. We also have about a 3-page, it's in your packet, kind of background paper that helps explain some of these things. But what I want to do is go through some of these and then get your input on it to make sure that, this is, by the way, this is draft. The coalition meets next Wednesday to finalize this so that we can take it to the candidates for the governor and eventually to the new administration as well as to the legislature. So it's still a work in progress. So you have an opportunity to influence it. So whole person primary care is the focus. Along the left side, maybe Deb, if you can scroll up a little bit, we're saying there's 3 system change that's needed. And this is, again, back to Ben Miller, rethinking what we're doing, continuing to do, even as good as 100 million sounds, putting 100 million into things that don't work is not going to be very successful. What we need to do is have in-state government someone responsible for whole person primary care, for public health, if you will, that includes health, behavioral health, oral health care. We need to ensure that policies and procedures of all state agencies. There was discussion this morning about housing. So I think it's the Department of Community and Economic Development that might have that. Certainly economic development, jobs, there's labor and industry. All branches of state government have to be alerted to and understanding the importance that they play in the health and healthy communities in this Commonwealth. And we need payment reform. Payment that doesn't incentivize, that's negative, too many negatives there, but to move the incentives towards health and wellness, healthy living, as Lauren said this morning, promoting prevention and early identification that promotes self-care, early treatment, and this concept of collaborative, primary, integrated, whole person, behavioral health, oral health, physical health care. So 3 broad system changes needed. Then we have some priorities. These we think are more immediate, maybe some of them more doable. And again, this is where we want your discussion around some of these things. We need to retain the good people that are already in our system. So there need to be, this concept of livable isn't even sufficient. We need to have wage increases. We need to make health, behavioral health, oral health care jobs well-paying and appealing to people. Child care. We have an extraordinary challenge in this nation, really, and Pennsylvania is no different. Many people are not in the workforce right now because they're doing childcare. My daughter was telling me last night, she's a teacher. One of her friends says, I primarily am teaching to pay for the childcare for my 2 youngsters. Some people aren't willing to make that trade-off. Childcare is an extraordinary challenge for us. We need to address, we need to recognize that and do something. People now, maybe it was COVID, maybe this was happening anyway, maybe it is the new generation, but this concept of work-life balance is very important to people. Probably should have always been, but it's now recognizable and employers need to know that. Sidebar. I live in this central Pennsylvania area. There's a manufacturing company, I forget what it is. They're advertising starting wages of $20 an hour and guaranteed 7 days off consecutive each month. It's a week vacation each month that people can take. To know that you have that kind of talent. I don't know what they're, I don't know if they make you work 6 days a week or something, but it's a manufacturing organization that's alert to the need for better wages and for this work-life balance. We in the healthcare and human service behavioral health world need to be competing with manufacturing, with Amazon, which is also paying $20 an hour, for warehouse work that doesn't have a lot of stress to it. So no question, we need to retain the good people we have. We need to learn how to attract people. And part of that certainly is wages. We've talked about this a little bit this morning, career building and the infrastructure that can support people learning about healthcare, behavioral healthcare work, and wanting to move into these careers. Campaigns to promote this are necessary. And some of these things aren't really expensive, and some organizations already have some responsibility for some of this. It just needs to be organized and a focus. There are roles that various positions have in the health and behavioral health world. We need to help people be able to practice to the fullest extent. So there needs to be a look at what is prohibiting people from doing what they're trained and capable of doing. We need to look at ways in which people can be more readily licensed. There were some good discussions this morning about the program in Lancaster County that Anna talked about a group of organizations coming together to support social workers getting their licensure in an affordable and streamlined way. The State Department, the licensing, if you're familiar with the backlogs, we have an antiquated licensure system in Pennsylvania. That needs to be fixed. One of the things around this collaborative care, whole person care concept is the need for consultation to primary care teams. And so there's an ECHO program that you might be familiar with, might have heard about, provides psychiatric consultation to primary care physicians. Again, in the do things differently, if it hasn't been working well, we've learned a lot today about how effective telehealth has been and how it can continue to be big. About half, I think it was 40-some% that Sally Walker talked about in her rural area that want a blend of telehealth and in person, and another, if I remember, 18%. So, a majority of people are willing to do telehealth for behavioral health. We need to make sure that continues and to make the maximum use of that. Because people aren't getting their mental health care readily available to them, they're searching. And so there are multiple ways of getting help online. Is it any good? Well, that's questionable, isn't it? But there are apps, and there are bloggers, and there are people that set themselves up as counselors. We as a profession need to look into this and do something about it. Use it, obviously. Apps and wearable technology are ways of helping us, of helping people deal with anxieties and stress and depression. Let's find out more about how we can use this, and let's look at artificial intelligence and move our system to where people are, not making them come to us, as I think it was Ben Miller that said that this morning. There is ways to monitor, so we can help people monitor when their anxieties or their suicidal thoughts are getting the best of them. There are a wide array of wellness supports, and we can maximize use of that. And then the final kind of major point that we have, and these are streamlined, these are very watered, if you will, summarized. The final one we have here is we need to, as we said earlier on the left side of this page, to have a structure that incentivizes wellness and working community settings and integrated care. That's what I have to present. Now I want your ideas. What's missing, or what can we embellish? We have, again, we have an opportunity to tell the incoming governor, the new governor and his administration on what they should be working on, what they should prioritize. So what would you tell the new governor?
Take my privilege that I have a microphone. And my first thought is to scroll back up, and the editor and me, don't forget the D in child care reimbursement when you make your final draft. The second part of that, though, is really about child care and how we value that as a nation, as a community and society. We don't. And so we have very underpaid, very understaffed, and undertrained folks caring for children. If they are able to care for children, because now we also have just that workforce, many closures and not sufficient space for children to be cared for well. And so I think we need to partner in this particular area with that childcare serving universe, and we need to get to know them as good partners. For me, as a child and adolescent psychiatrist, we need to prioritize prevention and early intervention, and that is really helping families raise their children well so that you have living healthy. So that's just my 2 cents, and looking at partnership. The other is just, if I scroll further down and think about telehealth, it scares me that we will stay in silos in that universe and not look at valuing team, collaborative, coordinated care across whole health systems. Okay, who wants to chat? All right, start with Amy.
By the way, thanks, Mary Ann, and your 2 cents, even in this inflationary time, is very valuable. So I thank you for that. And it occurred to me that if we do a better job with childcare, we will have healthier, more well-adjusted children that are in our schools and become healthy, well-adjusted adults.
Hear, hear. I don't see much in the space about loan reimbursement specifically. And I mentioned earlier, I did all my training as a single parent, so I had crazy loans because there's no money for childcare. And then worked in a prison where I was a contract worker, so I can't get the public service loan forgiveness. Tried to go to Pennsylvania State, and they said we give 9 physician awards a year across all specialties. Got caught up in the National Health Service Corps and lots of issues with them and whatever else. I won't bore you all with the details of my specific life, but I kind of wanted to tell my own story briefly there to say that these are interconnected issues. And at least for me personally, they've made me feel locked out of doing work. A lot of parameters around what work I can and cannot do and what I need from my employer. I think that having more attention on loan forgiveness and help with that would be really important for our state.
It's an oversight on this page. Thank you for bringing it to my attention. We had it on there, and when we were kind of trying to make this look, if you will, on one page, but loan repayment and for a wide array of health disciplines, psychiatrists certainly, but also social workers, licensed professional counselors, and even if it had to be tied with like a 2-year commitment to staying in public care would be something we'd like that. Niels.
It's someone who had to unfortunately not be in the rural public psychiatry space as of December. And it really was centered around childcare. Schools were closed. We had to prepare for the next school year. With the looming specter of 100% return to work with no reimbursement for any telehealth or telepsych through that agency, it's like, well, and they said, well, could you do it for us 100% of the time, telepsych? Well, I said, I don't know, can I? Not because I want to work from home. I need to provide care when I need to, and sometimes it's unplanned and unexpected. And that's just even before like just illness and stuff. It was just because of closures. And then, going from a highly regulated, because of, great organizations, but, just operating in that space, then to going to a space where, we're not required for a lot of those bits of paperwork. You really do have more time and can see more people. And I'm still seeing Pennsylvanians rurally. And I mean, that hasn't changed because individuals still sign up for these types of services, but I'm seeing people in rural Pennsylvania, rural Florida, and probably next week, rural Texas. So it all kind of, it still somehow plays out. And then even with some of the loan forgiveness options, if you then read the terms, it is adversarial. I mean, it's almost very reluctant to even accept the money because it's a cudgel. And it is, the terms are really yes, they want return on their investment, but wow. And I've haven't had the opportunity to participate in the Pennsylvania loan repayment, though I've tried to, I've applied and it's very limited. So that's been a challenge, but I didn't go for any of the national nursing core options because the terms are preposterous. And I would never, it's just fiduciary responsibility. I would never agree to that. It's a loan shark. It's like, I don't know. So there's a lot of challenges, but having had to bear some of that out, I can certainly identify with what you put in there, and they're great points.
Yeah, thanks. Yeah, I think there's a culture change happening in the employer-employee relationship. It used to be the employers had the upper hand. They had plenty of people that would be applying for jobs. If you didn't like it, you leave and they get somebody else. Now it's just the opposite. The employees have a lot more, and maybe we can get some of these kinds of things changed so it's not so oppressive, so that it's easier for people to get loan repayments and to get forgiveness, so that we can keep them in the system. Yeah.
So in terms of loan repayment, I think that folks who are probably my generation and younger understand that sort of the loan payment programs out there are, I think maybe Nils just said, not even a drop in the bucket. It doesn't even start to cover the amount of loans. I mean, even for a social worker, you're looking at somebody who's in $60,000, $70,000 of debt after graduate school. And what's been happening is that we're really having more conversations around front loading that relief, because we're asking people to take such a financial risk to work for their community, and to really make it clearer to the people who are thinking about loan forgiveness on how to move that money to the front rather than the back. Because we do have programs that work. Even in this state, we have CWIN, who Sally's not here anymore, but that's the child welfare program for social workers. And because they understood that there was such a need for workforce in the child welfare world, they found a way to pay for graduate school and undergraduate school for potential social workers. And that includes the fact that you're given a stipend and money for books, and they pay for your education. And yeah, you work for child welfare for 2 years, but it's really this idea of front loading that cost so it doesn't feel so risky to get into the field. And I mean, I've been talking to lots of residents this weekend, and I talk to social workers all the time. It's a risk. And that's what you hear people say. I'm putting out all this money, I'm putting all this time, I'm putting on this effort. And in some spaces in the social work field, we're at a crisis. Our licensure exam, we just found it to be tremendously racially biased. We're almost 50% of Black social workers taking the LCSW exam for the first time are not passing. And that's a big, big problem. So I think really thinking critically around what are the barriers for people to get into school, move forward, get those licensure exams. And we'll talk more about that, I'm sure. But I just wanted to have us think about not maybe the back end, but the front end. How do we help people at the beginning?
Yeah, you've made the point to me that the only people that can afford to get social work degrees are people that are in upper class, which is fine, and they're probably well motivated, but we need people also with lived experience to be social workers, and they can't afford it right now.
And I would add those that work really hard for in social work, as well as getting into medical school. Right now, we have folks that graduate medical school and can't get into residency programs. They're now in debt, and they don't have a way to finish their education, let alone pay down the debt, because we don't have sufficient residency slots. So some of that fiscal infrastructure is upside down.
Yeah, we think our bigger paper references something about for people that don't get into medical school, although we could include people who don't get into residency. These are people that have the interest, the desire to do something in the medical healthcare kind of field. If they don't get in, there should be something else that we can offer them. This is like a group of people that we should be recruiting from.
We have someone online.
Hi, thanks so much for listening. For the first time in my 25 years of working in workforce, the legislature put additional funds, actually substantial additional funds, in the primary care loan repayment program for this fiscal year. And the health department reports that they are funding about 25% of the applications that are submitted. One of the challenges is that it is the definition within the legislature of what is considered, actually within the public health code in the state, what is considered to be primary care. So if you are going to be making some inroads with the legislature, I think looking at that definition of what is primary care would be really helpful. At the federal level, they increased that definition. It always included psychiatrists, but they now have also included marriage and family therapists and so on, social workers and so on, outside of the traditional MD nurse practitioner group. So just as an FYI, but I completely understand that it's a laborious process to apply. And then once you are accepted into loan repayment, you have to really follow the rules pretty carefully.
Thanks for that comment. Yeah, that fits with our whole person primary care concept. And if we can convey that message, it might get some change to the loan repayment guidelines. For those of you that are here, and I guess we could send these out, but the little 3-page talks about some additional things that didn't quite make it onto our one pager. And one of them is, and I sort of referenced it when I said practicing to within the scope of practice, but there are, we're trying not to use the word extender, that's seen as derogatory in many cases, but there are community health workers, or there are peers, there are dental therapists, that can expand the work that's being done. The dental area is extraordinary. The woman from the World Health Association said that in some places in the Commonwealth, it takes 2 years to get a dental appointment if you're on Medicaid. In 2 years, you're losing some of those teeth that are causing you problems, or you're having such health problems, oral health, that it causes other health problems. That's unacceptable. So, but Pennsylvania doesn't have dental therapy. About 20 states do. But that's something that we, to change the system, we should look at that.
Stan, I don't know if the issue of trying to figure out what the designated, health person power shortage areas came up as a topic. I know that the state has an office in the Department of Health that will help communities define themselves as health person shortage areas, but it's a challenging task. There's not a lot of support for it. It's left to each local community to do it. And if the local communities don't do it, and there could be myriads of reasons why they don't, from lack of resource to actually having people who don't want the area declared because they've got a lock on the patients that they're seeing and they don't want to have anybody else come into the area. That one of the things that would be really helpful is to have the state actually decide that it was going to start a process of eliminating health shortage areas in the state as a concerted effort, and that it would do the recruiting and the work that was necessary to encourage people to fill those things. And if people did do it, that they would get some recognition. I think probably even beyond what they get in terms of the financial support, in terms of loan repayment or whatever. But a lot of people, if they do this, it feels like they're stepping off the ladder. They're getting out of academics, or they're going out of the big system, or they're doing whatever. And then where does their career go? Right? They're left in some small town in Pennsylvania, which maybe somebody wants to be and should be, but they don't feel like they're connected to anything else. And they kind of have committed professional suicide at a certain level to do that. So, so I think if there was a concerted effort at the state level to really decide that we weren't going to have shortage areas and work towards that, maybe that would help.
It's an interesting concept, isn't it? We know we have this problem. Let's say we're going to do something about it. I may be unfair. I don't know if the state health plan says that, but if it doesn't, it sure should.
Eliminated health disparities in those areas. I'm not sure what the politics of that is, but I know it's been a big issue for people trying to get that money, as they're like, wait, this wasn't, now it isn't, why,
Okay.
Hang on.
Like he needs a microphone?
I know.
Well, for those people that are out of state, I might need the microphone. Just an observation, having attended a number of state health plan meetings, and we have members that are on that SHIP, the state health plan process. I can tell you that I've never been to a meeting of I served on the mental health substance abuse task force of that group. I've never been at a state health improvement meeting at which there was an appearance by the Bureau of Health Planning, which is the group that we're talking about here. That's the group that actually would go out and find health professional shortage areas. I've never been in a meeting where they attended. That's the same department. Never been at that meeting. Thanks.
I think that speaks to our silos at the state level. Who talks to who participates, how do we partner? And that's a heavy sigh. Go ahead, Sierra.
So, hi, this is Lisa again. Actually, every state receives funding from the Health Resources and Services Administration to have a primary care office, which is what the office is that does the designations. And I would suggest that it would not be a good idea to recommend that the state not do those designations. There's a significant amount of funding that is and programs that are tied to those designations. And it is not necessarily a community's responsibility. The state our primary care office has to verify all of the data that are collected and reported, and then they have to submit those data to the Health Resources and Services Administration to get the designation. So some communities have paid for a consultant to come in and do all of the data collection and verification of providers, but the state then is required by the federal government to verify all of those data. It is a quite laborious process, but the state does do their very best to try and get through those designations. Just so you know, there was at the federal level an automatic health professional shortage area process that was being done where they were actually de-designating a number of designated areas across the country and also here in Pennsylvania. There was a huge outcry and they have actually stopped that auto designation process, which is great. So that is one thing. The other piece is about the State Health Improvement Plan. I've been serving on that committee since SHIP started in 1999. And the group that heads up the development of the SHIP and the state health assessment used to actually be in the same office as the Bureau of Health Planning, but then they moved into the Office of Operational Excellence, I think is their current title. And the office that was doing all these designations changed its name to the Primary Care Office. So there is a lot of connection between those two offices. And I agree, they have not been sitting on the current or even the last SHIP, but it doesn't mean that they aren't available. So just wanted to offer up those comments. Thank you.
Thanks for that clarification. I gave you 4 minutes. It looks
You
like.
gave 4 minutes over. Thank you very much, Stan.
Thanks, everyone.
Okay. So we're going to press forward. We are in the final stretch. And I don't need to really introduce Ken. I think he's been speaking today and we all know who he is. So Ken Thompson is going to talk to us about creating a healthy community with ICT.
Thank you, Marianne. So I recognize that we are down to dwindling numbers and you guys are the stalwarts and I appreciate it very much. I'm going to do my best to make this pithy and still a little interesting, and then we're going to get to the end of it, and then just have a couple of moments to reflect together on what we've heard today. I do hope to get you out of here earlier than we anticipated because we like to under promise and over deliver, right? That's the right word. So what I want to talk about now, just for a bit, is this whole idea of integrated community therapy and what's called solidarity care. And the tagline, "Community is the best therapy," is actually a crib from work that's being done in the UK, where they're talking about community as the best medicine. This is an idea which I hope to explain a little bit as we go forward. So next slide. And thanks, Deb and Val, for getting my slides up on the screen here. It's really appreciated. And the AV guys who've done a tremendous job getting us online, bringing us into the future. We're really, really, really happy about that. And I think we've had upwards of 40, maybe more people who participated online, which just is just a good sign, because that means that that's a little less carbon going into the atmosphere and a few more people who were able to watch their kids into the future. So what is integrative community therapy? I'm going to talk a little bit about ICT and collective trauma, and necessity being, I don't know if you guys have heard this before, but sometimes it's the mother of invention. Unfortunately, in mental health, sometimes necessity seems not to be the mother of invention, and we just kind of wait around and wait around and wait around until it decides to deliver. I'm going to talk a little bit about the practice of ICT, and I'm going to talk about some reflections on solidarity care and mutual aid and its use in the Anglophone, the English-speaking world. So next slide. Just so you guys know, this idea of climate change plays out here in an interesting way. Brazil, as you've probably heard, has been suffering the demise of the Amazon and the Amazon rainforest. And the thing that I hadn't really appreciated about that is that when they cut down the rainforest in Brazil, they don't continue to have rain in the areas where the rainforest used to be. The rainforest kind of generated its rain. When you cut it down, you have desertification. So in Brazil, in the interior, it used to be filled with lots of people. When they cut down the jungle, when they cut down the rainforest, the area became a desert, and people kind of cut themselves out of their own place of living. And they've gone in large numbers into the urban areas of Brazil. Now, I'm going to tell you why I'm talking about Brazil in just a second, but just suffice it to say that a lot of people in Brazil got displaced. They went to urban areas in Brazil, and they got congregated in large shanty towns known as favelas. You may have heard of favelas. They are very, very challenging places to live with very limited resources, under constant assault from the police and the army, and frequently knocked down and people displaced again. So people have moved, they've gone to the favelas. Go to the next slide, please. One of the favelas is the Pirambu favela in Brazil, in a city called Fortaleza. Fortaleza is the biggest city in Brazil that you've never heard of. You've heard of Sao Paulo, probably. You've probably heard of Rio de Janeiro. Fortaleza is the third city. It's up on the northeast coast. And it is, it's supposedly a beautiful place right along the Atlantic, except for the shanty towns and the favelas that have evolved around it. One of those favelas, as I mentioned, was Pirambu, in a small neighborhood. You can go to the next slide. Small neighborhood there, or a small portion of the favela, which was called Quatro Varas, was being knocked down on a regular basis by the police, and a human rights lawyer got involved. This is starting in the 1980s. A human rights lawyer got involved, and he happened to have a brother who was a psychiatrist at the university there. And he called his brother and said, "Could you come to the favela and help out? Because, you know, the folks here are heavily traumatized. And they're dealing with all kinds of challenges of poverty. There's endemic crime in the community. There's, you know, families that are really challenged and broken, kids who don't have parents, all the kind of stuff that goes with very serious social deprivation and oppression." So he called his brother, whose name is Adalberto Barreto. And Adalberto came to the favela. He brought a couple of medical students with him from the university. And he did something that I wish I had done, but I just couldn't think like this. he sat there and he asked, he said, I'm here to provide psychiatric services. And he found, when he got there, there was a line around the block of people waiting to be seen with psychiatric challenges that they were facing, right, of all kinds. And he looked at the line and he said, I have no idea how I'm going to take care of all these folks. And he tried, he made an effort to provide sort of clinical care. He said to somebody, you know, look, what's happening? And the person said, I can't sleep. I'm very distraught. And, you know, it's really a problem. He said, well, I could help you out with some medicine to sleep. And the woman said, no, that won't do because I can't afford the medicine in the first place. That's not going to solve my problem. And so he's like, what the heck am I supposed to do? How am I going to take care of this challenge? And then somehow, and I still haven't gotten the specifics of this, but somehow he observed something that all of us have observed. He noticed that people in the favela came up to this woman and kind of tried to take care of her. Somebody started to rub her back. Somebody said, could I get you a glass of water? Would you like to sit down? You know, just things that sort of tended to her. And Alberto walked away from that and said, wait a minute, maybe the secret to figuring out how to do something in this community is to figure out how to help release that capacity for each person to help the other person, take care of the other person in some way. How can we make that happen? What's the platform that will allow that to happen? I mean, it happened anyhow, you know, at some level, but it was not obviously enough because there was a line around the block of people showing up. So let's go to the next slide. So what he invented with the help of the folks from the favela, so it was a joint co-production, is this concept of integrated community therapy, which is large group dialogic, we call it therapy. It's really kind of therapy and social and emotional support. It's got as much sort of prevention to it or promotion to it as it does healing. It's got all the elements at the same time. So it's a little challenging to capture it in these words. And he invented this concept, and it's now spread throughout Brazil. There are 40,000. We can go to the next slide. There are now 40,000 facilitators trained to do this kind of work, this kind of group work in Brazil. They don't have to be professionals. In fact, the vast majority of them are not. Most of them, in fact, are community health workers who've been trained in this kind of method. And so it started as now it's almost 35 years they've been doing it. We're now trying to bring this method to the United States. It's spread throughout Latin America. It's being done in Asia. It's being done in Africa. It's being done in Europe, but it hasn't been done in a North American context or to that matter, an Anglophone country before. So this is an example of what it looks like. So up in the top left is an example of what we call an ICT round. So people are in this grouping. On the lower right there, that's a picture of a Zoom meeting that we did, an ICT in the United States. So before, obviously, this was all done, in person. And the radical change was that when COVID happened, and I won't go into the details of how we managed to get involved with ICT as COVID emerged, but suffice it to say that we did. And as a result of that, most of our work has been actually online, on Zoom, doing work like this in groups like this, so online. Part of the rationale for what ICT does is that it's a place where people are asked to express themselves and talk about challenges, emotional challenges that they have. There's a Brazilian saying, as you see here, when the mouth is silent, the body speaks. When the mouth talks, the body heals. So the concept is that people, in talking about what's happening with themselves, that this is by its own nature, by its expression, something that has utility for people to take care of themselves. Go on to the next. And the work that's done in an ICT is not necessarily to take on the most challenging thing that somebody's had happen to them in their life. In fact, we're involved in the public display and discussion of people's feelings. We don't ask people to talk about secrets, because secrets are very challenging, and secrets are things that people don't want to talk about and don't want to have be public, and will obviously generally not talk about. So we tell folks, we're not looking for your secrets. Those are things that if they're really challenging and troubling, that's another place to talk about those. So we're not taking it away from the intimate clinical experience of that, of those kinds of circumstances. But we are talking about the kinds of challenges that you might have, say, with childcare, right? Or the challenges you might have with any business or job that you have, or relations in families that are challenging, various kinds of in-laws, et cetera, et cetera. So Muhammad Ali has a convenient quote. I didn't know that Muhammad actually knew a lot about therapy, and particularly the ICT, but it isn't the mountains that you climb that wear you down, it's the pebble in your shoe. So what we talk about in the ICT settings are, what is the pebble in your shoe? What is it that you're confronting on a day-to-day basis that's kind of wearing you down? Go on to the next. I'm going to talk a little bit about what the ICT looks like. These are the rules, right? People speak only from the position of the I. So you don't tell people what to do. You don't give advice, judgments, anything like that, interpretations. The most important thing that people do is listen, right? Be silent and listen to other people. And then each person reflects from their own experience, if they want to share it, how what they heard from the other person impacts on their lives and what they've learned in their own lives. And we use all kinds of methods to get this stuff expressed. So music, poetry, the Brazilians really like to get up and dance. That's part of the culture. It's really, really hard in North America to get Americans so far to dance. I think we'll find that there are pockets we'll do it, and we're hoping we can figure out how to get more people up and moving around, because the body and the mind are so intricately entwined. But poems, jokes, anything we can use to kind of help people make a connection to the feelings that they've expressed and the circumstances that they're in, and share. So ICT sessions involve anywhere from 100 to from 10 to 200 people, usually around the range. We try to hit somewhere between 20 and 40, 50, something like that. Generally, they've been focused on disadvantaged communities, but as you heard me talk today, we've heard from college students that they think this method would be really helpful, and even on campuses. And the process is, you give the rules, you welcome people. Actually, first, before you give the rules, you welcome people and you set the tone of this event being something for people to participate in as they see fit, that it's most important that they are able to listen and to talk about their own experiences when and if they feel like doing it. We share celebrations and gratitudes as part of the opening process. Then what happens is we ask people to nominate some challenge that they've got. And usually in a group of, anywhere from 10 to 50, as I said, we'll get 4 or 5 people to step forward and say, here's a challenge that I'm facing on a day-to-day basis. And the facilitator's job is to take that challenge and generalize it enough that it becomes kind of part of the human condition that everybody can react to and relate to. And then we ask people to talk a little bit more about the person who gets, the people who put up their pebble for consideration, to talk just a little bit more about what those challenges are. And then the group actually decides as a group which of these topics is the most important of the topics for that group to talk about that day. So it's an actual selection by the group of which theme they're going to focus on. And when they focus on it, what they then do is to talk about their own experience with a similar situation and what they have done to overcome it. So people end up sharing similar experiences, make that connection, and then people share how they've managed to deal with that particular challenge or problem. It is a pretty striking experience when people do this, to kind of resonate with each other and to also hear different ways that people have experienced the problem and how they have managed to find ways that they live with it, overcome it, or manage it in some way. And then after that process is done, after people have gone through that, the next step is for folks to reflect on what they've heard from each other and to share that experience and give and say to the people who said it, what you said actually touched me in this way, to express some gratitude from what they've heard, to express gratitude for the people who shared the pebbles, and to essentially get across the idea that everybody has something that they can contribute in terms of how these challenges are dealt with and managed. And there's something to take some gratitude out of in a gift. So there's gift giving throughout the group. And then there's the concluding ritual, which is that everybody stands up and we, or in the Zoom, we reach out and, touch the different corners of the box that you're in and try to make hand connections across. Anything you can to sort of show that there is an awareness that we have all experienced a linkage and a connection around our feelings, because the talk is about feelings, that is very unusual, particularly in our culture. It just doesn't happen very often. So that's how it runs. We can go on to the next slide. This literature is, there's a literature out there. It's actually fairly extensive. Of course, most of it is in Portuguese, but a salient finding is that when people are referred to an ICT group in very large numbers, it turns out that about 87% don't need to be referred on for further therapy, for further work. They resolve whatever challenge it is that brought them in the first place. And I should say a word about how that happens. In Brazil, the primary health services are funded by the Brazilian National Health Insurance. It's not a very wealthy service, right? But they have primary health stations throughout the country. If you go into one of those settings and you are noticed to have some kind of emotional challenge, that you're dealing with some kind of stress or strain that you're under, the primary health folks will refer you to the ICT that's being run by a community health worker in the church courtyard on Thursdays at 1 o'clock. So go to the ICT, participate, and become a member of it. There's no requirement that you go for any length of time. And truthfully, for this effect to work, it seems to be that there is a dose effect, that people, if they are going to avoid further troubles, it really helps for them to go to more than four sessions, but not much more than 4, to have the initial challenge resolved. So we can go on. Next slide. So the idea of the ICT is that it's about community building. This is very different than ordinary therapy, right? No, there's no therapy that we do that's actually about community building. It's about promoting a sense of shared suffering. Most of the work we do actually isolates people, and there's very little sense that they have shared suffering unless they find it together and come together around it. It's about providing a place of inclusion and diversity and of sharing experiences to promote healthy coping strategies. And by emphasizing the community building, it creates this sense of community collective healing and community collective capacity with an increase in resiliency. So that's the thought behind ICT. It's particularly useful in communities that have been disenfranchised or have had limited resources, because it does mobilize in those communities capacities that the communities may not necessarily be aware of within each other, and sometimes are hidden from them. So we can go to the next slide. Just some of the comments that or concepts that are undergird the whole idea of ICT is this concept of emotional literacy, conscientization. Much of this work derives from the theories of a guy named Paulo Freire, who was a Brazilian pedagogist who wrote a book called The Pedagogy of the Oppressed. And his key point, among others, but the essential one is that there is no such thing as an expert and or a teacher and a student, that a teacher has the role of being the teacher and the student has the role of being the student. That in fact, in any real adult communication, the teacher and the student are changing places all the time, right? So the idea in the ICT is that the facilitator is not an expert. The facilitator is a member of the group who helps the group run itself, but doesn't have answers. The answers reside within the group. In that context, and the notion of conscientization is the idea that when you talk about the challenges that people have in their day-to-day lives, they begin to think about the circumstances, the shared circumstances that they share together in those lives. They become aware of the social circumstances that are driving much of the challenges and the suffering that they're experiencing. Of course, key to this is this idea of solidarity, and I talked about the idea that that I mentioned solidarity care. The Brazilians call this whole approach solidarity care. The idea that human beings, when they connect with each other, actually provide and deliver a mutual benefit of self and mutual aid, of caring. And it is in the solidarity, it's in the feeling of being a member of a community, of being connected, that the process, I think, of healing that solidarity care unleashes really begins. And yeah, so just to talk about it really briefly now, and we'll come to a close, I think, in a couple minutes. I can give you a lot of reasons why I think an approach like this is really important. We have many, many collective traumas that we are experiencing, and those traumas do not do well to be talked about only in an individual context. I think it's really critical that we begin to think about how we have traumas and experiences people are having talked about in some collective way. So go on to the next. I'm sure if you look at this, you see what the traumas are. We know all these different ones, from the deaths of despair and deindustrialization to the ongoing political context that we're living in, to climate change, et cetera. So we can go to the next. So this is just really an enumeration of all the challenges that we're facing right now and why it's important for folks to come together in some kind of a community capacity. We can go to the next. Part of the argument that I would make is that there is a certain degree to which the processes that we've lived through, and particularly the way we have been governing ourselves and thinking of ourselves, that we have been consistently dehumanizing ourselves. I don't know if you guys remember the movie The Never Ending Story, but that's a children's fantasy about what's called the Great Nothing, which is consuming the world, right? And it's mirrored in the comments of Maggie Thatcher and the kind of political regimes that we've lived under for almost 40 years now, that there is no such thing as society. It's every individual on their own. We are all out here just by ourselves, whacking our way through the jungle, which, by the way, in that configuration is other people, right? Not a context in which being a human being, the kind of human being that I would like to be, and I imagine many others would like to be, is really going to flourish. So that's the context, I think, the really context, the undergirding context of ICT. It's mirrored in the limitations of clinical care, and we've sort of talked about this in various different ways. But the first one that I'll just describe, and we've talked about this kind of ad nauseum, is that there's just not enough clinical care providers, right? We need more. There's lines of people waiting to be seen. It's like Adalberto's gone to the favela again, and all the people are standing around in line, and he's thinking, well, let's bring a few more therapists with me. And you go and you bring a few more therapists, and the line gets longer. And you bring another therapist, the line's even longer, right? So the challenge of the immediacy of providing clinical care is that we will never have enough, not given the circumstances that we're in, not given the challenges that we're just not going to have enough therapists, trained professional mental health therapists to address these challenges. So that's one limitation. The second limitation, which I think really fits, I haven't used the word neoliberalism, but when I talk about Maggie Thatcher, that's a term that's underlying this idea that it is every individual for themselves. The problem with the way we do clinical care is that we basically say that over and over and over again, that it's your private problem. It's a problem that's so private, nobody should be hearing about it. We should have HIPAA forever, and everything that you have is your private thing, which is kind of true, right? All of us feel that at a certain level. But at the same time, every time we do that, we disconnect people from other people, right? We say to them, your private suffering is all yours and nobody else's. We say, your private suffering is the suffering that only you, and maybe me because I'm a clinician, can understand. And we kind of build ourselves a box that we can't get ourselves out of, because the capacity for other people to be useful to folks, I think this is the reason we're moving to team-based care, is that we're trying to find a way to create community for people. But we're doing it the only way we know how, which is clinically. So where is ICT going? We are in the process, we've created a nonprofit called Visible Hands Collaborative, which is now in operation. I had no idea how much work and how hard it is just to create an organization that makes no money, but apparently it's really, really hard. And we've started the process of trying to bring this idea of this innovation to the United States. We're trying to translate it into the American culture. It's not a simple thing. I mean, there's a lot about Brazil that unfortunately is really like the United States. There's a lot about Brazil that is also like the United States and good. But the challenge of getting this method, this innovation into our system is really quite extensive. And I've been talking to other people who've been trying to bring innovative services to the United States of various kinds. You heard about the friendship bench and various other things. It's really difficult to get these things in. Even getting LOCUS, which is a homeborn thing, into our system has been really challenging. The only thing that I can hope for is that we have so much pressure on us to find other solutions, to try to innovate, to try to do something different, to try to go for a bigger score than the little bit that we can continually try for with the model we've got right now. What's this? I have no idea if Einstein actually said this, but supposedly Einstein said, you know, the height of insanity is to try to do things, same thing over and over again and expect different results. So if we try to keep doing the same thing over and over again, we're not going to get anywhere. Is this something worth trying? And we are now trying to build out the capacity to do ICT, to train people, to develop trainers, and to bring this to the United States. So next slide. Thank you very much. And let's go. These are ways to connect. If you want to learn more about ICT, you can go to the website there and connect with me at the website, at the email there. And then this is a saying from Brazil: a community without solidarity is like a spider without their web, or an Indian without land. So no solidarity, no community. Thank you very much.
Okay, it is 4:26. I will just say I had the opportunity to participate in one of the Zoom examples of the ICT. And it was really a wonderful evening experience, listening to folks share their pebbles, and for us to think about which one we'd like to tackle and the process of doing that. The introduction of music to that, all of it was quite impactful just for a single episode experience. So,
Thanks, Marianne.
yep. Jim.
I did the same. I sort of had heard you talking about this a couple of years ago and thought I'll check it out. And I think maybe I went twice, and I was really intrigued. I'd say what I remember is the climate of friendliness and welcoming. It was notable because I was awkward, sort of embarrassed, the kind of things that Americans sort of get embarrassed by. I mean, I was doing an American version of a dance. It was like this. And, you know, and they actually chose a pebble that I brought in the one night, which was the frustration of dealing with people who were just fighting the rules of COVID, not wearing a mask, not undermining the mandate, which we had. And the process of getting that clarified. And then, as you said, it was like my little suffering of the day from that. I wasn't alone. I mean, it was I forgot the quote there, but the shared suffering component of that is what I really remembered and noted. It was also when COVID was tough, everybody was looking for community somewhere, like on Zoom. And there were some other places, like some friends had a salon, and that felt similar, but this felt like structured so that you could, you know, you didn't have to get invited by a friend. It was like, you knew what was happening. You know, you could go, it was sort of scheduled there, but not overly mandated. And I'm very intrigued. I really had a good experience, and I'm glad to see us translate this more. Yeah.
I will say that we're looking into, I'm working with some folks from the creative therapies, particularly dance therapists, to have them help us figure out what are the things that we can do that will get Americans to be able to use their bodies a little bit. You know, so we'll see. We're going to try to build a little slightly more US, and obviously we'll change from culture to culture what music and how we do it. But we're looking to sort of make sure that the body doesn't get neglected, and you're not just left feeling like the only way you can go is like this, Jim, because that's what I was doing too. It's like, that's my dance. Like, really, so embarrassing to like move around. Anyhow.
Which felt like an icebreaker, and which maybe actually kind of froze people up a bit. There might be another version of an icebreaker.
Yeah, no, that's what we're looking for, exactly.
Without too many words, but you know, maybe something.
Yep.
My name is Andy. I'm one of the public psych fellows from Penn.
Welcome.
I also dance like that. But I work in a clinic with not enough therapists, too many patients, impoverished area. And I feel like this is something that would be beneficial to implement. So my question for you is, how are you recruiting facilitators? You know, we have, I think, certainly a number of good candidates for it. I'm just curious, is this something that you were looking for, like applications for?
So we are, we'll be announcing trainings over the next period of time. We're doing them online. So far, we did do a training in Pittsburgh in April, and 5 of the 40 people came down with COVID. So we decided probably ought to not do that for a little while and see what we can do into the future. But there is online training. If you pay attention to if you're interested, one, I'll make sure that you hear about it anyhow. But we have some folks in Philadelphia who are doing ICT right now, particularly with Spanish-speaking community. So yes, so trainings are coming. All of our trainers so far are folks from Latin America. So, but they speak English. So we're trying to get more folks here, and then we want to get some trainers here to start bringing this out in full scale. Who else? Hi, Rachel.
Hi, quick question. So I guess thinking about sustainability, and I imagine that this would be very like this may not have occurred yet, since this is still, it sounds like very new to the US, but as far as say this being like a billable service to make it sustainable in like a US mental health setting, is this something where potentially could be billed just as group therapy, or is that something that your team has explored?
Well, we would absolutely. Couple challenges. One is that at least in Pennsylvania, a group has anywhere from 8 to 12 people and no more or no less if you want to bill. So that's a rule that they have in billing issues. The way the Brazilians have done it, and the way I think I'm tending to lean, is that the vast majority of ICT would be done ideally by folks who are community health worker, peer support folks who are running these things in community settings out of community organizations. Or now that I've gotten this idea from the students, on campuses across the country. And also in some connection or context of primary health services. If we can make this a skill that's part of what being a community health worker or a peer is, that seems to me to be the easiest way, because then it doesn't have to be billed for. What has to be done is that the people who do the facilitation just have to be paid, right? And that would be part of their job. However, if we bill for service and we have 50 people in a room, you could charge them very little money and you could still make a significant amount of money in an hour and a half. So, we'll see. We'll see how that all shakes.
Jeff.
Yeah.
Oh, go ahead, Jeff.
I too had the chance to sit in and thought it was echo what everyone else shared with their experience. Probably 3 quick questions. One was sort of, you touched on a bit, but I think group overall has been vastly underutilized as a modality, both in the sort of professional and non-professional areas. And, we were actually just talking about how to enhance that. Just was curious about your thoughts on, and you started along this path, the sort of pros and cons of professionalizing it versus not. I think there's room for both. I'd say that. The other thing I was curious about was, you had said that this is particularly useful for disenfranchised groups. Have you been able to informally, I know you don't track attendance, get a sense of who's attending demographically, and if you actually are sort of reaching the communities that you're...
I would say the answer to that is no.
Okay,
Yeah.
fair enough. And the last question, and this might be a bit aspirational, but this goes to the point of every county thinks every place is its own place. It's hard enough to sell Philly and Pittsburgh and Philly. I think about selling Brazil and Pennsylvania and America. So just was wondering about I really appreciate your thoughts on how to sort of localize this and make it a more palatable, marketable, and acceptable, because it's a real obstacle to acceptance.
Yeah, it's such an interesting thing. We have such ambivalence about the outside world. We both love it and want it, and at the same time, no, don't bring it anywhere near me. I think what did David ask about the breakfast package that we gave him? He wanted to know if it had scrapple in it. So the answer to your question is, we're trying, like Cal, to figure out how to put the scrapple into ICT for whichever part of the country we're in. And I believe actually Pittsburgh, the word solidarity actually has some meaning, right? I don't think it necessarily has the same context elsewhere. Other places it may be mutual aid. We're gonna have to figure out what the words are to make it work in every place in all the kind of communities without losing its fundamental capacity to help people connect with each other and have an emotional experience that brings people into each other's orbits in a way of solidarity. So, yeah.
I don't really have questions, just sort of comments, which I think echo off what some other people are saying. One, I think just swimming uphill against American culture and American ideals here of individualism. And I think back to my childhood, and somehow I was given the message that growing up and being successful actually meant moving away from my family, moving away from my parents. And, you know, now having lived a lot more of my adult life and become a parent, I've realized how isolating that is and how much you need to kind of work and build that community around you to really be more fulfilled and also just to make it on a day-to-day basis. But it's, you know, I think there is just that struggle against this concept that you should pull yourself up by your bootstraps and you should do it all by yourself and you should just have your little nuclear family. So it'll be kind of an uphill battle in terms of acceptance. The other comment is just about kind of group therapy modalities in general clinically. So I work in a first episode psychosis clinic, and I worked inpatient for many years before this and really had a bias, I think, that people with serious mental illness really couldn't benefit from or participate much in groups. And that we have had a group going for our young adults with first episode psychosis. And for some of them, that has absolutely been the most pivotal intervention, knowing, you know, just that connection, knowing that they're not alone, that the sense of solidarity and community building is so many of the same elements that you presented with an ICT. So I sort of agree that I think group therapy is a very underutilized modality. We also are just starting off with a group of family members for our individuals first episode psychosis, and that I'm really excited to see where that takes off. And I think kind of hits on the same things. Yeah.
It's not a question. I'm just going to take 1 second just to say, like, maybe I'm the only one, but like, I think after COVID, especially, but like humans love to form tribes. I think people are going to form tribes. Just, you know what I mean? You call what you want, but like, whether it's the MAGA tribe or it's like, you know what I mean? The traditional tribes of the hunter gatherer, like we are social animals who are born to like build tribes, and we haven't stopped. This is just another form of tribe. Like, of course it works. That's what humans do.
Right. So now we're trying to do it again. Well, you know, I have to say there's some distance between what you've just said. You know, there's the individualism and there's the group thing. And I think actually, I don't want to boil this down too far, but I think that there's somewhere in that issue, the actual political, social, economic challenge that the United States is dealing with right now is about exactly the context of that connection. Wes.
So, you know, we were talking about training yesterday, and it seems in a lot of ways that that's sort of a rate limiting step in making this happen. And so one of the questions I have is, you know, how important is that structure, you think? And because, you know, as we've been talking about this, it kind of occurs to me that, you know, some of the things you guys have been doing on Thursday night is very similar in some ways. You know, we have the, you know, seminars that we do for our fellowship, which is pretty similar in a lot of ways. I have a book club, which is pretty similar in a lot of ways. And it seems like the, you know, the real common denominator is just kind of making that connection to a group and being able to share, you know, whatever it is that we're thinking about. So I'm just wondering about, you know, your thoughts about that structure.
So there's two challenges that we're facing with this, which relate to what we were just talking about in terms of the culture and what people want and need. The first is to be a facilitator of this actually does take some learning about how to listen and formulate what people say in a way that is, you know, coherent, relatively condensed, and accessible to everybody who's be in a room. And that just takes a lot of work. Related to that is the whole issue about what the role of the facilitator, you know, who mostly are non-professionals, what they're, and actually, to be honest with you, it's harder to train clinicians to do this than it is professionals, because the clinicians go into it with that clinical model. And the first thing that happens is that instead of being a group having a discussion about their feelings with each other, what happens is that the person whose pebble is identified is essentially at the middle of that surgical amphitheater. and everybody's trying to solve that person's problem. And that actually isn't helpful. Solving a person's problem is not helpful in this group. What's helpful is everybody in the room sharing what they experience and how they've overcome it. And it just is the process that's that. So there is a little bit of training to do this specific kind of work. But I think you're right about being in groups and how to help and figure out how to have conversation and have people engage and share, and how to avoid some of the traps, you know, of giving advice or peddling something or whatever it is, so that you can kind of manage that. The second issue is well, I've forgotten what the second issue is, but it's there, and I'll come back to it. Yeah, Marcia.
All right, thank you, Dr. Thompson. I was going to share the same sentiment as Rachel, because I thought the group therapy was a similar experience to the ICT. I got to sit in on that. However, I didn't know it was limited to like about 12 people. So it's interesting to hear those stories. And just on the point made, yes, that, and I have like an international and American experience. So the culture of the American culture with that individualized, I'm going to handle these problems privately, quietly, it is very true. And I thought, as you expand on this, which is wonderful, I remember you introduced it at Squirrel Hill Health Center, is can we share it with existing groups, like what was already mentioned with the first-time psychosis for families, or Alcoholics Anonymous, Narcotics Anonymous, sexual abuse groups, integrated within that of groups that already have this shared purpose and experience. So it might be more easily acceptable to groups that already exist in. I just thought I wanted to share that. Yeah, thanks.
Well, I'll just say that the idea of ICT is to be as diverse as we possibly can, and to have the connection be evolving in that diversity. So that means that we're not looking just to find a narrow group of people who have a particular challenge and try to do the ICT with them. However, having said that, there's no reason you can't. There's no reason you can't, talk about this stuff. And I mentioned the concept of secrets. It turns out that in a group, the secrets that people have vary depending on which group you're in, right? Some groups, secrets like, substance use or, sexual issues or various things you would never talk about. But in some groups, that's the context in which the group exists. And it's not such a big deal to talk about that as an issue. So, so it really is very much context specific as to what the level of the disclosure is. I think the important piece is that we really want to try to make sure that, that in general, we are providing this to a web of people who have some reason to be in connection with each other. The original Brazilian model obviously comes out of the favelas, out of neighborhoods. And I think that that's probably the biggest connection, where people living together. But that's changing a little bit because of Zoom, that we can now think about, the capacity for people to be able to sign in from any place in the world into an ongoing ICT, because they find that there are people there who have experience, even though they're across the world, that may be meaningful and useful to them for their own edification, but also to be part of something, to feel like they have a connection. So we're wide open to all kinds of experimentation with it. Crystal.
So I also got to sit in, and I was one of the ones that Pebbles was chosen. So I found it interesting from someone who used to run support groups for sexual assault victims, domestic violence, and also families of individuals who have their loved ones have mental health and or co-occurring. So what it did for me is that you picked who you were going to hear from. So it wasn't one person who was controlling the group or interrupting others. So it is a controlled, it's a structured conversation, which is nice. The other thing is hearing that people had similar experiences, how they felt about it. No one was asking me how I felt. They were telling me how, interestingly enough, because I went with a problem I was concerned about with work and working on a grant where you're attached to other groups, and then COVID hitting and you no longer see these people. So I don't get invited to the staff meetings. So my connection is gone basically at that time. So similar experiences, and listening to it, it was interesting because someone at the end said, I realized that really my Pebble was a gem. And the next day I woke up and I went, oh, this is an opportunity. I've been looking at this from the wrong side. So it may be a group experience, but individually it was my problem to solve. And what I heard from others helped me make the decisions about what I should do and how it should be framed.
Yeah.
So it's not that you lose your individual.
Yep.
And
Well, and I also want to say, just to come back that, you know, one of the reasons that it's not so critical to go to a specific group with a certain kind of quotes pathology is that it really is open to people without criteria for pathology, right? We want it to be, it's not pathologizing the fact that people have pebbles.
Yeah, I was just gonna, I mean, it's so much of this is sort of, I'm getting into some bean counting operational things, but you showed some of the I mean, I'm thinking sitting here, you know that this works when what? Like the outcomes of this, are those the depression outcomes that you showed us? Are there other meaningful endpoints? I mean, to me, it strikes me intuitively as like, this is a good idea and works, but I'm thinking about the other, I mean, and the other thing I sort of, to your last point, is this really does, and Marianne, we're talking about this, it strikes me more as this is not a mental illness initiative. This is a mental wellness and health. And so this is healthy
living.
Yeah, this is what was
early intervention.
My daughter calls it yoga for the emotions.
Yes. And it weaves natural support. So, you know, that notion that you've got to be individual. We fail miserably in our mental health universe to help families make connections. And this is opportunities for lots of people to make connections and to think broadly and share.
Yeah. Just to answer, Jeff, the question about outcomes, you know, the Brazilians have looked at sort of clinical outcomes in terms of what happens when people use this resource and how does it play out in terms of their use of other resources? How does it play out in terms of their self-satisfaction with participating, those kinds of questions. And they found, you know, that at least from their point of view, that the data says that it's useful. The other thing that they find that's been useful is that they just find people coming to them. People come. They set them up and people come. And so they've been doing this. And I've met, I met Brazilians. There are Brazilians in Pittsburgh. And I run into them now. And I say to them, you know, I'm involved in stuff in Brazil. And they say to me, oh, really? What is it that you're doing? And I say, well, I'm involved in this thing called, you know, integrative community therapy. Actually, it's called Terapia Integrativa Comunitária in Portuguese or something like that. And they say, oh, yeah, I was in one of those. They're great. Like out of the blue, somebody just in Pennsylvania is hanging around telling me that they were in ICT in Brazil. So that tells me that it's got some reach, right? You know, I don't know. I literally, honestly, I have no idea what the value really is that this can bring. Maybe it's a small portion, maybe it's got bigger, I don't know. I just know that that I think it's a bromide to a problem we have in our society, which is that we have gone a little too far in the direction, or we're persisting too long in the direction of the pure individual. I'm going to pull myself up by my bootstraps. I'm not going to rely on anybody for anything ever. I think we maybe have gone to the limit of that. And that's basically what climate change is telling us, that this is, we cannot continue to do what we've been doing and get ourselves out of the problem that we're facing. We just, that's maybe the bottom line. And by the way, you guys have asked so many questions that you've actually gone over the time. And since it was my session, I didn't stop you, which is,
I was going to stop you.
You were going to stop me, good, because that was really unfair to Wes. I made him stop his session. I said, you got to stop it. But of course he didn't, but I made pretend like I did. And now it goes back to still my session, Marianne. I'm going to have less than that. I'm going to say one thing about the lesson of today. Actually, I'm going to say three things. The first, and two of them are from Lauren Roth, so you can credit these to Lauren Roth. Lauren Roth says 90% of success consists in just showing up. And I am just so happy that everybody here showed up. Thank you very much for coming. I'm really pleased, and I found the conversation and the discussions, presentations have been just extraordinarily valuable. The other thing that Lauren says is that everything is just semantics. So it is about talking with each other. It's about doing things, but it's also about talking with each other and learning from each other and sharing ideas. And the last thing I'm going to say, and then this is a provocation to all of you, to say whatever you'd like to say in the minutes you have, is I think we should do this again. I think we should do this again, at least next year. And maybe, I don't want to say this, but maybe sooner, I don't know. We absolutely went through the national agenda today. We talked about the national agenda and how it's going to apply out here in Pennsylvania. And I think that that's really extraordinary, a real opportunity. And we had people from the state here listening to us. We have the power of the room. We've got really great possibilities. And so that's what I've caught to out of today. Do it again and see what we can do to take it further. Anybody else want to share any thoughts about today, how it's been, what the experience was like? Yeah, Lloyd.
Can't end without pointing out the leadership that folks at the PPLC have given us. People have stated and there's no way this happens without that intentional leadership, and we greatly appreciate it. I did have dark hair when we started the process. All right, I didn't have to, but we do need to find ways to get this message out and be more public about it. And this is a good start. This is a direction. And I just can't say enough thanks to the people who so actively participate in making this happen. Thank you, and give yourselves a round.
I am remiss in not having said earlier today when I noted the changes. There are a lot of changes that I mentioned of people going, leaving us, but there's some changes in terms of who's with us and who's leading us. And Lloyd and Val, the two of you, it's just, it's a treat to be able to work with you and to go forward. And, you know, who's David Dinich? I don't even know anymore, right? So we should all recognize Lloyd and Val for getting us to this point, and also to the team that was already mentioned today. Allison did a great job in the morning of talking about the early mornings that you know, this group got up and really pounded away, and the work that Deb did and Mary did making this thing happen, and Lucy. I mean, it's just been extraordinary. So any other comments or things before we just announce that it's the end? All right. Thank you, guys.